Hi students, good afternoon and welcome to this live session. I'm privileged that we are starting with this dermatology session. So I'll just walk you briefly through the process. So we will be studying dermatology for next 2 days. We will be starting our class on both days around this time and we will end around 9:10. So we have these 2 days to cover most of dermatology. This session would be more FMGE oriented, and I would always prefer if you read and come, because you have to understand that in 12 hours I have to teach you whole of dermatology. So if it is just me speaking, it becomes a little difficult to retain that, but you have got annotated and then you'll have the PDF after the class also. So I would suggest that students who have read dermatology and come, so quickly revise it with me. However, for students who have not read and are reading dermatology for the first time, please focus on understanding the concept. You may not be able to remember the whole session after this, but if you go back to the notes, you would be able to revise easily. So for both types of students who have read and not read, this session should be beneficial. Now, just to make it easier for you, I have written that what topics I'm going to cover today and what topics I'm going to cover tomorrow. Now, obviously, we all are studying together for like 6-7 hours, and we do not know कि 4 घंटे बाद हमारी क्या हाल होगा. So थोड़ा सा हम schedule को ऊपर नीचे कर सकते हैं, but I would majorly try to cover these topics for today, which is basics, bacterial, viral and fungal infection, immunobullous disorders, hair and nail disorders of glands, psoriasis and lichen planus. And tomorrow I intend to cover tuberculosis, leprosy, sexually transmitted infection, pigmentary disorders, eczemas, connective tissue, genodermatosis, parasitic infestation, systemic diseases, tumors, drug reactions and some miscellaneous topics. However, in case I finish with my day 1 topics earlier, we might do few topics from the day to today itself, or if I'm not able to finish day 1 today, we'll carry it tomorrow. So let's enjoy learning, don't stress out. I know I'll be giving you a lot of information in this 6 hours, but please remember that this is a session where you will not be able to exactly memorize everything. This is more to help you understand how to memorize and what to memorize. So just be with me, interact with me, chat with me. Also, you're free to put in your queries in the chat box, but since we have a limited time, we'll not spam the chat box. So but keep putting your queries and I will answer them in due course of time. Right? So with that positive note, I hope you have all had your lunch. Keep your water with you. Start writing, start studying, and let's enjoy. I can stop anywhere that you want, but it should be a common group consensus, not a particular individual consensus. And I can also discuss any topic in more detail once we finish with this day 1 and day 2 sessions. So on day 3, we will have a test and discussion. So we would see how much did we learn in these 2 days. So we'll take the test and then there will be a discussion. So on 3rd day, we will have more time to take on with your queries. So if there is any particular topic which you feel कि आपको नई ढंग से समझ आया, थोड़ा सा और elaboration चाहिए, so on 3rd day, we will have more time for that and we can cover it there. Right? So on that note, let me see some thumbs up if you're able to hear me well and see me well. So I'll start my session. Okay, I'll make sure that I talk only in English. I will not talk in Hindi. Okay, so see, this is kind of rapid revision, but since I'm saying I'm focusing on FMGE, so I'll try to cover most of the topics. Now, the difference between rapid revision and main videos is when we give you main videos, we elaborate on each and every content so that you get the concept very well and you understand it very well. Obviously, that is not possible in 12 hours. So I would say that the topics are same. All the important questions which are asked in that topic will be covered in this session. However, my discussion or my elaboration on any topic will be limited. So I will not be able to go into the in-depth understanding of the topic. But yes, I am making sure that I am covering all the important topics and I am covering all the important questions which are asked in the exam. Right? I hope that answers your questions. Okay, and also there is a Telegram channel which will be in the description of this chat box, so you can join that, and all of us educators will be there in that Telegram channel, right? So let's move on with the session now. Okay, so since we are starting with the dermatology, the most important things is basics of dermatology. So what are the important things that you need to know in the basics? So when we start with dermatology or skin, you should know what are the layers of human skin. So layers of human skin are divided broadly into, so this is a super simplified view of a skin. So there is an epidermis followed by dermis, a subcutaneous tissue, and below that is the muscle layer, right? So most of my skin disorders would be concentrated in epidermis, dermis and subcutaneous tissue, right? But this is an oversimplified view, and this is how on histopathology my skin would look like. Now why am I putting this? Because whenever you're given a histopathology image in the question, it would be like this. So don't get confused. I will just come back to this image and tell you what are the layers of the skin, but this is how my skin looks on HNE. Now, so when I talk about the layers of skin, I told you the topmost layer is epidermis and below that is dermis. So dermis and uske upar epidermis. The most important thing that is asked in basics is, what are my layers of epidermis? So layers of epidermis are remembered by a mnemonic, come, let's get sun burnt. If you do not have skin, you will get sunburnt. So remember a mnemonic, come, let's get sunburnt. And now let's remember the layers of epidermis. So my first layer is with C, which is stratum. The next layer is with L, stratum. Lucidum. Next layer is G, stratum granulosum. Then is S, stratum spinosum. And then is the last layer, which is my stratum basale. So the layers of epidermis are divided into 5 layers: corneum, lucidum, granulosum, spinosum and stratum basale. You will be able to remember these layers, don't worry. Just remember the mnemonic, come, let's get sunburnt. Now these layers of epidermis that I have just told you are from top to bottom, right? But remember, my skin is formed from bottom to top, obviously, from here to upper layers, right? So the skin is formed from stratum basale and then goes up to stratum corneum, but I remember my layers from top to bottom, which is, come, let's get sunburned. So this is the mnemonic to remember the layers of epidermis, right? Now, again, so that was the pictorial description, and this is how my layers of epidermis looks on histopathology. So this is the topmost layer, which is stratum corneum, followed by stratum granulosum, followed by stratum spinosum, followed by stratum basale. Now I missed one layer here. Which is that layer I missed? I missed stratum lucidum. Why did I miss that? I will come back to this. So stratum lucidum is a layer which is only present in palms and soles. So you see stratum lucidum only in palms and soles. Easy to remember, like the thickest part of your skin is palms and soles. So my thickest layer is here. So this needs an extra layer of skin, and that extra layer of skin is called as stratum lucidum. So if in the question they ask you what are the layers of epidermis in any other part of the body, you have to exclude stratum lucidum. But if it is in palms and soles, you have to include stratum lucidum, right? Good. So I see that Most of you know about this. So before moving on to the layers of epidermis, quick thing about cell differentiation. I told you that though we have remembered the layers from top to bottom, the skin is formed from stratum basale to stratum corneum. So the lowermost layer, which is stratum basale, is actually the germinative layer from which the upper layers are formed. Now when this happens, when the skin forms from stratum basale to stratum corneum, the cells undergo certain changes. So a cell which is there in stratum basale looks like this, but a cell which is there in stratum corneum is looking like this, because my cell is undergoing differentiation as it moves through different layers of epidermis. Now this differentiation causes certain changes in the cell, which is again very easy to remember if you see this picture. So as the cells move towards stratum corneum, they become flatter, they increase in size, they lose their nuclei, they are dehydrated. That means the cells become dead by the time they reach stratum corneum. So just remember this, the layer cells in the stratum corneum are dead, and from the stratum basale, when they are reaching up to stratum corneum, since they become dead, they undergo these changes. They will not have mitosis, so no nuclei. They get dehydrated, they increase in size as they become flatter. So the question which is asked is that if I have a preterm baby who's a baby who's born preterm, which layer of epidermis will be missing in that? So since the stratum corneum is formed the last, in preterm baby, stratum corneum will be absent. Right? So this is a question which has been asked. So if the child is born prematurely, the topmost layer, which is stratum corneum, will be absent. Right? Got it? Another important thing that you need to know is that my skin is constantly renewing itself. What do I mean by renewing itself? The cell which is formed at stratum basale reaches stratum corneum and then sloughs off from it to the environment. So there is a constant new cells which are being formed and sloughed off in the environment. Right? Now this whole process of forming of cells reaching up to stratum corneum and then sloughing off in the environment is called as epidermal turnover time. Epidermal turnover time is the time taken by my epidermis to turn over itself. Now normally this time is 52 to 75 days. Another question which has been asked. So it can vary, and any value between 52 to 75 days is absolutely okay. Why is this concept again important for you? Because there are conditions like psoriasis, which we will study, in which this epidermal turnover time reduces to 4 days. So something which was getting turned over in 52 to 75 days is now getting turned over in 4 days. So this is important for you. So this is my epidermal turnover time, right? No, stratum corneum will not be absent throughout the life. Obviously, as the child matures, stratum corneum will be formed. Right? Now coming to various layers of the epidermis and their importance. So the first layer I told you was come, let's get sunburned. So C for come, C for corneum. Corneum is basically corneocytes. It is made up of dead keratinocytes. I told you, as the cells differentiate, they lose their nuclei, they lose their tendency to mitosis. So stratum corneum is actually formed by dead keratinocytes, and this is important because if something is dead, it will not be affected by harsh environmental conditions. So this stratum corneum actually forms a barrier in my skin and protects my inner layers of the epidermis and inner layers of the skin. So stratum corneum has a very, very important function, and to cater to that function, the keratinocytes here are totally dead. So they are not affected by pollution, dust, or whatever it's coming on its way, right? So it is made up of dead corneocytes, and the most important function of stratum corneum is that it acts as a barrier to prevent a transmission of external agents into my skin and to protect my inner layers of the epidermis, right? Now, since we are talking about different layers, I will also talk about few histopathological changes which are asked pertaining to that layer. I told you that stratum corneum does not have nuclei, but there are certain pathological conditions and certain physiological conditions where there may be retention of nuclei in the stratum corneum. This term is referred to as parakeratosis. So parakeratosis is retention of nuclei in stratum corneum. So if you do a histopathology and you're seeing nuclei in the stratum corneum, you will describe that finding as parakeratosis. Okay, parakeratosis. Now, parakeratosis can be seen in various conditions. They can be seen in certain physiological conditions, like if you do a histopathology from mouth or vagina. So that is my mucosa. You may see retention of nuclei there. So that's normal. But there are a lot of pathological conditions which are asked in the exam, which leads to parakeratosis. So important ones being psoriasis, eczemas, actinic keratosis, seborrheic keratosis, and sebum. Right? So this you can remember with the help of a mnemonic PEAS2. PEAS2. The most common ones which are asked are psoriasis and actinic keratosis. We will discuss about all these things, but remember that parakeratosis is retention of nuclei and seen in PEAS2 or psoriasis, eczema, actinic keratosis and these conditions, right? Now, if my stratum corneum is overformed, it is called as hyperkeratosis. So, hyper means increased thickness of stratum corneum. So, if I do histopathology and see such a thickened stratum corneum, I refer it to as hyperkeratosis, and this is seen in lichen planus and psoriasis. We will be discussing all these terms in their subsequent lectures. This is just an introductory part, right? So, don't get confused with too many names. So, hyper is increased thickness, para is retention of nuclei, right? Okay. The next layer which I told you already is called as stratum lucidum. Now, here remember lucidum has L in it. So, it is only present in something which has L in it, which is palms and soles, right? It is present in palms and soles. Lucidum means clear. So, this is also called as clear cell layer. Why? If you see on histopathology, they look very clear looking cells, and that is because stratum lucidum has a particular granules which are called as refractile granules of LED, which gives it a clear looking appearance, right? So, only three things you need to remember about lucidum: palms and soles, clear cell layer and refractile granules of LED. So, all of them has L in them. Remember, everything has L in them with lucidum, right? Dr. Shabir, I don't know if I can speak in Hindi. There are a lot of students who can only understand English, right? So, next, coming to next layer, I will try to talk some bit in Hindi maybe, but most of my lecture would be in English. The next layer was come let's get. So, get se tha granulosum. Again, very easy to remember. If it is granulosum, it will have granules in it. So, this is a layer which when you look on histopathology, you see multiple granules here, and this is a thin layer in the epidermis, okay. Now, two important granules that you find in this layer are keratohyalin granules, which are also called as profilagrin. Now, there are a lot of proteins which are there in my epidermis, which are kind of binding my skin together, right? So, this profilagrin helps to bind my keratin together, and this converts into filagrin eventually. This filagrin is seen in stratum corneum, but in stratum granulosum, we find profilagrin. Another question which has been asked. So, filagrin is in stratum corneum, but filagrin के पहले आएगा profilagrin, so वो पहली वाली layer में होगा जो कि stratum granulosum. So, profilagrin or filament aggregating proteins are keratohyalin granules and have a very, very important role in capturing the moisture in the epidermis. So, if there is a defect here, it leads to a condition called as ichthyosis vulgaris. I would sincerely request you all to just understand right now, because I'll be throwing so many terms. If you try to memorize each and everything, you'll get confused. This is the basics lecture. Try to understand. We will be talking about all of this in their separate conditions, right? So just remember that if profilagrin is defective, it leads to a disorder called as ichthyosis vulgaris. The second important granule that you see in this layer is called as odd land bodies, or these are also called as lipid coating granules. Now, lipid coating granules or odd land bodies are something which are providing fat to my skin. So, if it is deficient of, or if it is not working well, I get an eczema which happens because of no fat. So, this is called as steatotic eczema or no fat eczema. So, two granules, keratohyalin granules, if not functioning properly, ichthyosis vulgaris, and odd land bodies, if not functioning properly, I get steatotic eczemas, right? Okay. Now, the pathological changes that you see in stratum granulosum is usually 1 to 2 cell layer thick, but sometimes the thickness is increased, in which time we call it hypergranulosis. So, hyperkeratosis was when stratum corneum was increased. Hypergranulosis is when granular layer is increased. And where do you see this? You see it in lichen planus again. Then sometimes my granular layer may be absolutely absent. I told you epidermal turnover time is reduced in psoriasis. So, psoriasis में differentiation proper होता ही नहीं है, तो granular layer ही नहीं बनती है. So, agranulosis is seen in psoriasis. So, this is my hypergranulosis. You see lot of thickened granular layer, right? So, hypergranulosis lichen planus, agranulosis psoriasis, right? Okay. Now, we will skip this and we will talk about it later. Now, next layer is stratum spinosum. Come, let's get sunburnt. So, S से है spinosum. Now, spinosum means spines, right? So, what are these spines? So, these spines are nothing but intercellular junctions, which are called as desmosomes. Now, desmosomes connect my keratinocytes together. So, if this is my keratinocytes, they are connected together by intercellular junctions which are called as desmosomes. Now, stratum spinosum is my thickest layer of the epidermis. Now, since it is the thickest layer, I see these desmosomes very, very prominently in this layer. Meaning which these desmosomes are present in all layers of the epidermis. They will be connecting my keratinocytes everywhere. But here I am seeing them more prominently, and that is why this layer is called as stratum spinosum or prickle cell layer, and you see majorly desmosomes here, and it is my thickest layer of the epidermis, right? Now, if there is some problem in this layer, what can happen? So, various histopathological changes which can happen with stratum spinosum is there can be something called as spongiosis, which is intercellular edema. So, increased edema in between these cells. So, these are my cells. I see edema all around my cells. Or sometimes you can see intracellular edema or swelling which is inside the cell. This is called as ballooning. Balloon ki tarah फूल गया cell. So, ballooning easy to remember, and spongiosis is intercellular edema. Or sometimes the thickness of stratum corneum, stratum spinosum may be increased, which is called as acanthosis. So, acanthosis is increased thickness of stratum spinosum. Remember this, hyperkeratosis, hypergranulosis, but here the name is different. It is acanthosis, and this is asked. Now, why am I telling you this? Spongiosis and ballooning are feature of acute eczemas, whereas acanthosis is a feature of chronic eczema. So, the question they ask you is, if you do a histopathology of chronic eczema, what do you see? So, you see acanthosis. Or a question that can be asked is, in acute eczemas, what are seen? Spongiosis and ballooning. but these are all changes which are happening in stratum corneum, stratum spinosum. Clear? Okay. Then the last layer is the stratum basal. Come, let's get sunburnt. So, burnt is basal. Now, very easy to remember, it is the basal layer or lowermost layer of the epidermis. This is single cell layer thick, and this is the germinative cell layer from which my epidermis is forming. So, this is my germinative cell layer, right? This is what you need to remember here. Now, there are two changes which can happen here. There can be degeneration of basal cells, that the basal cells are degenerated, again seen with lichen planus. Or you can see something called as acantholysis. Lysis means separation, and acanthosis means, acanthocytes means keratinocytes. So, this separation of keratinocytes is called as acantholysis. This is seen in pemphigus group of disorders. So, again, forget about pemphigus, remember two terms here, acanthosis, which was increased thickness of stratum spinosum, and acantholysis. Lysis is separation of keratinocytes, and this happens in pemphigus group of disorders. Clear? Acanthosis, remember stratum spinosum, right? So, these were my various layers of epidermis. Now, what are these layers made up of? I have made the names to the epidermis, but what are these made up of? These are made up of different cells. So, these layers of epidermis in general are made up of 4 cells, okay? And what are these 4 cells? I have keratinocyte, Langerhans cells, melanocyte and Merkel cell. And if you want to a pictorial description, this is here. So, these all, the maximum cells that you see are keratinocytes. Melanocyte is something which is seen like this. This is pigmented. This is melanocyte. This is my Langerhans cell. And here I have Merkel cell, and overall all these are my keratinocytes. Okay, so keratinocytes, Langerhans cells, melanocyte and Merkel cell are my 4 cells which are important in the epidermis. Now again, what are the important questions related to this? So melanocyte and Merkel cell are both M. They are only present in stratum basal, right? Keratinocyte is my major cell. So, it is present in all layers of epidermis. From top to bottom, all layers are keratinocyte, right? Langerhans cell are only present in stratum spinosum. Lot of questions come on Langerhans cells. So, Langerhans cells are only present in stratum spinosum. So, they will give you an image, a histopath image, mark the basal layer and ask you which cell is not present in the basal layer of the epidermis. So, that would be my, so which cell will not be present in the stratum basal? Tell me. I am waiting for your answers. Wonderful. So, very logical, Langerhans cells. So, this is an important question because Langerhans cells are seen only in stratum spinosum. Good, that means you all are hearing. Good. So, now next question arises, where are these cells derived from? So, keratinocytes are derived from ectoderm. Langerhans cells are derived from mesenchyme. Melanocytes are derived from neural crest. We still do not know very well about Merkel cells' origin, but it is believed that they are probably derived either from ectoderm or neural crest. You can forget about that. Keratinocyte is ectoderm, L is M and M is N. So, L is M, Langerhans cells from mesenchyme, melanocytes from neural crest, right. Major functions. Keratinocytes are forming almost 90% of the epidermis. So, they are important in forming structure of my skin. Langerhans cells are antigen presenting cells. So, they are antigen presenting cells. Melanocytes. What are melanocytes? They are pigment forming cells. They give pigment to the skin. And Merkel cells are slow adapting touch receptors. Okay. So, keratinocyte 90% so forms the structure. Langerhans cells are antigen presenting cell. Melanocyte has melanin, so it is pigment forming cells, and Merkel cell are slow adapting touch receptors. Another question which is asked in this regard is that Langerhans cells, they stain with CD1A, S100 and CD207. So, this is also asked. So, this is all theoretical and you should be knowing about it, right? Now, this finishes my epidermis. So, we studied the layers and we studied the different cells in these layers. After my epidermis finishes, starts my dermis. So, I told you there is epidermis and dermis. But in between this epidermis and dermis, there is a junction which is called as dermoepidermal junction, or it is also called as basement membrane zone. So, dermoepidermal junction or basement membrane zone. It is a very thin structure, but very important. Now, important things that you need to know is that this junction is predominantly formed by type 4 collagen, and this is a very important junction for adhesion and signaling between epidermis and dermis, right? So, though this is a very thin junction on histopathology, it has a very complex structure in itself. So, there are a lot of antigens, there are a lot of things, but I will discuss about them in my lecture on pemphigus, because then there would be a lot of theory. So, you should understand why you need what. So, you should just know now that after epidermis, before the dermis, I have a small junction called as dermoepidermal junction or basement membrane zone, right? And below the zone, I have dermis. Now, for dermis, you just need to know this. Look at this image here. So, if you see this is my epidermis and this hole is my dermis. So, what is dermis harboring? Dermis has all the blood vessels, nerves, hair follicles, oil glands, everything is there in the dermis. So, dermis is an important tissue where you find all the important structures that you see on the skin, right? So, this is my dermis and this small junction is epidermal dermis junction. Now, I told you basement membrane zone was formed by type 4 collagen. Dermis is formed of type 1 and type 3 collagen. This has been asked once, so I am telling you. So, dermis is type 1 and 3 collagen and basement membrane zone is formed of type 4 collagen, right? So, in dermis, you see lot of collagen fibers, you see fibroblasts, you see ground substance like hyaluronic acid, all of this is present. And it also has a touch receptor which is called as Meissner's corpuscles. Merkel is in epidermis, Meissner is in dermis. Meissner has ER which is there in dermis, DER. So, Meissner's in dermis and Merkel in epidermis. This is what you need to know about the dermis. Now, then the skin has appendages. Right now, I am just naming those appendages. So, skin has 3 appendages: hair, nail and gland. So, these are referred to as appendages of the skin and we will talk about them separately. Now, this is how my skin looks like, and now you will be able to identify the layers since you know them. So, the topmost layer is stratum corneum, no nuclei, right? Then this thin layer which is more purplish is the stratum granulosum, and just above that if you see a clear looking cell, that is lucidum, but that is only there in palms and soles. So, corneum, granulosum, and this lowermost single layer is stratum basale. In between का ये जो सारा thick layer है वो सारा stratum spinosum है. एंड उसके नीचे जो हमें फाइबर दिख रहा है ये डर्मिस है. सो डर्मिस के दो पार्ट्स होते हैं. अगर मैं एपिडर्मिस बनाऊं, सो मैं एपिडर्मिस को ऐसे बनाऊंगी. दिस इज ऑल माय एपिडर्मिस एंड इसके नीचे है मेरा सारा डर्मिस. सो डर्मिस का एक पार्ट ये है जो एपिडर्मिस में इन्वेजिनेट कर रहा है, उसके अंदर जा रहा है. सो एपिडर्मिस ऐसे ऐसे जा रही है और डर्मिस उसके अंदर ऐसे ऐसे जा रहा है. तो ये जो जा रहा है इसको हम बोलते हैं, यानी इस पार्ट को हम बोलते हैं पैपिलरी डर्मिस, क्योंकि ये पैपिला की तरह अंदर जा रहा है. एंड द लोअर पार्ट ऑफ द डर्मिस इज कॉल्ड एज रेटिकुलर डर्मिस. रेटिकुलर डर्मिस इज द fibrous dermis. So dermis has two parts, papillary and reticular. Again, just know these terms because they will be used often when we talk about specific disorders, right? Now, moving on to, this was about the basics in skin structure. Now I'll talk about different skin lesions that you should know in dermatology. So I'm sure you would have read about it and it's very easy, but again you should know that skin lesions are divided into three parts: primary skin lesions, secondary and special. So primary क्या होगा? जो first appear करता है. Secondary is what is appearing on primary lesion, कि कुछ primary lesion है मेरा, उसके ऊपर कुछ secondary lesion develop हुआ. एंड स्पेशल लीजन्स क्या होते हैं? विच आर स्पेसिफिक टू अ पर्टिकुलर डिसऑर्डर. यानी अगर हमें ये दिख जाए पेशेंट में, सो वी कैन से ओके द पेशेंट्स डायग्नोसिस इज दिस. सो दीज आर कॉल्ड एज स्पेशल लीजन. सो देयर आर थ्री काइंड्स ऑफ लीजन्स दैट यू सी इन डर्मेटोलॉजी, राइट? सो फर्स्ट ऑफ ऑल वी विल टॉक अबाउट प्राइमरी स्किन लीजन्स. सो व्हाट आर माय प्राइमरी स्किन लीजन्स? एनीबडी? Okay. So one I have already written, but I would want you to give me more answers. Yes, macule. What else is a primary skin lesion? Eczema is a condition. I am not talking about skin conditions right now. We are just talking about lesions. How will we describe our skin conditions? So see, understand, skin is a very, very observatory field. You have to observe, you have to describe and make a diagnosis. सब कुछ लाल दिखेगा, सब में itching होगी, पर फिर हम कैसे differentiate करेंगे कि क्या क्या है? So वो differentiation will only happen if we have a good knowledge of how do we describe our lesions. Good. Yes. Very good. So absolutely right. You all know what are my primary skin lesions. So the first primary skin lesion is macule or a patch. Very easy to remember. This means there is just change in skin color. So macule can neither be depressed, it cannot be raised. You cannot feel a macule. You can only see a macule because macule is just a change in skin color. Right? If macule बड़ा हो जाए तो हम उसे patch कहते हैं. So macule is less than 0.5 centimeter, patch is more than 0.5 centimeter, but both of them just means change in skin color. So vitiligo के patient में when you see these white patches, these are macules. The freckles that you see on patient's face, they are macules. You cannot feel a macule. Remember this. Macule cannot be felt. It can only be seen because it is just a change in skin color. What if you feel the lesion? So when you see a lesion and if you can feel it, that means the lesion is solid, elevated, circumscribed lesion. So it can be either a papule, plaque or a nodule. What is the difference between all of them? Papule is less than 0.5 centimeter. Plaque is more than 0.5 centimeter. Right? So if you can see a lesion and feel it and it is solid, it is not fluid filled, it is not pus filled. So it is solid, you call it a papule or a plaque. Papule less than 0.5, plaque more than 0.5. Then what is a nodule? Now sometimes what will happen, if you try to feel a lesion, you would feel that that lesion has more depth than height. कभी कभी आप फील करोगे तो आपको लगेगा ये लीजन नीचे बहुत ज़्यादा जा रहा है, ऊपर तो मुझे बहुत थोड़ा सा महसूस हो रहा है. उसको हम बोलते हैं नोड्यूल. सो नोड्यूल हैज़ मोर डेप्थ देन हाइट. Okay, so these are all my circumscribed solid elevated lesions. We'll call them papule, plaque or nodule. Let me show you some examples. So what is this? The first thing is a raised lesion, solid raised lesion. This is my papule. This is also raised, circumscribed, but this is more than 0.5. So this is a plaque. And now see this. जब कभी आपको यहाँ पे कुछ दाना होता है और वो अंदर बहुत फील हो रहा है, but surface पे मुझे थोड़ा सा दिख रहा है, this we call as nodule. So papule, plaques and nodules, these are also my primary skin lesion, right? Now next is vesicles and bullae. अब क्या हुआ, एक हमने देख लिया कि कलर चेंज है, एक हमने देख लिया कि सॉलिड है, पर अगर फ्लूइड फिल्ड होगा तो क्या कहेंगे, तब हम उन्हें कहेंगे vesicles and bulla. So if my lesions are fluid filled, I call them vesicle and bulla. Vesicle is less than 0.5 centimeter, bulla is more than 0.5. So सबका less than 0.5 और more than 0.5 है हमारे पास. So fluid filled lesions we will describe as vesicles and bulla. This is very important students because आगे whatever dermatosis I am going to teach you, I am going to use these terms. तो ये समझ लो, नहीं समझ आए तो पूछ लो, right? Yes, you see it in chickenpox. Very good. You see it in herpes. So this is a bulla, this is a vesicle. Okay, clear? Then what if it is pus filled? If it is pus filled, I call it a pustule. So pus filled lesions are called as pustule. Now remember, this was a question once. Pustule is a lesion which can be both primary and even secondary. Now what happens if you have a vesicle or a bulla and it gets infected? तो अगर वो infect होगा तो उसके अंदर pus आ जाएगी. But that will be a secondary change because it's happening on a primary lesion. So pustule can be both primary or secondary. So pustules can be primary. Primarily a patient can present just with pustules. Okay, and sometimes when there is a collection of pus like this, I call it an abscess. So pus filled lesions are pustule and collection of pus is called as abscess, right? Cyst versus bulla. Okay, so bulla are fluid filled lesions. Cyst is an enclosed cavity. It has a lining in it, right? Bulla will not have a lining. And cyst again, you would feel more than you see on the top. And there is a lining to it and there is an enclosed cavity which is filled with fluid. Whereas bulla is in the layers of the epidermis, there is no enclosed cavity. Okay? Then sometimes there is extravasation of RBCs in the skin which can happen. So you see these red spots, they are called as petechiae, purpurae and ecchymosis. So these small ones, I call them petechiae. If they are a little larger, I call them purpura. And अगर बहुत बड़ा है ऐसे, so हम इसको बोलेंगे ecchymosis. There is no size differentiation in pustule. Abscess and pustule is, abscess is whenever there is a big collection of pus, we call it an abscess which can be drained. Pustules are small, okay, but there is no size criteria. Don't get confused. So extravasation of RBCs, when you have this, now extravasation of RBCs will lead to presentation of these red lesions. So these are called as petechiae, purpura and ecchymosis, and these are also primary skin lesions, right? Now coming to secondary skin lesions. Secondary skin lesions are lesions which are formed on primary lesions. So let's look at, so any idea what can be these? Can you give me an idea of what are my secondary skin lesions? Can pustule be primary and secondary in same? Very unlikely to be in the same, because if you have primary pustule, yes, it can get secondarily infected and you can have secondary pustule also, but again not so common. Yes, so you are all right. Scales, crusts, ulcers, these are my secondary skin lesions, because when you see a scale, scale कहाँ form होगा? Scale तो किसी plaque पे ही form होगा या किसी चीज़ पे तो form होगा ना? So that's my scale. So what is a scale? Scale is nothing but a visible exfoliation of stratum corneum. Now, depending on the type of scale, there are different disorders which we can diagnose, and this is asked to you in the exam ki scale dete hain, match it with the correct diagnosis. So let's learn some of these scales which are commonly asked. We'll again talk about them when we talk about specific dermatosis. So if my scales are silvery white, now you tell me what would be a diagnosis. I'm just writing the scales that I'm seeing and you will tell me the diagnosis. If the scales are greasy, if my scales are fish-like, if I see a collarette of scales and if I see fine brany scales. Okay, very good. So, silvery white scales is a characteristic feature of psoriasis. If in your exam they mention silvery white scales, don't think about anything, mark psoriasis. Very good. Lichen planus has no scaling. Somebody gave me lichen planus as the answer. Then very good. Greasy scales is seen in seborrheic dermatitis. Seborrheic dermatitis. Very good. Good job. Fish-like Ichthyosis vulgaris. Where else did we study Ichthyosis vulgaris? I told you profilagrin defect leads to Ichthyosis vulgaris. So IV के बारे में हमने already दो चीजें पढ़ ली. And fish-like scales. Collarette of scales is seen in Pitriasis rosea. So again, please, if you have not studied, don't get parishan mat hona. This all we will talk later. Fine brany scales is seen in Pitriasis versicolor. Right? So this is just to tell you that they ask you this scale and the lesion. So I'm just putting together most of these scales which are asked to you. The next secondary skin lesion is called as crust. Crust is nothing but dried up exudate. जब आपको चोट लगती है, कहीं से पस निकलता है, जो पपड़ी जमती है उसको हम crust बोलते हैं. So it's a dried up exudate, and again different types of crust can be seen in certain conditions. Like this is a case of impetigo, which I'll discuss in few minutes. Okay. Then quickly now moving on, this you have studied in, this you will study in surgery. Next you have erosions, ulcers and fissures. So erosions or ulcers, what is the difference? Erosions are something where you see denudation of epidermis, but it is very, very superficial, right? Whereas in ulcers, you see this denudation of skin and it is going deep. So this is an erosion, but this is an ulcer. So in ulcer, the denudation of skin is going up to deep in the epidermis, deep in the dermis, not epidermis. And here it is very superficial dermis. So if my skin is getting eroded superficially, I call it erosion. If there is an ulcer, ulcer would have a proper base, it will have a proper margins, erosions will not have that. And fissures are nothing but linear cracks in skin. So कभी कभी जब आपके पैर फट जाते हैं सर्दियों में तो वो fissures होते हैं. So fissures are linear cracks, erosions are superficial, ulcer is deep, which is extending deep into the dermis and can even go up to the subcutaneous tissue, right? Okay. Anybody who can tell me what is this? This is very commonly asked and that's why I've put it here. What is this an image of? And what will you see on histopathology? What is this? Okay, I will describe the features here. What do you see here? You see increased pigmentation of skin. You see increase in skin markings. And you see increased thickness of skin. तो आप बेसिकली प्री मेडिकल टेस्ट दे रहे हो PMT. PMT is a feature of, absolutely right everyone. So this is lichenification. Now this is something which is commonly asked. One of the secondary lesion is lichenification. Now sometimes if my chronic eczema patient scratches too much, the skin becomes like this. And what are the changes that you see in lichenification? PMT. Pigmentation, markings and thickness of skin, that happens, and this manifestation is called as lichenification, and this is seen in chronic eczema. So अगर chronic eczema में ये दिख रहा है तो histopath में हमें क्या दिखेगा? Let's see कुछ याद हुआ है कि नहीं? What do you see on histopath if this is seen in chronic eczema? अच्छा ये भी बता दो कि किस लेयर में चेंज दिखेगा? Very good, Dr. Sheikh. So, on histopathology, you would see acanthosis. I told you acanthosis is increased thickness of stratum corneum. Yes, you're right. You will see also hyperkeratosis here. You can also see hyperkeratosis here. But the question that the examiners want to ask you is this. So, lichenification is associated with PMT. It is a manifestation of chronic eczema. So, you see acanthosis here, which is very, very specific, right? Clear? So, I'll move on. Now, special lesions, we'll discuss in each disorder. This is just to give you an idea what I mean by special lesions. So, special lesions are lesions which are seen only in a particular dermatosis. So, here what is this? This is a burrow which I see in a condition which I call as scabies. So, burrow would be my special lesion because ये और किसी disorder में नहीं दिखता. तो अगर आपको burrow दिख रहा है, you can straight away say that the diagnosis here is scabies. What are these? These are my comedones. Comedones are a feature of acne. I'll discuss them in detail when I talk about these disorders. Then a very, very important question which is asked, target lesions. Target lesions, this was asked in yesterday's FMGE exam also, are seen with erythema multiforme. So, this is just to give you a brief idea that what do I mean by special lesion. So, if you see the target lesion, you can straight away say, okay, the diagnosis is erythema multiforme. So, before finishing the basics, another important question is lines in dermatology. There are two lines in dermatology that you should be able to identify and know the difference of. So, lines in dermatology, you should know there are two major lines for you. One is Blaschko's lines and the second is Langer's lines. Now, why I have put this image? Because this is what is asked. They give you the image and they ask you what kind of line is seen here. Now, remember Blaschko's has S in the center. So, all its lines are S-shaped. And what is the shape of S? It's all curvy. So, curvy S-shaped lines, if you see, like if you see this image, you're seeing all curves, curvy S-shaped lines, these are Blaschko's lines. So, when you look at the image, look for this. So, if you see this, this is Blaschko's lines. Langer's lines are more geometric. They are like this. They are like this, they are like this. So, you do not see curves here. So, Langer's lines are more straight, L for Langer, L for lines. Okay, so they are actually lines. Blaschko's has S, so S is curvy shaped lines, right? We will discuss about that later, right? How can we get you a better PPT? But I hope in the class it's quite clear whatever I'm writing and discussing. Yeah, great. So, now the difference between Blaschko's and Langer's line, which you should know, Blaschko's lines are lines of embryonic development. When your skin is forming, the way that they are developed, lines of embryonic development, they are called as Blaschko's lines. So, Blaschko's lines has S, which means S shape, and it has C, which means these lines are constant. They do not change and they have a strict midline demarcation, right? On the other hand, Langer's line has anger. Anger is never constant. Anger aata hai aur chala jata hai. So, this is not constant. What is Langer's lines? Langer's lines are basically orientation of collagen and muscle fibers in my skin. Now, as we know, with age, collagen and muscle changes. So, these lines cannot be constant. They will keep changing. Why are these lines important? They help us in giving incisions. So, if I have Langer's line which is like this, and if I place my incision like this, my healing will be better. However, if my Langer's line is like this and I am placing my incision like this, it would lead to much more damage of collagen and muscle bundles. So, when I am giving a surgical incision, I follow my Langer's lines, and these lines are also called as relaxed skin tension lines. Relaxed skin tension lines or RSTLs. Remember this. Okay, so Langer's lines and Blaschko's lines. Okay, another important thing that is asked and you should be knowing about is Wood's lamp. Now, there are a lot of things. I told you dermatology is more about observation, but you need certain tools. Like I have always my magnifying glass with me. Another tool which is useful in dermatology is called a Wood's lamp. So you should know about Wood's lamp because I'll be talking in various dermatoses that we use Wood's lamp for this. So what is a Wood's lamp? It is a low output mercury lamp, and it has a filter in it which is called as Wood's filter, which is made up of barium silicate and 9% nickel oxide. This Wood's lamp, when you put on a patient, it emits light in the wavelength of 320 to 450 nanometer with a peak at 365 nanometer. Right? So this is something you should know, that Wood's filter क्या होता है, barium silicate and 9% nickel oxide, और इसकी peak wavelength 365 nanometer पे होती है, right? So then what happens, there are certain disorders which will fluoresce when you put Wood's lamp. So इस तरीके से fluorescence दिखता है इसमें. So कौन से color का fluorescence दिख रहा है और what color of fluorescence is seen, what type of fluorescence is seen will help me make a diagnosis of those conditions. So we should just know right now that there is a tool called a Wood lamp with a peak wavelength at 365 nanometer, right? Okay, the another tool that I use is called as dioscopy. What is dioscopy? I just told you about extravasation of RBCs which leads to petechiae and purpura formation. Now, lot of times I see erythema on the skin or redness on the skin. Now, I have to differentiate whether that erythema is due to vasodilatation, if there is an increased blood flow in the skin and that is giving rise to redness, or there is actual extravasation of RBCs. So I do a test which is called as dioscopy. So dioscopy, what do? I take a glass slide and press it on the skin. So if I press it on the skin and my skin blanches, it is called as erythema. And erythema happens because of vasodilatation. Okay, so if there is blanching, because if it is only due to increased blood flow, once you press dioscopy, वो सारा blood periphery में चल जाएगा, तो there will be blanching effect or white effect. So this is called as erythema. However, if I do a dioscopy and I do not see any blanching, that means it is due to extravasation of RBCs, and so this can be my petechiae, purpura or ecchymosis. So petechiae and purpura are, I call them as non-blanchable, whereas here it is blanchable. So blanchable means dioscopy mein if you blanch, it blanches. If it doesn't blanches, I call it non-blanchable. Clear? Then we use various smears in dermatology. I will not talk about them in detail. You will study about them in microbiology. Now we will move on to specific disorders, and first we will cover few infections like viral, bacterial and fungal infections, right? So once basic, can you give a glance overall once again? So don't worry, when whatever I have taught you till now, some part of it was theoretical, but whatever you need detail about, I will be talking about them in each subsequent lectures. So you do not have to worry about that. We will come to Nikolsky sign and everything, right? So now we will be talking about separate disorders. So I have not discussed signs in dermatology here because I will discuss it with specific disorders so that you understand it well, right? So now I will start with infections, and the first viral infection that we need to study is molluscum contagiosum. So a question again which is asked, so this is an important topic. Molluscum contagiosum, as the name suggests, is caused by molluscum contagiosum virus. So the virus name is molluscum contagiosum and it belongs to the family of molluscipox. So again, the family and everything you will study in microbiology. Now this molluscum contagiosum virus is the largest known DNA virus. It's the largest known DNA virus. Okay. Now, amazing. So Dr. Kuvar, you are right. In dioscopy is used for apple jelly nodules, but not in pemphigus vulgaris. In apple jelly nodules can be seen in granulomatous disorders like lupus vulgaris. Okay, I will talk about it. So see, I do not want to give you a lot of information in the beginning when you do not know what is lupus vulgaris, what is pemphigus vulgaris. Right now, I have just told you the various terms that I'll be using subsequently, right? But you're right, apple jelly nodules, but not in pemphigus, in lupus vulgaris. Very good. That's okay. So, absolutely right, you all are. So, I would like that. Keep telling me what you know about the topic so that I know what you know and I can stress upon that. So, molluscum contagiosum is the largest known, MCV is the largest known DNA virus, and it causes a viral condition called as molluscum contagiosum. So, what is a molluscum? Molluscum is exactly this. So, these are nothing but asymptomatic and very important umbilicated papules. So, if you see such, what do I mean by umbilicated? So, if you see a lesion, आपको center में एक del या depression दिखेगा. So, these are umbilicated papule, and that is the giveaway point for molluscum contagiosum. So, if a patient is presenting with umbilicated lesions on face, think of molluscum contagiosum, and these are totally asymptomatic, can be seen anywhere on the body, but face is a very common site, and that's why I've put face. Children have them very commonly, and that's why I've put a child's face. So, form some visual memory. So, it's more common in children and it is seen in face. Now, since it's a viral infection, you also see a family history. It can be transmitted from one patient to another. So, family history is usually present. Okay. Now, an important phenomena that you see here is called as pseudo-Koebner's phenomena. Now, what is pseudo-Koebner's phenomena? I'll talk about Koebner's phenomena. Koebner's phenomena is, suppose I have a lesion here. Suppose I am a patient of psoriasis and I scratch my skin. I get lesions which are similar to psoriasis on my hand. So, wherever I am scratching, I am getting lesions of similar morphology as I have on other parts of the body. So, अगर मुझे psoriasis है और मैं scratch कर रही हूँ तो वहाँ पे मुझे psoriasis के lesions हुए. अगर vitiligo है और मैं scratch कर रही हूँ तो वहाँ vitiligo के lesions हुए. So, that is called as Koebner's phenomena. But molluscum contagiosum shows pseudo-Koebner's phenomena. What do you mean by that? That in pseudo-Koebner's, here, there, when you scratch, you see lesions on the lines, but this is happening because the virus itself is auto-inoculating itself, right? In psoriasis, vitiligo, it's happening as a pathogenic phenomena. Here, it is happening because of seeding of microorganisms, and this is called as pseudo-Koebner's. So, pseudo-Koebner's is a feature that you see with molluscum contagiosum and also with warts. A very important question. Pseudo-Koebner's phenomena is seen with molluscum contagiosum and warts, right? Now, molluscum is usually a clinical diagnosis, but if I take one papule and see it under histopathology, this is what I see. So, I see lot of eosinophilic inclusion bodies. I see these bodies. So, these are nothing but my molluscum contagiosum virus which is present. These bodies are called as Henderson-Peterson bodies or HP bodies. So, these HP bodies are also a feature of molluscum contagiosum. So, quickly revising, caused by MCV, has umbilicated papules predominantly on face, shows pseudo-Koebner's phenomena, and has Henderson-Peterson bodies on histopathology. These are 5 main points that you need to remember for molluscum contagiosum, right? How do you treat molluscum contagiosum? Rarely asked. So, I'll just quickly touch upon it. It can be self-limiting also. Remember this. So, if I have a very, very small child who has molluscum, I'll just leave it, because lot of times body's own immune system will identify the virus and it will be chucked out of the body. So, good part is it is not affecting any internal organ. It is only localized to my skin, predominantly in the epidermis, right? But if cannot be taken out, then you have to extract it out or use some chemical methods, like you can use TCA application. Remember, with molluscum and warts, So with molluscum contagiosum and warts, two things are common. Multiple things are common. They are both viral infection. They both show pseudocombners, and there is no effective oral treatment for them. So there is no effective oral treatment that I give you a medicine and it can be taken out. So you have to remove these lesions. So removal can happen by chemical methods. I can use some acids to destroy the virus, or I can remove it physically using electrocautery, radio frequency, lasers, or something like that. So you have to either chemically or physically destroy them. This is true for both molluscum and warts. However, sometimes you have to give certain oral medications to boost up the immune response of the patient, or if I have a patient who is HIV positive with extensive molluscum I cannot remove, then I give certain agents which act as immunomodulators. So two agents which I used here are levamisole and cimetidine, right? But more commonly you will be given a clinical picture. Okay. So this is, I showed you HP bodies. So these all intracytoplasmic eosinophilic big bodies that you are seeing are HP bodies, right? So this is molluscum. Now I told you MCV comes under the category of mollusky pox virus. There are two other pox viruses which you should briefly know. One is ORF virus, which causes something which I call as ecthyma contagiosum. These are both zoonotic infections. So what do you mean by zoonotic infections? Which is transmitted by animals. So in patients who rear sheep, on exposed parts, you can see something like this, which is called as ecthyma contagiosum. So you have a plaque with central crusting. So just remember ecthyma contagiosum seen with ORF virus and seen with sheep. Then patient who milk cows or are rearing cows develop a condition which looks similar to this, but it is called as milker's nodule. So easy to remember, milker's nodule will have in patients who have cows, and ecthyma contagiosum or EC happens in patients who have sheep. Here the virus is called as pseudopox virus. Pseudopox virus, right? So these are two other pox virus infection that you should just keep in your mind. The more important viral infection, which is again very commonly asked, is human papilloma virus infection, which causes something called as warts, which I have been referring again and again. So warts are caused by HPV or human papilloma virus. Now this HPV virus has more than 200 subtypes. बहुत सारे subtypes हैं, and I don't know why, but examiners are very fond of asking you subtypes of HPV virus. So I have enumerated few subtypes which are very commonly asked, and we will try to remember them. So important HPV subtypes that you should know can be remembered with the help of mnemonic DSP, come eat a burger. DSP, come eat a burger. Now, how do I remember this? So these are HPV types, HPV 1, 2, 3, 4, 5, 6, 7. So I have written till 7, okay? And what kind of warts do they cause? Is remembered by a mnemonic DSP, come eat a burger. So from D is deep plantar, S is superficial plantar, P is plain warts, C is common warts, E is EDV, A is anogenital, and B is butcher's wart. So 1 to 7 you will write, and the warts that they cause can be remembered by this mnemonic. Out of this, if you ask me, the most important ones are this and anogenital. So verruca plana or plain warts are caused by HPV subtype 3 and also by 10. Common warts or verruca vulgaris is caused by HPV type 4, also caused by 2 and 27. And anogenital warts are caused by HPV type 6 and 11 and also by 16, 18, 31. Now when I am talking about anogenital warts Anogenital warts are caused by two kinds of HPV subtype. EDV will come to. This is just to help you remember what are these. So, anogenital warts can be low risk or high risk. Remember, HPV is a DNA virus which is also having oncogenic potential. So, this has oncogenic potential, but there are not all subtypes which are oncogenic. There are certain high risk HPV types which can lead to oncogenic potential, right? So, these are usually responsible for anogenital warts. So, anogenital warts, if caused by low risk HPV types, they are usually by 6 and 11, and high risk HPV types are 16, 18, 31, 33, 45. So, if I have a patient of anogenital warts and I do genotyping and I find these strains of HPV, then I have to counsel the patient that there are high risk of oncogenicity, whereas if it is caused by low risk, I'm content. Right. So, this is another thing that you should be knowing about HPV, that it has oncogenic potential, right? Yes, and that is why we have lots of vaccines now for HPV. Okay. So, now this was just to memorize. Now, I told you there are few which are commonly asked. So, how do warts look like? So, common warts, which was DSP cum. So, it was 4th. So, 4, 2 and 27 are the strains which cause my common warts, is also called as verruca vulgaris. Now, warts is called as verruca. Vulgaris means common. So, I will use this term vulgaris very often. So, the commonest subtype of any disorder is referred to as vulgaris, right? So, the commonest form of warts are called as verruca vulgaris and are caused by 4, 2 and 27. They present with this raised. So, verruca, whenever I am saying the word verruca, it means something which is raised and hyperkeratotic. Hyperkeratotic. So, मतलब ऐसे दिखेगा निशान, raised होगा और hyperkeratotic होगा, उसके surface पे verrucous surface होगा, right? So, these are common warts, can be seen anywhere on the body, and as I explained with molluscum, you see pseudomonas. So, if you have a patient with verruca vulgaris, you would see sometimes that एक line में, in one line, you see lot of warts. So, this is pseudomonas that the patient may have scratched there and led to seeding of organism along that line. Clear? So, this is verruca vulgaris caused by 4, 2 and 27. Then the next kind of wart are called as plain warts, DSP, P for plain. So, this is caused by DSP is my HPV subtype 3, also caused by 10. Now, plain warts are referred to as verruca plana. Warts is verruca and plain is plana. Why do I call them verruca plana or plain warts? I just told you warts have a verrucous surface. Now, this kind of wart has a smooth surface. So, this is plain topped. It does not have a verrucous surface. So, this kind of wart is very, very commonly seen on face and is very commonly seen in patients who are HIV positive or immunocompromised. So, you get a question like a patient on chemotherapy develops this kind of lesions on face. What is the diagnosis? So, face immunocompromised, and when you look at these lesions, so compare it with this lesion. So, this is all raised and verrucous. This is more flat. So, you see hyperpigmented, slightly raised lesions, but they are much more flatter than what I saw with verruca vulgaris. So, these are my plain warts or verruca plana, which is caused by 3 and 10, seen on face, seen in patients who are immunocompromised, right? Are you guys there with me? The next important type, so somebody asked me about EDV. EDV is epidermodysplasia verruciformis, not important for you, so I am not discussing that right now. Okay. What looks like skin tag? Yes, good. So, skin tag, yes. So, you are right. Sometimes you may confuse verruca vulgaris with skin tag, but remember skin tag is always very soft, whereas verruca vulgaris will be more rough and will have more hyperkeratotic surface, right? Now, Coming to the next important warts that you should be knowing, they are anogenital warts. Now remember, anogenital warts are usually sexually transmitted, so they come under the category of STIs or sexually transmitted infection. These warts are also called as condyloma acuminata, and this is what you should be knowing, because they give you this image and they give options not as anogenital warts but as condyloma acuminata. Condyloma means broad based, acuminata means pointed. Okay, so on the anogenital area, you see that these lesions are more broad based and have a pointed base. So these are anogenital warts and they are a type of STIs, and they can be caused by both high risk and low risk HPV types. So low risk is 6 and 18, high risk is 16 and low risk is 6 and high risk is 16 and 18, 6 and 11. Okay, now remember, what's molluscum? They're totally asymptomatic, no pain, nothing. So all these lesions are totally asymptomatic. So lot of times patient will ignore the lesions and these lesions keep multiplying, and then they will come to you, right? So anogenital warts are asked, they are given to you as question, and they ask you what is it also called as. Condyloma acuminata. Now on histopathology, though not asked, but you should just know, if you look at these lesions, like in molluscum we saw Henderson-Peterson bodies. Here you see modified keratinocytes. This HPV goes and modifies the keratinocytes, and you see these clear looking cells which have a perinuclear halo. These are called as coelocytes, and these are another feature that are associated with HPV, that you see coelocytes on histopathology. Okay. Treatment, again, I do not have a very effective oral treatment, so I use all kinds of chemical and physical treatments that I have. So the long list is telling me that I do not have one proper treatment. Now what are the important treatment options that you should be knowing here? That you use different treatments like TCA, you can use salicylic acid here. But the common ones that they ask you is, if I have a pregnant patient and that pregnant patient has what? So what is the safest treatment that I will do? This is a question for you guys. You have to tell me. So if you have a pregnant patient with warts, what is the safest treatment options for that patient? Very good. You use cryotherapy. Cryotherapy is you take liquid nitrogen gas and you freeze the warts. So that is preferred in pregnancy, and also you can do lasers. You can also do TCA, but the best option would be cryotherapy. You do not use 5-fluorouracil in pregnancy, right? Remember that. So cryotherapy, laser and even TCA can be used. So if none of them, if either of them is there, mark that. If all of them are there, mark cryotherapy, right? But otherwise you can use various methods. Now another important thing that you should be knowing, there are two drugs which are also used for verruca, just know their names, which are podophyllin and imiquimod. Podophyllin and imiquimod are two drugs which are also used for warts. Clear? Coming to the next viral infections, which is my HSV or herpes simplex virus infection. Okay. Anogenital warts treatment. So if you have an anogenital warts, usually they'll give you for diagnosis. But if you have to treat, again, you can use TCA, you can use podophyllin, you can use imiquimod. In fact, podophyllin and imiquimod are, podophyllin is the drug which is majorly used to treat anogenital warts. Imiquimod can be used anywhere, also used for genital area, but podophyllin is very commonly used for anogenital warts. Okay. Now coming to the next virus, which is my herpes simplex virus or HSV. Herpes simplex virus or HSV. Now this has two subtypes, thankfully not more than 200 subtypes, 1 and 2. Now HSV1 is known to cause herpes infections above the waist, and HSV2 is known to cause infections below the waist. So my anogenital herpes or herpes genitalis is more commonly caused by HSV2, whereas above the waist, that is the lesions that I see on face, herpes labialis and all, is more commonly caused by HSV1. So there are two subtypes. Another important thing that you should be knowing about HSV is that it has a tendency to be latent. What do I mean by latent? Sorry. So what do you mean by latent? Latent means once this virus infects a person, it is going to stay in that body forever, right? So these viruses, once they infect, they go and settle down in the dorsal root ganglion and they become latent there, and they have a tendency to come back anytime whenever the patient's immune system is compromised, the patient is pregnant, or anything physiological or pathological immunocompromised state, these lesions can come back. So HSV causes a primary lesion when it happens for the first time. It can cause recurrent lesions because these lesions can happen again and again, and they can lie latent. And the importance of latency is also that if someone has HSV and it is latent, suppose the patient has herpes genitalis and this virus will be latent, even in the latency phase, the patient can transmit the virus to his or her partner, right? So HSV, this is an important feature about HSV. Okay. Now, so the different herpes infections, herpes simplex virus can cause different infections depending on what body area it is affecting. So if it is affecting my oral mucosa or buccal mucosa, I call it herpetic gingivostomatitis, gingiva and stomatitis. This is the most common cause of gingivostomatitis in children. The patient with herpes always has pain. I told you molluscum and warts was painless. Now this is a type of virus which causes lot of pain. So you have painful vesicles and erosions here. So the classical thing about any HSV infection is that it presents with vesicles and erosions. And these vesicles are usually grouped vesicles and the erosions are coalescing erosions. I am going to use these terms very often with herpes, so please remember this. So what do I mean by this? So when you see vesicles in herpes, they are grouped. They are like this. You see small vesicles. And then these vesicles will rupture and form erosions. So when you see the erosions, they are like this. They are like this. So you see coalescing erosions and grouped vesicles with HSV, right? Now when this is happening in the gingiva, I call it herpetic gingivostomatitis. So patient has painful vesicles and erosions, along with there may be fever, there may be lymphadenopathy. So herpetic gingivostomatitis is usually the primary HSV infection. Then when first time HSV infects the oral mucosa, it leads to herpetic gingivostomatitis. So there is lot of painful vesicles, erosions, fever and lymphadenopathy. Okay. But as I told you, this virus has a tendency to be latent. So then it might get latent in the dorsal root ganglion and then later present with something which is called as herpes labialis, a question which is very commonly asked. So herpes labialis is nothing but HSV which is affecting the vermilion border of lip. Here the HSV virus gets latent in the trigeminal ganglion because here the nerve root is trigeminal ganglion, so it gets latent there. Now, it is not essential that every time patient will have herpetic gingivostomatitis and then develop labialis. The patient can directly have labialis and infection here also. Okay. So, remember herpes labialis presents with vesicles and erosions which are present on vermilion border of lips. And it is a very recurring condition. It's a very recurring condition. Patient has fever, कुछ भी होता है यहाँ पे दाने निकल जाएंगे. So this is also called as cold sore. Cold sore or herpes labialis is same thing. It can get aggravated by menstrual cycles, fever and anything, right? Pain, yes, it's a good question. pain may be there, which sorry, I just missed few of the questions. So, is podophyllin a superficial cream? Podophyllin resin is a cream, but in India we have something called as podophyllin toxin, which is available as a paint or a solution. Why problem with teratogenicity if it is a cream? Okay, I think you're talking about 5-FU. So, even creams get absorbed, and if they're teratogenic, they cannot be used in pregnancy. And pain. Now, next question is, if herpes labialis causes pain? Yes, it may cause pain, but it is not as painful as herpetic gingivostomatitis. So, most often patient presents more with discomfort and irritation. Now, remember this, kids, students, that whenever HSV affects primarily, when it is causing the first infection, that is very troublesome. Lot of pain, lymphadenopathy, fever, systemic features. But once it gets latent, the body also mounts an immune response. So these secondary or recurrent infections are usually less symptomatic. So whenever a patient has an episode of recurrent herpes genitalis or recurrent herpes labialis, it's less symptomatic, not much painful, and also settles down early. Right. So, more often patient presents with discomfort and irritation. So, they will give you this image, they can give you history that there was a fever, menstrual cycles or whatever, and then the patient developed this vesicular lesions on the vermilion border of the lip. This is the vermilion border where it is touching the skin. You develop these vesicles there, right. So, this is herpes labialis. Genital herpes I will be talking about in our class on STD, so I will not talk here, but this is how it looks like. Then it can also be seen in healthcare workers, so people who are anatomists or pathologists who are working with biopsy samples. So there may be inoculation of HSV virus on fingertips, in which case I call it herpetic whitlow. Herpetic whitlow is seen in healthcare workers on fingertips. See the characteristic thing that I told you. You see these coalescing erosions and vesicles. This is very, very typical of HSV, and this is how you identify this condition. Labialis is not usually seen as a drug reaction. No, if it is due to drug reaction, I would rather label it as fixed drug eruption. Okay, good. What am I showing here? This is such an important question, has been asked multiple times. What am I showing here? Yes, obviously I am talking about HSV. So, this is a Zank smear of HSV. But what are the features that you see here? Good. So, you are right. This is a Zank smear. Zank smear is a smear which is in which what you do is you make Zank smear. I'll quickly revise, though you'll study in microbiology. Whenever a patient has a vesicle or a bulla, you rupture the vesicle and bulla, and from the base of the vesicle or bulla, you scrape the base with the blunt end of the scalpel, and you smear it on the slide, and then you stain it with Giemsa stain. Then you stain it. Sorry. And you stain it with Giemsa stain. That is called a Zank smear. Now, Zank smear is done for two main conditions in dermatology. One is pemphigus and one is herpes or HSV. So, what do you see in HSV? That's very, very important. So, pemphigus, the classical thing that you see is acantholytic cells, which I will talk about. In HSV, along with acantholytic cells, you see multinucleate giant cells, or MNGs as it is called, or MNGs, and this is very, very important. So, both acantholytic cells and multinucleate giant cells can be seen, but the important feature of HSV is multinucleate giant cells. So, you see this, a cell which has multiple nucleus. So, this is my HSV infected cell, and this helps me clinch a diagnosis whenever there is a doubt. So, multinucleate giant cells are a feature of HSV, and this is asked n number of times. On Zank smear, if you see MNGs, you think of HSV. Clear? How do you treat herpes? So herpes, again, we will not go into so much detail. We use antivirals. The common antivirals which are used are acyclovir, valacyclovir and famciclovir. Whenever I am having the primary episode, which is my first episode, I give 200 milligram 5 times a day. And primary episode is always longer, more severe. So you need antiviral for at least 10 days. However, in recurrent episodes, I will give 400 milligram 3 times a day, which is equivalent to this dose, but I give for a shorter period of time, which is 5 days. Right? Apart from this, you do not need to remember dosing of each and every one. Remember, acyclovir, vala and famciclovir are antivirals which are used here. Once a question was asked, what if the patient is acyclovir resistant? In that case, we use foscarnate and cidofovir. Right? Foscarnate and cidofovir are used in acyclovir resistance case. So, wrapping up HSV, remember in HSV, you have primary, you have recurrent and latent stage. It is latent in dorsal root ganglion. You see vesicles which are grouped and you see coalescing erosions. The lesions are usually painful or associated with some discomfort, and you give antivirals like acyclovir for treatment. Clear? So, this is all that you need to know about HSV. And multinucleate giant cells on Zank smear is also a feature of HSV. Now, this is another question which is asked. I have told you also. So, sometimes once the patient has HSV, it can lead to a reaction pattern on other parts of the body. So, usually you are given a question or a patient presents like this, a patient of herpes labialis or herpes genitalis presents with such lesions on the extremities. So, what is it? So, these lesions, if you look clearly, are looking like what you see on a dart. So, there are 3 zones to it. There is a central zone, then there is an outer zone, and there is a third zone. So, these are called as target lesions. And these target lesions are a feature of erythema multiforme. Erythema multiforme is a reactionary thing which can be seen with viruses, after virus or after drugs. But more common is the viral etiology. And in virus, the common viruses which cause EM is HSV, Mycoplasma. These are my common viruses. It can also happen after drug reaction, but more commonly it is seen after a viral infection, and that too HSV and Mycoplasma. So, you are given a question that patient had vesicles over the upper lip. So, this came in yesterday in FMGE exam. A patient presented with vesicles on the upper lip followed by development of these lesions. An image was given. What is the diagnosis? So, when you see target lesions, you only think of erythema multiforme, right? Okay. So, these are also called as target lesions. Target lesions has 3 zones to it. There is a central zone of necrosis, edema and then erythema. No, not Lyme's disease. In Lyme's disease, what you have is called as ECM or erythema chronicum migrans. That different, don't get confused. You do not have target lesion there, right? So, target lesions, erythema multiforme seen with virus and drugs. Please remember this, a very, very important question. Quickly, this is not so important, but since they have asked EM, sometimes what happens if a patient has pre-existing eczemas that can be infected by HSV. So, a patient who is of atopic dermatitis may suddenly start developing vesicles all over the body. In that case, think of eczema herpeticum, eczema which has been infiltrated by herpes, right? Now, why am I telling you this? Suppose you have an eczema patient who's flared up. You think eczema has flared up and you give steroids to the patient. So, no, you do not give steroids. You think about this condition that it may be HSV which is affecting a pre-existing dermatosis, and you give acyclovir to the patient. That is what you need to know about eczema herpeticum, also called as Kaposi vericilliform eruption. Okay. Now, coming to the next virus, so we discussed molluscum, warts, HSV. The next important viral infection for you is varicella. Now, varicella causes 2 infections. So, in children, it will cause So varicella is caused by varicella zoster virus. So varicella zoster virus, because it causes two kind of infections, varicella in kids and zoster in adults. Okay, varicella is also called as chicken pox. It is seen in children, and zoster is seen in adults. Now this virus also shows latency. So this virus is also showing latency just like HSV. So when a child has varicella or chicken pox, that virus gets latent in the dorsal root ganglion, and in adulthood would present with herpes zoster or varicella zoster. Clear? Clear about this funda? Right. So first we will talk about the first infection which is causes, which is called as varicella or chicken pox. Chicken pox will usually affect children, as you know. There will be a preceding history of fever, malaise, the patient may have this, and the incubation period is 2 to 3 weeks, 14 to 17 days. So 2 to 3 weeks incubation period. How do you transmit the infection? Through respiratory route. So through respiratory route, it is not through skin that the infection is transmitted predominantly. So the patient after an incubation period develops some fever, malaise, and 2 to 3 days after that, patient develops, as you all were telling me, somebody was referring to polymorphic lesions. So typical feature of chicken pox is, this also came in FMGE exam yesterday. So a patient presenting with fever and then a centripetal rash on the trunk which was vesicular. So this was the question yesterday. The characteristic feature of rash of chickenpox is three things. It is polymorphic, it is morbilliform, and it is centripetal. What do you mean by polymorphic? By polymorphic, I mean different morphologies. So you have lesions of different morphologies. The patient will have macule, where there is just redness, develop into a papule, and then develop into a vesicle, and this forms crust. So this is the progression of lesion. So there is redness, उसके ऊपर papule बनेगा, papule में vesicle बनेगा और फिर वो फूट जाएगा और उसके ऊपर पपड़ी जमेगी. और एक patient पे on the trunk of the patient you see all these. So you can see macule, papule, vesicle, crust all together, and that is why you call it polymorphic lesions. What is a sign which is associated with the chicken pox? Come on. I'm so sorry about Hindi, English. You guys are confusing me. So tell me, what sign or what kind of sign is associated with chickenpox? Till I complete this, you give me the answer to that. So polymorphic is you see multiple lesions. Morbilliform means something which is red. So there is redness that you see on the trunk. And centripetal means which spreads from trunk to outside. Centrifugal is peripheral. Petal is central. So more commonly trunk is affected. So this is how you see. You see trunk having macule, papule, vesicles and crust. Good job. So when you look at these lesions closely, you see something like this. So you have a baseline erythema and you see a vesicle sitting right in the center. So it looks like dewdrops which have fallen on rose petal. So it is just like a rose petal and dewdrops falling on them. So dewdrop on rose petal appearance is very, very classical for chickenpox. So you have a prodrome followed by development of polymorphic centripetal morbilliform lesions, and you see dewdrops on rose petal appearance in children. Very good. So rose drop you all know, right? So this is how chickenpox present to you with. How do you treat chickenpox? For treatment of chickenpox, you have to mostly give symptomatic treatment. You do not usually give antivirals unless there is an adult having it or you think that the child is prone to developing complications. So in most of the cases, you just treat with antipyretics, antiallergics, some calamine lotion and things like that. The second infection which this virus causes is called as herpes zoster or varicella zoster. So VZV, now what happens is when you had chickenpox, it gets latent in a dorsal root ganglion of a body. And whatever dorsal root ganglion it got latent in, it can get activated from there only. So now as we know that for different ganglions there is a midline demarcation. So I will have different root ganglion here, I have a different root ganglion here, a different root ganglion here. So varicella zoster virus, wherever it has got latent, it will get reactivated on that particular dermatome only, right? So herpes zoster typically has a dermatomal distribution. Again, a very, very important question that is asked. What do you mean by dermatomal? It is only going to present in a single dermatome. So it is unilateral. So if in the question or on the image you see unilateral or dermatomal vesicular vesicles on erythematous base, you only think of herpes. And remember, it is very painful. Chicken pox is not painful. Chicken pox is itchy, there can be discomfort, but herpes zoster is extremely painful. So if you have a patient presenting with painful vesicles on a particular dermatome, unilaterally distributed, don't think of anything else, just think of herpes zoster, right? So the most common site where you will get is thoracic. So thoracic root ganglion is most commonly affected, but you can have it here, you can have it here, anywhere in the body, but thoracic is most common. But please remember, painful dermatomal unilateral lesions, especially vesicles on erythematous base, think of herpes zoster. Okay. Now sometimes if my herpes zoster is affecting the ophthalmic division of trigeminal nerve, then what will happen? I will have lesions here on the face. But how do I know that my eye will be affected? So I look for vesicles on the tip of the nose. So if I see vesicles on tip of the nose, I know that nasociliary nerve is affected. And nasociliary nerve is a branch of ophthalmic division of trigeminal nerve. So I know that there are chances of ophthalmic complications in this case. What is this sign called as? You will tell me. So if I see lesions on tip of the nose, I know there are increased chances of ophthalmic complication, and this sign is referred to as Hutchinson sign. Very good. So this is called as Hutchinson sign, right? So Hutchinson sign is a feature of herpes zoster and is telling me that tip of the nose, ophthalmic branch is affected. Good, right? So got herpes zoster. Now how do you treat herpes zoster? So now since it's a very painful condition, it is, another important thing I forgot to tell you. So this happens because of reactivation of virus, right? So remember, herpes zoster is not infective. So like chickenpox happened because of respiratory route, the virus can get transmitted again. So chickenpox is very, very transmissible and it is very easy to transmit chickenpox to someone. But herpes zoster is happening because of reactivation of virus, so it is not very, very infective. There are only 1% chances of infecting a patient, and that too if the patient is seronegative, right? So otherwise it is not usually an infective condition. Please remember this for herpes zoster. It is happening because of reactivation of virus, and this is also a question which is commonly asked. How do you treat herpes zoster? You have to give acyclovir here, and since it's very painful, patient is in a lot of distress, you have to give high dose. So you give 800 mg 5 times a day here. For HSV, just to recapitulate, you are giving 200 mg 5 times a day, but in herpes zoster you give 800 mg 5 times a day. Clear? Right? So you have to give oral treatment. In herpes zoster, no, you do not have to wait. You have to start the treatment as soon as possible. In chickenpox, I told you, it is not necessary to start antivirals, right? Sometimes a herpes zoster patient can have a persistent pain, tenderness, tingling, paresthesias after the zoster resolves. That is called as post-herpetic neuralgia. So persistent pain or nerve symptoms after herpes zoster, which can be more than 1 month or more than 3 months, is called as post-herpetic neuralgia. Just know this term, right? Herpes zoster is very, very commonly asked, right? So, I will move on to the next virus now, only the important things now. So, there is a virus which is called as Epstein-Barr virus, which you know causes infectious mononucleosis. EBV causes a skin condition which is called as oral hairy leukoplakia, another commonly asked question. So, in oral hairy leukoplakia, it is seen in HIV positive patients, and you see that on the lateral border of tongue, you have white verrucous patches. So, on the lateral border of the tongue, you see something like this. So, this is oral because it is in the oral mucosa, hairy because it is looking like hairs, and leukoplakia because it is a white patch. So, oral hairy leukoplakia, you should be able to identify this condition. You should know it is more commonly seen in HIV positive patients, and it is associated with Epstein-Barr virus. Right? Now, whenever I say leukoplakia means that this white thing cannot be scraped off, right? So, it cannot be scraped off. Only then you call a lesion as leukoplakia, when you cannot scrape off this white thing. Okay, clear? So, this is what Epstein-Barr virus causes. The next virus that we should be knowing is called as human herpes virus, and that too 6 and 7. Now, human herpes virus, smokers have this too. Smokers can have leukoplakia. Specifically, oral hairy leukoplakia is more commonly associated with HIV. Okay? Right. Now, HHV is human herpes virus. It causes Pitriasis rosea. It is a trigger factor for lichen planus, and it causes a condition called as roseola infantum. So, we need to know this. So, more commonly they ask about Pitriasis rosea, so I will discuss that in detail. Even roseola infantum is caused by HHV. Roseola infantum is also called as exantheme subitum. Now, if you remember these two terms, you know everything. So, roseola is rose colored lesions, infantum because it happens in less than 2 years, subitum means sudden onset. So, just remember roseola infantum. No slap cheek appearance in this. Slap cheek appearance is seen with parvovirus. That is a different virus. This is human herpes virus 6 and 7. This causes roseola infantum or exantheme subitum. So, what happens? Patients suddenly will develop fever. Fever will suddenly settle down, and there will be appearance of these rose colored papules and macules on trunk of a child. That is it what is happening. So, you just need to remember that it is caused by HHV, roseola infantum and exantheme subitum. This is something which you are asked very, very commonly. Pitriasis rosea. Now, remember, Pitriasis means scaly. So, whenever I am using the term Pitriasis, that means there has to be some scale. What is the kind of scale that you see in Pitriasis rosea? It is a very specific kind of scale that you see. So, the question is, can leukoplakia be related to fungal infection? No. So, when you have fungal infection, it is not leukoplakia. So, I will explain you that. Leukoplakia is a term which you use when you are not able to identify a cause of white patch in the oral mucosa. Any undiagnosed or a patient who has white patch in the oral mucosa where you cannot put it into a particular diagnosis, that is called as leukoplakia. Wonderful. Yes, you are right. So, it is colorate of scales here, which I will just show you. So, Pitriasis means scaly, rosea means rose colored, right? Now, Pitriasis rosea is an infection which is caused by HHV 6 and 7. So, here what happens is a patient has either an upper respiratory tract infection or a GI tract infection, 2 to 3 weeks after which patient starts to develop a single scaly lesion on trunk. Okay, and this lesion is called as herald patch or mother patch. Herald means to start. So it's a very peculiar manifestation which Pitriasis rosea have. You will have a history of URTI or GI infections. 2 to 3 weeks after that, patient notices a single scaly lesion on the trunk, which is called as herald patch, and it looks like that. Subsequently, in 1 to 3 weeks time, patient develops multiple small scaly rose colored lesions on trunk, which are called as secondary lesions, right. So, first the patient will develop a single lesion which is called a herald patch or mother patch, and subsequently patient develops numerous lesions which are rose colored and they are predominantly seen on trunk. So, this is Pitriasis rosea. Now, Pitriasis rosea, if you look at the lesion more clearly, so what happens here is, okay. So, if I look at the lesion, suppose this is my herald patch. If I look at this lesions, so I have a scale which is surrounding the edge of the lesion. This is called as collarette of scales, or collarette of scales means collar like scales. Okay. So, Pitriasis rosea is associated with herald patch. So, herald patch is seen in Pitriasis rosea. Collarette of scales seen with this. Now, when the patient presents with lesions on the trunk, now these lines follow the lines of cleavage, and so it forms a pattern on the trunk which is called as Christmas tree pattern. Okay. So, all these are important points for Pitriasis rosea: herald patch, Christmas tree pattern, collarette of scales, presence on trunk, right, and caused by HHV. So, we remember this with the help of a mnemonic HRCT. For H, I have herald patch and HHV. For R, I have rose colored lesions. With C, I have collarette of scales and Christmas tree pattern. And for T, I have trunk involvement. Okay. No, Dr. Avinash, maybe that's incorrect. Erythema multiforme, the more common reasons are viral infections. So, 80% are caused by viral infections and 20% by drugs. Okay. So, these are the important features HRCT for Pitriasis rosea, and you shouldn't be knowing about this because very commonly they asked you about Pitriasis rosea. It is a self-limiting condition, so it will resolve on its own. Okay, there is another sign which is called as hanging curtain sign, not commonly asked, but you should be knowing that also comes with H. So, the scales, they look like hanging curtain, it is not very relevant. So, but collarette of scales is very important. Christmas tree pattern is important, herald patch is important, trunk is important, and caused by HHV 6 and 7 is important, right. Next virus, that is HHV8 or human herpes virus 8, it causes a condition which is called as Kaposi sarcoma, another important thing that is given in the exam. Now, Kaposi sarcoma is a vascular tumor of endothelial cells. It is also seen in HIV patients just like oral hairy leukoplakia. Here again, you should be able to identify the condition and know that it is called as Kaposi sarcoma, seen in HIV positive patients, caused by HHV8. It can be seen on body, it can be seen in mucosa. So, sometimes they give a mucosal image of Kaposi sarcoma also. The characteristic finding in Kaposi sarcoma is you see multiple dark red to violaceous nodules. So, since it is a vascular tumor, you see a lot of dark tinge to it, a very violaceous tinge to it, and there you see multiple nodules which can be there in the mucosa or they can be there on the body. So, you should be able to identify this and know that it is called as Kaposi sarcoma, right? Okay. Now, someone was referring to slab cheek appearance. Slab cheek appearance is a feature of parvovirus B19. So, parvovirus B19 causes something which we call as fifth disease, and the infection is called as erythema infectiosum. How do you remember? Erythema is redness. Infectiosum is something which is spread. So, parvovirus causes slab cheek appearance, as if somebody has slapped my cheek. So, you see lot of turgid erythema or redness which is there on the cheeks. So, it looks like the erythema is spreading. So, erythema infectiosum or fifth disease is caused by parvovirus B19, and the appearance that you see is called as slab cheek appearance. It is usually seen in a child who is well, not ill, and you see this erythema which is there on the face. Now, once a question was asked where you were given a description of slab cheek and you were asked what other disorder can be associated with it. So, basically the examiners wanted you to know that slab cheek appearance is associated with parvovirus B19, and parvovirus B19 can cause other disorders like obviously arthropathy after fifth disease, transient aplastic crisis, anemia and hydrops fetalis. So, they had given in the option aplastic crisis. So, you should know that parvovirus B19 just does not cause fifth disease, it also causes aplastic crisis, arthropathies and anemias, right? Okay. Then another very common viral infection which is asked, can you identify what is this? It is caused by Coxsackie A16 and enterovirus 71. Coxsackie A16 is something that you should be knowing. What is this infection that I am showing? So, here the patient's hand, foot and mouth are given and they are affected. Good job. So, you are right, this is actually called as hand, foot and mouth disease or HFMD. The classical feature is in the name. You will have an image of hand, foot, mouth, and there what you would see, this vesicles or purpuric lesions on erythematous base. So, on an erythematous base, you see these vesicles and purpuric lesions. It is a viral infection caused by Coxsackie A16, usually seen in children. These days, there is an epidemic of HFMD that happens in school. Nothing to be done, it is just needs supportive treatment. But lot of times you get this image in the question and you are asked what it is. So, this is hand, foot and mouth disease, right? And that finishes my viral infections. So, I will wait for a minute. Any questions on viral infections, and then we move on to bacterial infections of the skin. Bacterial infections is a small topic, we will cover that and then we will move on to the next infection. No doubts, great. So, students, are you able to get what I am teaching you, or do you think my pace is too fast? But I have just 2 days to cover most of the dermatology, so I have got all the high yield topics here. But again, any doubts, any questions, you are most welcome to ask. Okay, I think I am teaching really well, no doubts. Good. Thank you so much for your input, and so I am glad you are understanding everything. So, we will move on to bacterial infection. Now, again, only the important infections in bacterial that you need to talk about. So, the most important that is asked in bacterial infections is impetigo. Now remember, bacterial infections are also referred to as pyodermas. So if you see the term pyodermas, don't get confused. Pyodermas also mean bacterial infections of the skin. Now these bacterial infections can vary. I am not giving you the classification because nobody asks you that. But these bacterial infections can be very superficial, just involving the upper layers of the skin, can be very deep like cellulitis, where they are going up to the level of dermis or lymphatics. So there are different kinds of bacterial infections that can happen, and they are mostly classified based on whether they are superficial or they are deep, or whether they are localized and widespread, but that classification is not important for you. So the most common bacterial infection that you see in children is called as impetigo. So most common pyoderma in children is impetigo, and the most common site is face. Now impetigo can be of two types. It can be bullous impetigo or non-bullous impetigo, out of which non-bullous impetigo is more common. Yes, good. Yes, you see golden colored crust. So remember this. So impetigo is bullous and non-bullous. So when I talk about bullous and non-bullous impetigo, this is how they look like. In bullous, you will see a bulla. In non-bullous impetigo, you would not see a bulla, because here the bulla ruptures. And so you see mainly crusted erosions here, or you see crusts here. This type of non-bullous impetigo is also called as impetigo contagiosum. Right? So non-bullous impetigo is also called as impetigo contagiosum. Don't get confused if impetigo contagiosum is given. So impetigo is impetigo, contagiosum is something that spreads. So contagiosum is for, because here you do not see bulla ruptures, so they form crust and this crust spreads. So it is called as impetigo contagiosum. So this is how it looks like. I'll first show you and then. So this is my non-bullous impetigo or impetigo contagiosum, where you are seeing lot of crusted lesions on the face of a child, whereas my bullous impetigo will present with bulla. Bullous impetigo is rarer, impetigo contagiosa is more commoner. So how do you differentiate between the two? Obviously clinically you can differentiate, but few other points. Bullous impetigo is usually seen in newborns and very small kids. Impetigo contagiosum on the other hand is seen in toddlers and school going kids. Bullous impetigo is caused by Staphylococcus, can also be caused by strep, but predominantly Staphylococcus. So it's like in developing countries, you see Streptococcus, in developed nations you see Staphylococcus. So here what I'll do to avoid confusion is, you only remember Staphylococcus here, and for impetigo contagiosum you remember Streptococcus. So whenever I am talking about bacterial infections, there are two main organisms that we are talking about, pyodermas, which I am talking about, Staphylococcus and beta hemolytic Streptococcus. Group A, beta hemolytic Streptococcus and Staphylococcus are two main organisms which are causing this. So bullous impetigo is caused by staph, impetigo contagiosum is caused by Streptococcus. Now bullous impetigo also can crust, but crusting is very important in impetigo contagiosum, and this is called as honey colored crust. So if in the exam, because this is very commonly given, honey colored crust is seen with impetigo contagiosum. Here you see golden colored crust, but this is rarely asked. I will not talk about lymphadenopathy, not important, but a complication. Since impetigo contagiosum is caused by Streptococcus, you can have post-streptococcal glomerulonephritis here. This was once asked. So post-streptococcal glomerulonephritis can be a complication of impetigo contagiosum, right? Now, so important points again: honey colored crust, crusted erosions on child of a face, think of non-bullous impetigo or impetigo contagiosum. However, if they give you a bulla, think of bullous impetigo. Now, why are the bulla being formed here? Because here the Staphylococcus targets desmoglein 1. You will know about desmoglein 1 when we study pemphigus. Just remember here the target is desmoglein 1. Because of that target, the skin splits off and leads to formation of bulla here. Right? The treatment, before treatment, yes, this is important. Sometimes they give you this. If you do a gram stain, since it's staph and strep, what do you see? You see gram positive cocci in clusters. So, you see gram positive cocci in clusters called as grape-like clusters or something like that. But lot of time with the image, they can also give you this, and this further helps you identify. How do you treat? You only give topical antibiotics. That helps. You rarely need oral antibiotics for impetigo because it's a very, very superficial infection, right? The next bacterial infection that you should be knowing about is Ecthyma pyogenicum. Ecthyma pyogenicum is caused by Streptococcus. So, it is caused mainly by Streptococcus, and what do you see here? This is what you see. You have a erythematous painful lesions which has got heaped up crust. It is a little deeper than impetigo, and that is why I call it ecthyma, and I have given a different name to it. And usually the patient will present with 1 or 2 lesions. So, there is heaped up crust that you see on the erythematous background. Okay. So, here you need to remember, if you remember, we discussed ecthyma contagiosum. Where was that? Ecthyma contagiosum was seen with ORF virus. So, ecthyma is of 3-4 types. So, ecthyma contagiosum was a viral infection which was caused by ORF virus. मोलस्कम कंटेजियोसम हमें याद रहेगा कि वायरस होता है, तो एक्थाइमा कंटेजियोसम भी वायरल होता है. एक्थाइमा पायोजेनिकम, also called as ecthyma infectiosum, is caused by Streptococcus, and we will study ecthyma gangrenosum, that is caused by Pseudomonas. So, 3 kinds of ecthyma, but their names are different. Contagiosum is ORF, pyogenicum or infectiosum is strep, and gangrenosum is Pseudomonas, right? Then this is another important topic in bacterial infections. Now, पहले impetigo था, superficial था, ecthyma था, deeper था, पर localized था. अब हम और deep infection पे आते हैं, तो हमारे को होता है erysipelas and cellulitis. Now, here what happens is a patient will usually present with fever, pain, some systemic symptoms, and there will be redness and swelling of an area which can be a limb. So, it can be on the forearm, it can be on the leg. In both these conditions, my history will remain the same: fever, pain, some systemic symptoms, redness and swelling of the area. But how do you differentiate between these 2 conditions? So, erysipelas is something which affects only till the level of superficial dermal lymphatics, whereas cellulitis is something which goes deep into subcutaneous tissue, right? So, cellulitis is going deep into the subcutaneous tissue, but erysipelas is more superficial. Because of that, erysipelas is well demarcated, and this helps me differentiate between erysipelas and cellulitis. Since it is more superficial, the lesion is well demarcated, whereas cellulitis is not well demarcated, it is more diffuse. Clear? This is asked lot of times. So, सब कुछ same है. The only difference which will help you make a diagnosis is whether they have mentioned well demarcated in the question or not. If they have mentioned well demarcated, you will mark erysipelas. If they have mentioned diffuse, you mark cellulitis. And then they ask you the causative organism also. So remember, erysipelas is group A beta hemolytic streptococci, whereas cellulitis can caused mainly by staph. Okay, so हमारी यहाँ लड़ाई स्टेप और स्टैफ में चल रही है, कौन क्या कॉज कर रहा है, राइट. So please remember this: well demarcated erysipelas, diffuse cellulitis. Good. Very good. Okay, I'll try to write in good handwriting. Okay. If you have erysipelas and cellulitis, here you need oral antibiotics. So treatment will be oral antibiotics. Got it? Now, further, sometimes the infections can affect the hair follicle. Okay. Now, hair follicle can be infected in various ways. So, this is a pictorial description of how. So, if this is my hair follicle, if the infection is very restricted to the follicle, I call it folliculitis. And this folliculitis can be superficial or deep. However, sometimes what happens, the infection also involves the perifollicular tissue, in which case I call it furuncle. So, furuncle is when my perifollicular tissue is also involved. And sometimes what happens is this, that it involves contiguous follicles. So, एक follicle and perifollicular tissue is involved, but surrounding follicles and perifollicular tissue is also involved, then I call it carbuncle. So, carbuncle is when multiple contiguous hair follicles are affected. Okay, got it? So, folliculitis, furuncle and carbuncle are various follicular infections which affect the skin by a bacteria. So, in superficial folliculitis, it is also called as Bouchard's folliculitis, and this has been asked. So, Bouchard's folliculitis is nothing but superficial folliculitis which can affect my face, my limbs, and what you see is multiple small pustules. Follicular pustules. Around the follicles, you see multiple small follicular pustules. It can also be on the face, it can be on the limbs, anywhere. So, Bouchard's folliculitis is nothing but superficial folliculitis, right? Sometimes the folliculitis may be very deep, like in scalp or in beard. So, here the infection is more deeper. When it is happening in beard, this deep folliculitis is called as Psychosis barbae. So, psychosis means fungus, but it is a misnomer. So, this is Psychosis barbae, is deep folliculitis of beard. This is how my furuncle looks like. So, furuncle is folliculitis with perifollicular tissue being involved, right? And my carbuncle is when I have multiple, so these are all contiguous hair follicles which have got affected. Carbuncle is usually seen in diabetes mellitus and usually seen on trunk. So, carbuncle in diabetes mellitus and trunk, right? You should just be able to identify these conditions. Now, these were direct bacterial infections, but lot of times this staph and strep also releases toxins in the body, and this toxin can cause certain dermatoses. So, one of these dermatoses is called as staphylococcal scalded skin syndrome. Staphylococcal scalded skin syndrome, also called as SSSS. So, in this what happens is, it's easier to understand. A patient has a focus of infection elsewhere. So, a patient may have ear infection or a boil somewhere, whatever. Acha, what is a boil? Boil is a furuncle. I forgot to tell you that in common layman terms, furuncle is called as boil. So a patient, usually a child who is admitted, has some infection somewhere. Now that infection, because of that infection, there is Staphylococcus in the body. From there, Staphylococcus starts to release a toxin, which is called as exfoliative toxin or ET1 toxin. This toxin goes into the blood and causes peeling or sloughing of the skin. How does that cause it? This toxin goes and binds to desmoglein 1 in the skin. This desmoglein 1 is present in stratum corneum. So it binds there, it weakens that, the bonds get weak and my skin splits off. So you see peeling or sloughing of skin hair. So how do you get this question? A child who is probably admitted in the hospital presents to you with sloughing of the skin, and in the history you may get that there was an ear infection, a boil, and a few days after that patient had fever, sloughing of the skin. So what is it? It is staphylococcal, caused by staphylococcus, scalded skin. Skin is getting scalded or peeled off because of that. So this is a toxin mediated disorder caused by ET1, and ET1 targets desmoglein 1, which is present in stratum corneum, and so it leads to splitting. We will talk about Nikolsky sign in pemphigus. Just remember that here also my Nikolsky sign is positive, right? So you should be able to, yes, you see true Nikolsky here. I'll talk about different types of Nikolsky, but yes, you are right, this is true Nikolsky. So this is another question. They give you an image like this and they want you to identify that this is staphylococcal scalded skin syndrome, right? Now, I was talking about staph, strap. So you should also know this, that what are the infections which are caused by staph and what are the infections caused by strep. So remember, all follicular infections, right, and toxin mediated disorders are caused by staphylococcus, right. Then streptococcus, NBI, ecthyma, erysipelas, this is all caused by streptococcus. Cellulitis more commonly caused by staph but can also be caused by strep. So there is an overlapping thing, and I don't think so they should ask you this, but once they had asked you, all is caused by staphylococcus except. So remember, non-bullous impetigo, ecthyma, these are caused by streptococcus. Non-bullous impetigo or ecthyma contagiosum. Okay? Clear everyone? We'll move on to the next kind of bacterial infection. So till now we were talking about staph and strep infections. Now, Corynebacterium is an important bacterium that also causes bacterial infections, and it causes 3 infections precisely: erythrasma, pitted keratolysis and trichomycosis axillaris. I've written them because once they had asked you, Corynebacterium causes all except. So erythrasma, pitted keratolysis and trichomycosis axillaris. Remember, this is a misnomer. Again, mycosis means fungus, but there is no fungus here. It is caused by Corynebacterium, which is a bacterial infection. Now, the most important Corynebacterium that is asked to you is erythrasma. Erythrasma, erythra means red. So erythrasma is an infection that you see. It is caused by Corynebacterium minutissimum. You should know all about erythrasma, very important. So it is caused by Corynebacterium minutissimum. It can affect multiple body sites, toe web space, axilla, groin, inframammary area, and this presents with a well demarcated, non-itchy, very mildly scaly erythematous plaque. So something like this. So you have well demarcated, non-itchy, mildly scaly erythematous plaque. Now when you have something like this, you can also confuse it with tinea or fungal infection. So what do you do here? Here you do Wood's lamp. And what is the finding on Wood's lamp? What am I seeing here? So here I am doing Wood's lamp, and you see this is the lesion, and when you do Wood's lamp you see this. What is this finding called as? quickly. You all know this. This is very important and very commonly asked. Wonderful. Yes, you're right. So, this is called as coral red fluorescence. So, when you do a Woods lamp, you see this red colored fluorescence called as coral red fluorescence, and this is because this bacteria produces something which is called as coproporphyrin 3. So, this coproporphyrin 3 emits this fluorescent thing, and then this leads to coral red fluorescence. So, lot of times you are asked coral red fluorescence is seen with, you are asked the organism, and you are asked that why does it produces fluorescence. This is because of coproporphyrin 3, right. So, this is how it presents, and they also ask you, they give you an image like this and they ask you how do you diagnose. So, you do a Woods lamp and this shows coral red fluorescence. So, this is very, very important. Erythrasma is very commonly asked and coral red fluorescence is asked, right. The next is pitted keratolysis. Pitted keratolysis is also caused by a form of Corynebacterium which is called as Micrococcus sedentarius. Micrococcus sedentarius, it is seen on feet, and this is the typical description. You see the feet and you see these pits being formed on the feet, and this is because this bacteria is causing keratolysis or lysis of the keratinocytes, which leads to formation of pits. This is seen in patients who have very, very wet feet. So, hyperhidrosis patients, patients who are swimmers or who live in wet areas constantly, housemaids, someone who would be always dealing with wet work. So, this also predisposes them to this infection, and you get these pitted lesions, keratolytic lesions on feet. So, you should know that this is called as pitted keratolysis and is seen with Micrococcus sedentarius, which is a type of Corynebacterium, right. Trichomycosis axillaris, just know the name. The next bacterial infection that is asked you is called as anthrax. Anthrax is a bacterial infection which is caused by a bacteria, Bacillus anthracis. Bacillus anthracis is a zoonotic infection. Zoonotic infection is infection which is transmitted by animals, and so it would be seen in livestock handlers. So, now whenever there is any zoonotic infection, it will happen on hands and feet mostly, because that will come in contact with the livestock. So, it is seen with livestock handler. Now, with anthrax, you form a particular lesion which is called as malignant pustule. Again a misnomer, because this is not a malignancy and this is not a pus-filled lesion. So, what you see is this, you see an erythematous plaque which shows central necrosis or crusting, right. So, this is my malignant pustule. So, lot of times this is asked, malignant pustule is seen in, it is seen with anthrax, and the causative organism is Bacillus anthracis. Clear? The last in bacterial infection, you should know about few Pseudomonas causing skin infections. So, Pseudomonas causes something which is called as hot tub folliculitis. So, what do you mean by hot tub folliculitis? A patient who takes bath in a community swimming pool or in a jacuzzi which is not well cleaned would suddenly develop monomorphic pustules on trunk. Monomorphic is similar looking. Same morphology pustules on trunk after jacuzzi or swimming pool bath. This is called as hot tub folliculitis, and this is caused by Pseudomonas, right. The next and the more commonly asked question about Pseudomonas skin infection is, which I told you. So, I told you ecthyma contagiosum infectiosum, and it causes ecthyma gangrenosum. So, someone mentioned eschar. Eschar is a term which typically we associate with ecthyma gangrenosum. Now, Pseudomonas, understand, is a bacteria which is something serious. Pseudomonas skin infections are more common in patients who are HIV positive, diabetic patients, and hospitalized patients. So, typically when a examiner wants to ask you about Pseudomonas infection, he will give one of these history. A patient who is hospitalized, who is a diabetic, HIV patient, develops a lesion like this. So, what is this lesion? You see this erythematous lesion, and in the center you see these necrotic crust, and this necrotic crust is called as eschar, and this complete lesion is called as ecthyma gangrenosum, जैसे gangrene बन गया हो. So Pseudomonas causes ecthyma gangrenosum, which forms an eschar in the center, and eschar is nothing but a necrotic crust, and it is seen in this group of population. Clear? Okay, this is in general when you have to treat bacterial infections. What do you do? If it is a superficial infections, you use topical antibacterials like fusidic acid. You can use mupirocin, bacitracin, ritapamullin. These are the agents. Oral, you use cloxacillin, cephalosporins, erythromycin or amoxicillin. So, lot of times they give you an image of bacterial infection and ask you how to treat that. So, they basically want to know whether you know it is a bacterial infection, and so you have to give antibacterials for it. Clear? That finishes our bacterial infections. So, should we finish fungal infections and then take a short break, or do you guys want a 5-minute break right now? Quickly. Difference between eschar and target. Oh, so target lesion is very different. Target lesion, you will see 3 zones. With eschar, you are seeing a necrotic crust in the center. You do not see 3 zones. Yes. So target lesion has 3 zones. So waiting for more inputs. I can finish fungal infections and then take a break. Okay, finish fungal. Quickly. I do not want to waste any more time. So I'm waiting for more inputs, and whatever is the consensus, we can do that. No, fungal will not take 10 minutes. Fungal will take around 20 minutes or so. Okay. So again, break fungal, just take 10 minutes. So 3 for break, 3 for fungal. Let's see. So let us finish fungal infections and then we can take a break. Okay. So I am getting different inputs in the app and on YouTube. So okay. So let's finish this off. So that will finish half of our session today. Then we'll take a 15 minutes break and then we can move on to the next thing. And also with this, we will finish the infections for today. The rest of the infections, which is TB, leprosy and STIs, I will try to do tomorrow. Okay. So great. So without wasting any more time, coming to fungal infections. So important fungal infections that you should be knowing. One of the very important fungal infection which is asked in the exam is P. versicolor, also called as Pitriasis versicolor. Now Pitriasis, I told you, means scaly, and versicolor means various color. Now remember, when we are talking about fungal infections are broadly divided into superficial fungal infections, subcutaneous mycosis and systemic fungal infections. So we are not going to deal with systemic fungal infections here. We will talk about superficial fungal infections and we will talk about subcutaneous mycosis here. Okay. So Pitriasis versicolor is my first fungal infection that I want to talk about. It is a very superficial fungal infection. It is called as Pitriasis versicolor because it is presenting with scaly lesions and these lesions can have various colors. Now the organism causing Pitriasis versicolor is Malassezia. So Malassezia is the organism causing Pitriasis versicolor. The common species are globosa, furfur and sympodialis. Globosa, sympodialis and furfur. Okay, sorry, just give me a second. Okay, so Malassezia, remember, is a fungus which is a normal commensal of human skin. Our skin has a lot of good bacteria and fungus, and Malassezia is one of them. When it becomes pathogenic or when it increases in quantity, then I get various Malassezia related disorders, and Pitriasis versicolor is one of them. The species causing that is globosa, furfur and sympodialis. Remember, Pitriasis versicolor is an asymptomatic infection because it is very superficial, so there is no itchy. It is usually seen in rainy seasons or with change of weather, because in these seasons Malassezia grows more. Also, it is seen in adolescent age group because again this age group there is increased oil secretion and Malassezia loves oil. So, there is increased Malassezia over colonization here. How do the patient present to me with? The patient presents with asymptomatic scaly macules which can be either light colored or dark colored. So, you can, that is why it is called versicolor, because they can either present with light colored lesions like this or dark colored lesions like this, and they are very small lesions, very fine scaly lesions that you see. They are mainly present on trunk, and the scaling that you see is very typical. The scaling here is fine brany scales. So, typical thing is fine brany scales. So, something that you do not sometimes see. You have to scratch the lesion and then you see these fine bran like scales. What is a bran? जो wheat के बाहर होता है ना, वो bran होता है. So, fine brany scales is seen here, and because you see it after scratching, we call it as scratch sign. Right? So, you get an image of a trunk where you see these multiple hypopigmented or hyperpigmented lesions which are associated with fine scaly brany scales, and this is Pitriasis versicolor or also referred to as tinea versicolor, which is a misnomer again. Now, sometimes they ask you why does it become white. So, white it becomes because this fungus produces carboxylic acids, and this carboxylic acid causes decreased pigmentation or hypopigmentation, which leads to whiteness in the lesion. Then some people ask you why it becomes hyperpigmented. The hyperpigmentation happens because of giant melanosomes, but more commonly they ask you this, that hypopigmentation happens why? Because of carboxylic acid, right? Then yes, it inhibits tyrosinase, you are right. How do you diagnose? You do a KOH smear, another thing that is asked. Now, remember, Malassezia is a dimorphic fungus. So, you have two stages that you see. You see these hyphae and you see these yeasts. So, you have both yeast cell and hyphae. So, this looks like you have spaghetti and meatball appearance. So, this is spaghetti here is the hyphal form and meatballs are the yeast form. It is also referred to as banana and grapes appearance, right. So, remember, Pitriasis versicolor, on KOH you see spaghetti and meatball appearance, which is very commonly asked. Okay. Then what is the next test that you can do? You can do a Wood's lamp here. What kind of fluorescence do you see in Pitriasis versicolor? Tell me. What kind of fluorescence do you see in Pitriasis versicolor? Very good. So you see yellow color fluorescence when you do a Woods lamp on malassezia. So how do you remember this yellow fluorescence? I told you malassezia is to do with oil glands, right? More oily adolescent age group, you see more malassezia, and because of this oiliness, oil is always yellowish in color. So remember, yellow color fluorescence is seen with Woods lamp. Right. So, with Pitriasis versicolor, remember fine briny scales, remember spaghetti and meatball appearance, remember on Woods lamp you see yellowish fluorescence. How do you treat? You give topical azoles, clotrimazole, luliconazole, any of this you can give. You can also use agents like zinc pyrithiron, selenium sulfide and sulfur, which are also antifungal agents. In severe cases, you give oral azoles. Okay. So, broadly you should know topical azoles are given, and you should remember these names because they have no azoles in them, but they are also antifungal in nature. Zinc pyrithiron, selenium sulfide and sulfur, right. Then we come to dermatophytosis or tinea. So, one was Pitriasis versicolor. The next infection that you should be knowing about is dermatophytosis. Now, remember, dermatophytosis and tinea are same thing. Dermatophytosis is fungal infection caused by dermatophytes, right, and this fungal infection is also called as tinea. Clear? Now, these dermatophytes have three species: Epidermophyton, Microsporum and Trichophyton. Okay? Now, these species can affect my skin, hair and nails. Remember, it does not affect my mucosa. Okay. So, skin, hair and nails. Now, they ask you what species affects what. Now, Epidermophyton has E in it. E is very close to H. So, it will not affect hair, but it will affect skin and nails. Microsporum has M. So, it is very close to N. So, it will not affect nails, but will affect skin and hair. Trichophyton has tri. Tri means 3. So, it affects all skin, hair and nails. Okay. So, 3 species, and what do they affect? Epidermophyton does not affect hair, Microsporum does not affect nails, Trichophyton affects all 3. Right. So, these are my 3 species, and what do they affect? Now, based on the site which is affected, my dermatophytosis is named accordingly. So, just to give you an example, if I have tinea on my head, we call it tinea capitis. If there is tinea on the face, we call it tinea faciae. If it is in the body, you call it, what do you call it? If you have tinea on the body, so scalp, I am calling it capitis. Face, you call it faciae. Body, you call it corporis. So, on body, you will call it corporis. How about nails? Nails, come on, quickly tell me. What if my tinea is affecting my nails? You call it, okay. So, here onychomycosis is any fungal infection of nails. When it is specifically caused by tinea, I call it tinea unguum. Okay. Yes, so tinea unguum is one which causes the nail infection. So, onychomycosis is a broader term which means any fungal infection affecting the nails. If it is affecting my groins, I call it tinea cruris, and if it is affecting my beard, I call it tinea barbae. So, these are different types of tinea based on the site they affect, right. Now, what does tinea do? Tinea manifests something like this. Tinea is also called as ringworm because it is presenting with the annular erythematous plaque which shows peripheral scaling. So you have a typical lesion like this. You have a lesion, annular lesion, which shows central clearing. So annular lesion would mean a lesion which shows central clearing. Annular lesions, erythematous lesions with periphery showing scaling or crusting. So this is how a typical tinea lesions look like. Okay. Now, when it affects my scalp, I call it tinea capitis. So it is affecting my scalp hair. So then I call it tinea capitis. Now, tinea capitis, you have to remember, is of two types. It can be inflammatory type or non-inflammatory type. So, in non-inflammatory, I have two tinea capitis, grey patch and black dot. In inflammatory, I have cheiron and favus. So, what do I mean by inflammatory and non-inflammatory? Non-inflammatory are usually caused by species which are anthrophilic, whereas inflammatory types are caused by species which are zoophilic. Zoophilic species are species which are inhabiting animals. So, अगर वो species हमें affect करती है तो हमारी body ज़्यादा inflammatory response mount करती है and that leads to inflammatory type of tinea capitis, right? And non-inflammatory is if it is an anthrophilic species. Another thing that you need to know about tinea capitis is it can give rise to two kind of infection. Now, suppose if this is my hair follicle, the two things can happen. My fungus can grow on the sides of the hair like this, in which case I call it as ectothrix, that the fungus is outside the hair and so it is called as ectothrix. The second possibility is if this is my hair follicles, my fungus has invaded inside the hair shaft and is lying inside the hair. In this case, I call it endothrix. It is inside. So, I call it endothrix. So, endothrix is when my infection of the hair is happening by invasion of fungus inside the hair. So, endothrix, ectothrix and inflammatory and non-inflammatory. So, these are the different kinds of tinea that we should be knowing about. So, the first is grey patch. You have to identify this. Now, how do you know this is a grey patch? What do you look here? You have a patch of alopecia and on them you can see some grey scales. So, this is grey patch type of alopecia, grey patch type of tinea capitis. So, alopecia with grey scales, right? What is this? This is my black dot. Why do I call it black dot? Because I am seeing all the black dots here. So, this is my black dot type of tinea capitis because I see these black dots, and these black dots are nothing but swollen hair shafts. I just told you about ectothrix and endothrix. So, grey patch is a type of ectothrix infection. Here the fungus is outside and that is why I can see grey scales here. These grey scales are nothing but fungal colonies, right? So, I have these scales. So, that means these scales are fungal colony, they are outside. So, they are ectothrix. Black dot on the other hand is endothrix infection. So, endothrix infection is when the hair is invaded from inside. So, it causes the hair shaft to get weakened, the hair falls off and what I see is swollen hair shafts. So, black dot is endothrix, grey patch is ectothrix. Now, important things that you should be knowing about them. Ectothrix, since my infection is outside, when I do a Wood's lamp, I see a positive green fluorescence here. Again, something which is asked in the exam. So, positive green fluorescence is seen with ectothrix, whereas endothrix will not cause any fluorescence. So, if you do a Wood's lamp, it will be negative here because here the fungus is inside the hair shaft, so it does not emit anything out, right? So, ectothrix or grey patch will show positive Wood's lamp fluorescence. This ectothrix or grey patch is usually caused by Microsporum canis, and endothrix is caused by Trichophyton tonsurans. Right? So, I am talking just about the non-inflammatory type of tinea capitis, which is black dot and tinea capitis and grey patch. So, everything is there in the name: grey patch, scaly patch. Since scales on the outside, I see a positive Woods lamp fluorescence, and it will be an ectothrix, and it is caused by M. canis. Endothrix, on the other hand, will present with black dots, swollen hair shafts, no Woods lamp, and caused by T. tonsurans. Right? Now, this is, here you see inflammation. So, what is this type of tinea capitis? Tell me, what is this kind of tinea capitis? Yes, you are right. So, this is cheiron. Cheiron is an inflammatory type of tinea capitis. So, here what do you see? You see boggy swelling. Boggy swelling is very, very important, because if in the question you have boggy swelling, think only of cheiron. So, cheiron presents with boggy swelling on the scalp, which is studded with pustules and broken off hair. Here you may also see lymphadenopathy present. So, boggy swelling studded with pustules, think of cheiron. Now, cheiron is caused by, it is a very severe infection, you can see this. So, caused by long names: Trichophyton verrucosum and Trichophyton mentagrophytes. So, Trichophyton verrucosum and Trichophyton mentagrophytes, and here if you do Woods lamp, that would also be negative, because what happens here is there is so much inflammation that the fungus is killed. So, there is nothing to show Woods lamp fluorescence. Okay, clear? The last of the tinea capitis is called as Favus. Favus is caused by Trichophyton schonleni. You have to know the names of the fungus specifically which is causing this. So, Favus ends with S for schonleni. And here you see these cup-shaped crusts which are called as scutula. So, scutula is S, schonleni is S, and Favus has S. So, schonleni, scutula, and this will show Woods lamp fluorescence. Okay. Now, Woods lamp fluorescence is seen here because these crusts that you see are nothing but fungal colonies. So, Favus is showing cup-shaped crust and schonleni. Clear? Okay. So, this is just a brief revision of what we have discussed. So, we have discussed most of this. I will not go into the further details. An important thing that you need to remember for tinea capitis management is always griseofulvin. You do not give you can give topical antifungals, but my treatment of choice or drug of choice is griseofulvin. In fact, griseofulvin is hardly used these days, but in tinea capitis, this still remains my drug of choice, because this is asked. You are given a history of tinea and then you have to tell what drug will you use. So, griseofulvin is the drug of choice. Right. Yes, so you are right on fluorescence. When you see in Favus, you see a dull green fluorescence. You see dull green fluorescence here. Okay? Clear? Then this is tinea faciae. You should just be able to identify when you have fungal infection on the face, I call it tinea faciae. If it is on the body, we call it tinea corporis. So, tinea corporis is when you have body affected, and body would include everything except the special sites which we have discussed. Okay. Then we have tinea pedis. Tinea pedis is when my feet are affected, I call it tinea pedis. Tinea pedis is also called as athlete's foot because it is seen in athletes who are constantly running with shoes on. So, the humidity, their sweat gets accumulated and that leads to this fungal infection. And so, this is tinea pedis is synonymous with athlete's foot, right? Then you can have tinea in the groins or fungal infection in the groins. When you have it in the groins, you have to understand that groins, again, because of hot humid environment, this fungus will grow more. So, there is a term which is called as dhobi itch or jogger's itch. So, dhobis have to work in hot humid environment, joggers are constantly running, so friction and sweating in this area. So, this leads to something which we call a tinea cruris. Cruris means folds. So, they ask you dhobi itch is or jogger's itch is. So, this is tinea cruris. Very, very important kind of tinea, tinea incognito. Now, there is no site called as incognito. So, what does tinea incognito means? Incognito means hidden. Incognito means hidden. So, here what happens? A patient who has had tinea starts to apply certain OTC or steroid creams, right? So, they start applying certain OTC or steroid creams which modifies the picture of tinea. The picture of tinea is modified and so you do not see that classical tinea look, but what you see is these erythematous papules, pustules, pigmentation which is randomly distributed. So, if in the question they ask you that a patient presented with an itchy lesion and then applied certain OTC or steroid cream. So, this is a giveaway. If they write this in the exam, OTC or steroid cream, and they give you a lesion which is something like annular lesion but not exactly like tinea, think of tinea incognito. So, because of this OTC or steroid creams, the clinical picture gets modified, the tinea gets modified and you have a picture like this, and this is called as tinea incognito or tinea which is hidden. So, again you have to stop the creams, steroidal creams here and give antifungals to the patient. Another very, very important question which is asked, right? Then I have tinea unguum, when my tinea affects my nails. Now, somebody said what is the difference? So, onychomycosis is a broader term. Remember, Candida and other fungus can also cause nail infection. So, onychomycosis is any fungal infection of the nail. When it is caused by dermatophytes specifically, I call it tinea unguum, right? Now, when it affects the nails, it can lead to different kind of manifestations. So, it can just affect the distal and lateral part of the nails, in which case I call it distal lateral subungual onychomycosis, or it can affect the proximal part when I call it proximal subungual onychomycosis, or it can just forms white flakes on the surface when I call it superficial white onychomycosis, or it can cause total dystrophy of the nail when I call it total dystrophic onychomycosis. Okay. So, these are different manifestations of nail getting affected by dermatophyte. Now, this is what is asked you very commonly. So, what are the treatment options when nail gets affected? So, if you have single nail being affected, you use nail lacquers, and there are two nail lacquers which are commonly used, cycloperox and amorolfin. You must have studied it in pharmacology. So, two nail lacquers that we use is cycloperoxolamine and amorolfin. However, if more than 3 nails are affected and we see lot of dystrophic changes, we give oral treatment to the patient. And in oral treatment, we give itraconazole or terbinafine. The dose of terbinafine, so this is my preferred drug. So, dose of terbinafine is 250 milligram daily, and this is given for 6 weeks in fingernails and 12 weeks in toenails. Now, fingernails grow at a faster speed as compared to toenails. So, with fingernails, you give it for 6 weeks, and for toenails, you give it for 12 weeks or 3 months. You can also give hydroconazole 100 milligram twice a day. Again, 2 months for fingernails and 3 months for toenails. Now, for onychomycosis, we use pulse therapy at times. So, pulse therapy is giving high doses of drug for short period of time. Okay. So, what pulse do we use? We use itraconazole, which is given 200 milligram twice a day. Double कर दिया हमने dose. वहाँ पे था 100 milligram twice a day, हम 200 milligram twice a day दे रहे हैं. But here we are giving only for 1 week every month. We are only giving 1 week every month. Okay. And then you give it 2 to 3 pulses for fingernails and toenails के लिए 4 to 5 pulses. Okay. This is important. This has been asked. So, if you have a toenail, you give for 12 weeks. If you have a fingernail, you give for 6 weeks. Right? This is how on KOH my dermatophytes looks like, branch, septate, hyphae. This you would have studied in microbiology. So, treatment, I have covered the treatment which is usually asked, but there are 2 classes of drugs which are commonly used. So, azoles and allylamines. So, this you will study in pharmacology. So, I will not touch upon the mechanism of actions of these drugs, but remember azoles and allylamines are my 2 agents which are commonly used. Right? Are you there with me? So, I am going to finish this fungal infection soon and then I will give you a short break. So, just stay with me till then. Okay. Now, coming to the next fungal infection which is Candidiasis. In Candidiasis, we need to know just few things. Candidiasis is caused by Candida albicans, which is the most common thing. Now, remember, whenever they are talking about Candidiasis, they will give you something like immunocompromised state, pregnant patients, diabetes. So, because Candida mainly affect this subgroup of population and Candida will present with yeast form which is seen here. Right. Now, Candida can also affect my oral mucosa. Tinea did not affect my oral mucosa. So, in oral mucosa, Candida causes oral candidiasis. Now, oral candidiasis again will happen more commonly in patients who are smokers, who are diabetics, who are pregnant or immunocompromised. So, this is usually given in the history. And then the patient presents with whitish plaques in the oral mucosa. Whitish plaques in oral mucosa, which in most of the cases are removable, okay, in the most commonest of cases. Now, oral candidiasis has been divided into 4 forms. It can be the first and the most commonest is oral thrush, which present with these whitish plaques, and along with that patient has some discomfort. So, patient can have irritation, patient can have difficulty in eating food, right? But sometimes these plaques are very stubborn, in which case I think of candidal leukoplakia. And as I was telling you, in leukoplakia, the plaques are very, very stubborn. So, you see adherent plaques which are not rubbed off easily, right? Sometimes even antibiotics causes Candida. So, when you take antibiotic, post antibiotic, you feel that there is the area has become red. So, Candida can not just present with white plaques, it can also present with red plaques. And this happens when the patient has taken antibiotics or after dentures. So, if you have a patient who after antibiotic or dentures presents with sore mouth, think of Candida. Right? It can also affect the corners of the lips. So, when it affects the corners of the lips, I call it angular cheilitis. Okay. Then, Candida can also affect my genital mucosa. In males, it causes melanoposthitis. You should just know what all it causes. I will not dwell into the details. Now, an important thing about Candida is that if you look at a patient who has been infected with Candida, it's very easy to identify because you see something which is called as satellite pustules. So, if you see satellite pustules which are there in the genital area, groin area or even in the inframammary area, you think of candidal infection. What do you mean by satellite pustules? कि suppose infection यहाँ पे है, उसके side में आपको छोटे छोटे से pustules दिख जाएंगे. So satellite pustules is a feature of Candida. Then obviously it can affect my intertriginous areas. It can also cause vulvovaginal candidiasis. So in candidiasis, when you do investigate, you see these yeast form and you do a test called as germ tube test. Again, you will study about it in microbiology, right? When you are treating Candida, you have to give azoles. So azoles are my treatment of choice for Candida. You do not use allylamines here, okay? The last subtopic is subcutaneous mycosis, after which we will finish fungal infection. In subcutaneous mycosis, you have to remember few things. Subcutaneous मतलब वहाँ तक fungus गया है, तो वो कैसे जाएगा? How will the fungus reach up to the subcutaneous layer? So it usually happens by pricks. So it is usually thorn pricks, and these subcutaneous mycosis, that is why we see very commonly in farmers, gardeners, because they keep getting this thorn pricks through which the fungus is implanted into the subcutaneous tissue. There are three kinds of subcutaneous mycosis which are important: sporotrichosis, mycetoma and chromoblastomycosis, out of which this is like very, very important. You get it, or you get a question on this, on subcutaneous mycosis almost every year. So yesterday there was a question on mycetoma. So sporotrichosis is a subcutaneous mycosis which is caused by an organism called as Sporothrix kenkai. Sporothrix kenkai is a fungus which is causing the sporotrichosis. Now, this sporotrichosis is usually seen in rose gardeners and farmers, and that is why it is also called as rose gardener's disease. Rose gardener's disease. Now, a typical point about sporotrichosis is in this, the fungus which affects in lymphatic distribution. So, typically you see lesions which are present in a linear fashion along the lymphatics. So, you see lesions which are present along the lymphatics in a linear fashion, and this is the characteristic of sporotrichosis. And this pattern is, that is why also referred to as sporotrichoid pattern. So, when you see these erythematous papules and nodules which are present in this linear or sporotrichoid pattern, very commonly such an image is given to you. It can be on the hand, it can be on the feet. Think of sporotrichosis because it affects the lymphatics, and so you have lesions along the lymphatics. Okay. Next, another important thing is if you do a histopath, you see asteroid bodies. So, asteroid bodies are nothing but these star-shaped bodies. So, what happens is this fungus gets down and my inflammation surrounds this fungus, leading to a star-shaped body or asteroid body. So, asteroid body is again a feature of sporotrichosis. And this phenomena of uncovering this fungus is called as Splendor-Hopley phenomena. So, with sporotrichosis, linear or sporotrichoid distribution seen in rose gardeners or farmers, and you have this Splendor-Hopley phenomena. Right? Now, remember there was once a question. So, sporotrichosis, kenkai is also a dimorphic fungus. So, it would also appear as yeast and hyphae. So, they had given you a complete history and they had asked you that what organism causes it, and they had given you a KOH image of Sporothrix kenkai. Right? So, on pastane you see cigar shaped bodies. So, cigar shaped bodies, asteroid bodies, all feature of sporotrichosis. How do you treat sporotrichosis? You can give potassium iodide, itraconazole or terbinafine. Any of this can be given. Right? Got it? Now, next subcutaneous infection is called as mycetoma, also called as Madura foot. Right? Now, important thing about mycetoma is this is on the foot, seen in farmers, and is painless. Remember, these subcutaneous mycosis are all painless. So, painless lesion on the foot of a farmer, think of mycetoma. Now, mycetoma can be caused by both bacteria and fungus. When it is caused by fungus, I call it eumycotic mycetoma. Whereas when it is caused by bacteria, I call it actinomycotic mycetoma. Now, why is it important? Because in the exam you have to differentiate between two. So, lot of time they just ask you the diagnosis of mycetoma or Madura foot as they call it, but lot of times they also want you to differentiate between these two, which I will help you. So, this is how my mycetoma or Madura foot present to you at. Foot painless farmers with a triad where you see induration or thickening of the skin. So, you see that there is induration, thickened skin is there. And what else do you see? You see these discharging sinuses. So, you see sinuses जिसके अंदर से पस निकल रहा है. And if you touch this pus, this is actually fungal colonies. So, they appear as grains here. So, grains, sinuses and thickening are a triad which is associated with mycetoma. So, you have this discharging sinuses, and from these discharging sinuses, you see these grains coming out, right? So, this is how my mycetoma presents. But then how do I differentiate whether it is eumycotic or actinomycotic? You do not need this whole table. There are few things which are very, very important. Eumycotic presence with black granules. This was another question which was there in yesterday's exam. And here the granules are yellowish white or red in color. So, red or yellowish white granules is actinomycotic. Fungus is bad, fungus is black. So, black is eumycotic. Another important differentiating feature is the fungal infection or eumycotic one is slowly invasive. So, it would slowly grow out, and that is why with fungal mycetomas, the deformities are also much more. Actinomycotic mycetoma is rapidly invasive. क्योंकि painless है, the patient does not come to you. So, only when it is rapidly invasive, the patient will present to you early, and so it is associated with less deformities, right? So, if you have black granules, slowly invasive lesions, you will treat the patient with antifungals, whereas if it is a rapidly invasive one with red or yellow granules, you will give antibiotics to this patient. So, they give you a history and they want to know whether you will give antifungals or antibiotics. Usually in fungal cases, you also need surgery because they are very, very late presentation. So, there is lot of deformities which happen in them. Clear? So, black granules, eumycotic, red granules, yellow granules, think of actinomycotic. The last in fungal infection is chromoblastomycosis. Chromo means colored and blasto means verrucous. So, you just need to remember this. This is caused by Fialophora verrucosa, again a painless verrucous plaque on extremities. But the classical thing here is if you do a staining, you see these copper penny bodies, these bodies which look like copper pennies. So, they are bronze looking copper penny sclerotic or muriform bodies. So, this fungus, it divides in all plane. So, you have these copper colored pennies or sclerotic or muriform pennies here. So, this is what you need to know. So, colored. So, you have colored verrucous plaque with sclerotic bodies which are feature of chromoblastomycosis, right? And this finishes our fungal infection, and I will give you a 10 to 15 minutes break here, and then we will resume our session. Okay. So, drink some coffee, eat something and come back all rejuvenated so that we can begin our session again. Okay. Hi students, welcome back. Okay, so there's a question. Ecto and endo can be caused both inflammatory and non-inflammatory? Yes, they can cause both inflammatory and non-inflammatory. That's not a problem. Okay, any other questions? Now can you hear me? So now I just thought that we'll take a break from infection. So we are left with TB, leprosy and sexually transmitted infections, but probably we'll cover it tomorrow and we'll move on to the next set of topics which are also very, very important for us. And so the first of which is immunobullous disorders. Perfect. So welcome back everyone, and I hope you had your tea, coffee and are all rejuvenated. So just understand, I've been speaking for 3 hours. So please forgive me if I make some mistakes. Help me out there. Keep interacting with me, keep chatting with me, because that helps me keep going, right? So keep giving me answers, keep asking questions, because then the session feels lively. So next topic is immunobullous disorder, which you would know more commonly as pemphigus or bullous pemphigoid that you study about. So these are a group of disorders where there is development of vesicles and bulla, but they happen. So vesicles and bulla were also seen with herpes, right? But here the bullous lesions are formed because of some immunological process, and here that process is antigen antibody complex formation. So here there are certain structures in the skin which are being targeted by antibodies, and they cause structural dismantling of the skin, which leads to formation of vesicles and bulla. So broadly immunobullous disorder is that. So as I said, you do not have to keep all these 600 slides in mind yet. Right now you have to just understand. I am trying to give you the important topics. I'm mentioning these are the important questions. So when you read and reread and just revise, ye sab yaad ho jayega. Don't worry. Okay. Now, to understand immunobullous disorder, you should know how my skin looks like and how the structure looks like. So this is my keratinocyte, as I have mentioned here, and these are the junctions between the keratinocytes, right? And my epidermis is connected to dermis via my basement membrane zone, which is connecting epidermis to dermis. So why does immunobullous disorder happen? Now, if there is an antibody which comes and binds to these desmosomes which are connecting the keratinocytes, these keratinocytes will separate out, and that would lead to an intraepidermal bullous disorder. The space will be created, that space will be filled with fluid, and you develop vesicles and bulla on that area, right? The second thing that can happen is my antibodies can form against various structures in that basement membrane zone. Now, if my antibodies are formed against various structures in basement membrane zone, my epidermis and dermis will split apart, right? And there will be again space which will get filled with fluid, right? So there are two areas where my antigen antibody complexes can form, either in between the cells in the epidermis or in the junction between epidermis and dermis. Clear? Now, so broadly I divide these immunobullous disorders into either intraepidermal disorders or subepidermal disorders. Clear? So intraepidermal disorders are the ones where the antibody is targeting the antigen which is there in desmosomes, which is there in the epidermis only. I remember I told you desmosomes connect the various keratinocytes, and desmosome is a complex structure in itself. तो उसके against कोई भी antibody बनेगा तो cell separate हो जाएंगे, वहाँ जगह बन जाएगी, वहाँ vesicle या bulla बन जाएगा. So that will be called my intraepidermal disorder, whereas subepidermal disorders would be when my target antigen is something in the basement membrane zone, right? So here there will be a split between epidermis and dermis. So I will have a subepidermal lesion. So here my vesicles and bulla will be subepidermal, whereas here it will be inside the epidermis, so I call it intraepidermal. So my intraepidermal disorders are called as pemphigus group of disorders, and subepidermal are called as pemphigoid group of disorders. So pemphigoid and pemphigus, okay, as intraepidermal and oid in subepidermal. Clear? This is clear? Right? Are you with me? I think my chat is getting blocked. I'll reconnect. Right, good. So now few other things that you need to remember. If it is an intraepidermal disorder, that means the split is in the epidermis. So my bulla is really relatively superficial. So here I get flaccid bulla. What do you mean by flaccid? एक balloon है, if you fill it with water and it is very tight, it is called as tense. But if some amount of water is released and then you have that loose subballoon, that is called as flaccid. Okay, so my intraepidermal vesicles and bulla are flaccid, whereas my subepidermal bulla are tense. Why are they tense? Because they have a whole epidermis overlying them. So it is a thick epidermis. So here I have tense bulla, here I have flaccid bulla, right? So till now, for now we will remember this. So intraepidermal we will move on to. Now, not to make you afraid, but this is how my desmoglein looks like. So my desmoglein, which was connecting the keratinocytes, seemed like a simple line, is actually a complex structure which has lot of antigens. And depending on what antigen is being targeted, we have different type of intraepidermal or pemphigus group of disorders. We will not need to remember everything, but we'll just remember the important ones. So in my desmosomes, if desmoglein 1 is affected, I get pemphigus foliaceus. So 1 is first, so first for foliaceus. Remember this. If my desmoglein 3 is affected, I get something which I call it pemphigus vulgaris. Vulgaris is common, right? So common is vulgaris and desmoglein 3. There are two others that you need to know, just need to know their names broadly. So, desmoplakin, P for plakin, P for paraneoplastic pemphigus, and desmocolin, which is IgA pemphigus. Now, the most important for you are these two, desmoglein 1 and desmoglein 3, right? Now, so I will talk about them. Before moving on, just let me make you understand that how does it work. Now, desmoglein 1 and desmoglein 3 are part of desmosomes, but these desmoglein 1 and 3 are unequally distributed. For example, if I am talking about skin, there desmoglein 1 is there all throughout, whereas desmoglein 3 is only on the lower layers. In mucous membranes, desmoglein 3 is very little, only on the superficial surface, desmoglein 1 sorry, and desmoglein 3 is present throughout the mucosa. So why am I telling you this? Because if there is a disorder in which desmoglein 1 is being affected, so here if I look at the mucosa, mucosa has predominantly desmoglein 3. Desmoglein 1 is only there in the upper layers where desmoglein 3 is also there. So, desmoglein 3 will compensate, and so a disorder with desmoglein 1 will have no mucosa involvement, right? However, if there is a disorder with desmoglein 3 involvement, desmoglein 3 is present all over the mucosa. So, if this is gone, my mucosa is gone. So, I will have mucosal involvement. Okay, this is called as desmoglein compensation theory. So, what do I mean by that? If there is one desmoglein present, whether 1 or 3, it takes over the function of the other one. So, यहाँ पे mucosa will not be involved if it is desmoglein 1 only. But if desmoglein 3 goes, I will have mucosal involvement, right? This is what you need to know, and this is called as desmoglein compensation theory. Now, we will move on to specific disorders. So, this I already told you, there is vulgaris, there is foliaceus, there paraneoplastic. Nobody is going to ask you the classification per se, but they are going to ask you this. So, I have in pemphigus group two very, very important disorders which I should be able to differentiate between. One is vulgaris and one is foliaceous. Now, few things we have already discussed. In vulgaris, what is my target antigen? Desmoglein 3. In foliaceous, desmoglein 1. So, F for first, remember this. Now, also remember that in vulgaris, desmoglein 1 may also be affected, but the more common antigen is desmoglein 3. Now, if I go back to this thing, you would see that desmoglein 3 is present in lower layers on the skin here, whereas desmoglein 1 is more on the upper layers of the skin. Okay. So, if my desmoglein 1 is targeted, the split happens on the upper layer because the upper layer was predominantly desmoglein 1, वहाँ desmoglein 3 नहीं था. तो अगर desmoglein 1 को target किया जाएगा, then the upper layers of my skin will be affected. So, I get a split which is subcorneal split, whereas in vulgaris I get a suprabasal split. What do I mean by that? Vulgaris में नीचे desmoglein 3 is predominantly lower. Lower means in the basal layer. So, I have a split which is around the basal layer, above the basal layer. Whereas in foliaceous, I have a split which is much above, which is in the stratum corneum, just below the stratum corneum, and that is why it is a subcorneal split that I see. Okay. Clinical features I will explain with the help of diagram, but here in vulgaris, I see mucosa is always affected, whereas I just told you in foliaceous there is no mucosal involvement because desmoglein 1 is present in a very little quantity. In foliaceous in skin, I see more of seborrheic distribution, whereas vulgaris predominantly presents in the flexures. Okay. So, these are some of the important differences and we will come back to this once we see the pictures. So, this is how pemphigus vulgaris will present to us with. So, few things we have already known. Vulgaris is desmoglein 3 more than desmoglein 1. It is an intraepidermal disorder. How does a patient presents to you with? Patient will have mucosal involvement always in 100% of the cases. So, in the question they will mention whether mucosa is involved or not, and you see okay, great, you see non-healing painful erosions in the mucosa. So, non-healing painful erosions in the mucosa is a feature of vulgaris. Along with this, in skin I see flaccid bulla. So, this is how the patient presents to you with. So, there are flaccid bulla, and jab ye bulla, when it ruptures, it will leave erosions. So, if I am given in the question flaccid bulla with mucosal involvement, only think of pemphigus vulgaris. Clear? These are the two most important things to diagnose pemphigus vulgaris. There are some signs which we will talk about. But let's look at pemphigus foliaceous now. So, now what happens in foliaceous is, I told you it is the target antigen is desmoglein 1, it is very superficial. So, I have a subcorneal bulla. There are so many layers in the skin and the bulla is just, the roof of the bulla is just formed by stratum corneum. So, it will be so thin, so it will rupture off easily. So, here the subcorneal bulla is there, but they rupture off very easily. So, what do I see? I see only crusted erosions in seborrheic distribution. So, I hardly see a bulla here, plus I have no mucosal involvement, right. So, in foliaceous, remember desmoglein 1, crusted erosions in seborrheic distribution and no mucosal involvement. However, they give you vulgaris most commonly, but you should know this. Clear? So, this is how my foliaceous will present with crusted erosions. Hardly any bulla. Then there is a sign which someone was also referring to, which we do in these intraepidermal disorders. This is called as Nikolsky sign. Now, I told you that there are antigen-antibody complexes which are being formed. Now, wherever these antigen-antibody complexes are a lot, there I will form a bulla, but in the surrounding skin also now they are binding. Antigen antibody complexes are being bound, and it is possible that there the bulla has not been formed. However, the skin has been weakened there. So if I apply a tangential shearing force in the skin around a bulla, my skin peels off or forms a bulla. So this is Nikolsky's sign. Okay, so meaning of seborrheic distribution, sorry, I know I did not mention that. Seborrheic distribution is areas where you see sebaceous glands, so more on trunk, upper chest, face. So these are my seborrheic distribution. Okay. Now, so Nikolsky sign is when you apply a shearing force on the skin peels off like this or forms a bulla. So if my Nikolsky sign is positive, that means my disease is active. And Nikolsky sign is positive only in intraepidermal disorders. Because subepidermal disorders में जो roof है, that is complete epidermis, which you cannot shear off by just tangential force. So this is important. Nikolsky sign is positive in intraepidermal disorders. Clear? Now, there are two other Nikolsky that you should be knowing. So this is true Nikolsky. True Nikolsky is seen with pemphigus group, and we just discussed with staphylococcal scalded skin syndrome. However, in subepidermal disorder also, sometimes Nikolsky may come out to be positive, but if it does, I call it as false Nikolsky. In certain drug reactions, the skin also peels off on the shearing force, but there it is peeling off because drug has caused keratinocyte necrosis. It is not because of antigen antibody complexes, and so I call it pseudo-Nikolsky. Okay, so false is subepidermal because it should not happen there. So if I ask you Nikolsky sign is positive in subepidermal disorder, that statement would be false. So if you see Nikolsky there, we call it false Nikolsky. With drug reaction, we call it pseudo-Nikolsky. Clear? So Nikolsky sign is something that you should be knowing about. Then there is briefly, there is a bulla spread sign. Bulla spread sign is if there is a bulla and you put pressure on it, the bulla spreads. So that is bulla spread sign, and this can be positive in intraepidermal as well as subepidermal disorders both. But Nikolsky is in intraepidermal disorders only. Right? Now next, if I have a patient of pemphigus group, I will do a biopsy. Now what will I find in biopsy? I will do a Zang smear also, but let me just see. Okay. Two things that I will do first. I will do a Zang smear. I told you about Zang smear in herpes. So what happens is, if you may take a bulla, rupture it, and from the base you make a smear. So it's something like this. If you see in histopathology, this is my epidermis, this is my stratum corneum, this is my stratum granulosum, this is my stratum basale. So what am I seeing here on histopathology? I am seeing a split. You see a split. This is how pemphigus histopathology looks like. And here the split is above the basal layer, and that is why I call it suprabasal split. Right? So on histopathology, I am seeing a suprabasal split. Now, if I make a Zang smear, what am I doing? I am de-roofing this bulla and taking a smear from here. So I get this separated keratinocytes on Zang smear, and these are called as acantholytic cells. Acantholytic cells, or nothing but separated keratinocytes. Right? So separated keratinocytes or acantholytic cells are seen on Zang smear. Since the keratinocytes are now separated, उनके आगे पीछे कोई force नहीं है, so they are larger, they look like this. They have a large nuclei occupying 7-8 cell. So these are called as Zang cells, acantholytic cells, or separated keratinocytes, and this is a feature of pemphigus. In herpes, along with this, you also see multinucleate giant cells, right? So Zang cell, you will see acantholytic cells, and again Zang cell would only be seen in intraepidermal disorder, right? Subepidermal disorder में तो keratinocyte ही नहीं है ना, epidermis and dermis के junction पे separation हो रही है, right? So here you see this, and this is also seen only in intraepidermal disorders. Now coming back to histopathology, so what are you seeing on histopathology? One is you see this split which is suprabasal, and then look at my basal layer. If you look at my basal cells, they are also separated from each other. They are like this. They should ideally be like this, but now they are like this. So this appearance is called as row of tombstone appearance. If you go into a graveyard, you have those tombstones. So this is looking like row of tombstone appearance. So it's like this now. Okay. So a split, a row of tombstone appearance is a feature on histopathology of pemphigus vulgaris. And on Zhang smear, you see these acantholytic cells, right? So this I have already discussed. And if I have pemphigus foliaceus, see, where is the split? This is my stratum corneum, this is granulosum, spinosum and basal. Now you know the layers of the skin. So I am seeing a subcorneal split here. In pemphigus vulgaris, I am seeing a suprabasal split. So on histopathology, depending on the level of split, you can diagnose. Now, sometimes on histopathology, you may not get a proper split, or the split may be extending and you are not sure what it is. And sometimes even in bullous pemphigoid, so you do a biopsy, or sometimes what happens, patient does not have active bulla. So what do you do? So the test which we do in pemphigus group of disorders, which is considered the gold standard of diagnosing of this group of disorders, is direct immunofluorescence. Right? So direct immunofluorescence is considered gold standard of diagnosis. Here you give fluorescent labeled antigen, and when you put that with the biopsy sample, what happens? This fluorescent label thing goes and binds to areas where there are antigen antibody complexes and fluoresce on microscopy. And then what do you see? So you see, so the keratinocytes are all packed, and in between there is all fluorescence, because the fluorescence will go and bind to antigen antibody complexes. So you see a fish net pattern of immunofluorescence here. So direct immunofluorescence you are seeing a fish net pattern. So in between the keratinocytes there are all fluorescence which is seen. Again, a very, very important question. So fishnet pattern, okay. So fishnet pattern is a characteristic feature of intraepidermal disorder, specifically pemphigus vulgaris. Clear? Right? Now, so quickly revising this pemphigus vulgaris group of disorder. So pemphigus vulgaris, I had flaccid bulla, I had mucosal involvement. This is very important because this comes. I had suprabasal split, row of tombstone appearance, Nikolsky positive, and fish net pattern. You can also remember it with the mnemonic MINAR. MINAR, M for mucosa, I for intraepidermal or suprabasal split, N for Nikolsky, A for seeing acantholytic cells, and R for row of tombstone appearance. So MINAR is positive in pemphigus. Remember this. Mucosa, intraepidermal split, Nikolsky sign, acantholytic cells and row of tombstone appearance. These are all very, very important features, and these are, this is what will help you diagnose pemphigus vulgaris. Paraneoplastic pemphigus, you do not need to know detail. It is in itself telling you it is associated with neoplasms, most commonly non-Hodgkin cell lymphoma, and P for para, this is basically plakins are the target antigen here, right? So just know this, it is associated with neoplasms, and plakins, desmoplakin, periplakin, enviplakin are the target antigens here, right? Just quickly, rituximab is a medicine. It's an injectable medicine. Usually for pemphigus, we use oral steroids and immunosuppressants, right? But this is a newer drug. Nobody asks you usually about the treatment, so I am not going into that. But this is an it is a monoclonal antibody. It is anti-CD20 and it is an injection which is used for pemphigus. Just know the name and just know that it is anti-CD20. Okay. Now, moving on to the subepidermal disorders. So, epidermis and then subepidermal disorders. So, subepidermal disorders are also called as pemphigoid group of disorders, but here we also have a condition called as dermatitis herpetiformis. Sorry, I'm just refreshing my chat because it's got stuck. Right. So, dermatitis herpetiformis also comes under subepidermal disorders, right? Here I already told you the antibodies will be against dermoepidermal junction, but dermatitis herpetiformis is different. The target antigen here is epidermal transglutaminase. Epidermal transglutaminase, right? I already explained that here the blisters will be tense and Nikolsky will be negative. So, basically in subepidermal disorders, my MINAR is negative. I do not have mucosal involvement, no intraepidermal split, no Nikolsky sign, no Zank cell and no row of tombstone appearance. So, how does it present to you? So, before going into that, let me now tell you about this basement membrane zone. I told you it is a zone which is connecting epidermis to dermis. So, though it looks like this thin line, it is a complex structure in itself, right? Now, you do not need to remember everything about this complex structure. Just remember this, that my first part is hemidesmosome. Then I have lamina lucida. Then I have lamina densa, and beneath that here, so this is hemidesmosome, lamina lucida, lamina densa and then sublamina densa. Nobody is going to ask you the structure of basement membrane zone. This is for your understanding and understanding the disorders. So, in hemidesmosomes, I have two important antigens, BP180 and BP230, which are associated with bullous pemphigoid, right? In sublamina densa, this is made of collagen 7. And here I have two disorders, EBA and SLE, right? Then the other things you do not need to know, just know that this is how it is and how the different disorders have different antigens at these levels. So, hemidesmosomes BP180 and 230, lamina lucida is where I have laminin, again you do not need to know that. Lamina densa is the thickest part and that is why I told you collagen 4 is what makes my basement membrane zone, and sublamina densa has collagen 7. Right. So, hemidesmosome, lamina lucida, lamina densa and sublamina densa. Now, there are different antigens and through all these antigens, different subepidermal disorders can happen. But for you, what is most important is this bullous pemphigoid, okay, in which the target antigens are BP180 and 230, which is present in hemidesmosomes, superficial part, right. And for DH, for which I told you, it is epidermal transglutaminase, which is the target antigen here. Okay. Rest all will come in between, mucous membrane, pemphigoid and all. Only these two, EBA and bullous SLE, which is epidermolysis bullosa acquisita and bullous SLE, they are present in lowermost layer. So, they have collagen 7 as the target antigen and they are present in the lowermost layer. So, sometimes they ask you the order. So, pemphigus foliaceus is first, followed by vulgaris, then bullous pemphigoid and then EBA and SLE. Okay. Now, since bullous pemphigoid is most important, I am going to talk about that first. So, bullous pemphigoid is the prototype of my subepidermal disorders. We have already discussed about lot of features, few things. It will be seen in elderly patients. So, you would usually get a 60 years old or 80 years old. Then, bullous pemphigoid can have a pre-bullous stage. That is, before the bulla appears, the patient may complain of itching and urticarial lesions. Then it has tense bulla. Mucosal involvement is not common, seen in only 30%, so it's not very common, right? So, tense bulla, old age, pre-bullous stage, if there is history of any itching or urticaria, then you think of bullous pemphigoid. So, this is the pre-bullous stage which is presenting with urticaria or erythema or itching. So, the patient comes with these patches and eventually the patient develops tense bullae on these patches. So, tense bulla preceding itching erythema in elderly patients with no mucosal involvement, negative Nikolsky, no Zank cell positivity, think of bullous pemphigoid. Clear? So, this is what you need to know, the difference between them. I know they are making it difficult. So, the whole idea is they are asking you difficult questions now. So, that is why I am skipping the difficult part, but this is something which you should be knowing. Okay, great. Now, so I already talked about this. If you do a histopathology, if they give you a histopathology image, so you would see कि हमारा पूरा epidermis ऊपर है and the split is happening below the epidermis. So, it is a subepidermal split that you see, right? Subepidermal split is seen. Clear? And if you do a DIF here, what will happen? You will see linear deposition of IgG and C3. So, there is no fishnet pattern here. Just at the level of dermoepidermal junction, you will see fluorescence which is linear deposition. Clear? So, you can easily now differentiate between bullous pemphigoid and pemphigus group. Tense bulla, flaccid bulla, Minard negative, subepidermal split on DIF, linear deposition. Clear everyone? This you should know. Pemphigus vulgaris, bullous pemphigoid, right? And the third important, so this we will not need to know. Third important thing in this group of disorders is dermatitis herpetiformis. This is what you should be knowing. Just orally telling you, I am not covering that because I don't think so it's very relevant. Pemphigoid gestationis is just bullous pemphigoid happening in pregnancy. I'll go back and just show you the image here. So, when I say pemphigoid gestationis, it is just bullous pemphigoid in pregnancy. So, if you are given a pregnant patient with itchy urticarial lesions around the umbilicus which eventually develop tense bulla, you know that this is pemphigoid gestationis and this is nothing but bullous pemphigoid in pregnancy, right? Okay. Moving on to the next important group of subepidermal disorders which is asked, which is dermatitis herpetiformis. Now, this is peculiar. This is peculiar because one, its target antigen was different. It was epidermal transglutaminase. Epidermal transglutaminase. Then second, though it is a subepidermal disorders, you do not see any bulla here. There is no bulla here. So, clinical manifestations is absolutely different. Third important thing, it is associated with gluten sensitive enteropathy. So, typically in the history you are given some history of GI symptoms or gluten sensitive enteropathy, right? Gluten sensitive enteropathy, no bulla. So, how does it present? It presents on extensors with itchy excoriated papules. So, if you have an image like this where the lesions are present on extensors, itchy excoriated papules, it is a recurring condition and there is some history of celiac disease given which is gluten sensitive enteropathy, think of dermatitis herpetiformis. So, there is nothing related to herpes here. Okay. So there is no bulla that you see just extensors, each excoriated papules, association with gluten sensitive enteropathy, and look at the DIF here. On DIF you see papillary tip immunofluorescence. So if you see papillary tip immunofluorescence on DIF, so all the 3 DIFs were different. One was that fishnet pattern, then other was linear, and this is just papillary fluorescence. Clear? How do you treat DH? This you will tell me. This is important, that's why I am asking you the treatment. Come on. Sorry, my chat is also getting. Okay. Very good. So only thing that you need to remember is you have to give Dapsone and you have to give gluten-free diet. And when I say gluten-free diet, somebody mentioned iodide. So iodine is for provocation. If you're not sure if it is dermatitis herpetiformis, you give iodine to the patient. And iodine will increase the problem, and that is iodine provocation test, hardly asked. What is asked is this. So you give Dapsone and you give gluten-free diet. Now what is gluten-free diet? You have to avoid bro. That is barley, rye, oats and wheat. Then what is allowed? You can give MR, which is maize and rice. So maize and rice are allowed, bro is avoided, and you give Dapsone. So D for dermatitis herpetiformis, D for Dapsone. Okay? Remember this. And gluten-free diet is very, very important. So you have to avoid bro, that is you have to avoid barley, rye, oats and wheat, and give maize and rice. Clear? So no prednisolone here, nothing, you just need these two. And the patient improves significantly. Okay? Clear? Anything that you did not understand in immunobullous disorders, kindly tell me before I move on to hair disorders. So in immunobullous, you have to know how to differentiate between vulgaris and foliaceous, and you should also know how to differentiate between pemphigus and pemphigoid group of disorder. Remember MINAR and it would help you. Right. Any questions on immunobullous? What is Dapsone is an oral drug which is used to treat multiple skin conditions. It's also used in leprosy. You will learn about details of Dapsone in pharmacology. No, Koebner's and bulla spread are absolutely different. Bulla spread is if you have a bulla and you press on the bulla will spread. So this is, I can draw here, maybe okay, I'll draw here. So if there is a bulla and you apply a pressure on bulla, what will happen is, if this was my bulla, the bulla will spread like this. That is bulla spread. Koebner's is when you scratch, you develop lesions of similar morphology there. So it is different. Bulla spread is seen in pemphigus group of disorders. Koebner's is seen in psoriasis, lichen planus and vitiligo. Absolutely different conditions. Right? Any more questions on this topic? Okay. So, okay. So, I understand that mucosal involvement with respect to desmoglein was. So, just remember, okay, you do not need to know the details. Just remember, in foliaceous, you do not see mucosal involvement. With vulgaris, there is mucosal involvement. Okay. This is what you need to remember. I was telling you the reason behind it, but that's okay. So, foliaceous, no mucosal involvement, and in vulgaris, always you have mucosal involvement, right? So, quick recap of this topic. So, I have done multiple quick recaps. Vulgaris and foliaceous. Vulgaris, flaccid bulla with mucosal involvement. Pemphigus, foliaceous, only crusted erosions, no mucosal involvement. Pemphigus foliaceus, desmoglein 1, pemphigus vulgaris, desmoglein 3. In pemphigus group of disorder, you see a suprabasal split, vulgaris, and you see Zang cell, you see acantholytic cells, and there is a positive Nikolsky and row of tombstone appearance on biopsy. In pemphigoid group, which is bullous pemphigoid, you have tense bulla, you have elderly patients, you have a pre-bullous stage, you do not have positive Zang cell, no Nikolsky positive, no row of tombstone appearance. So, you would see just subepidermal split and you would see linear deposition on DIF, right? So, Minar is also for foliaceous? No, Minar is mainly for pemphigus vulgaris because you do not see mucosal involvement in foliaceous. The prototype of pemphigus group of disorders is vulgaris. So, we always compare with vulgaris. Okay? Nicotinamide is not compulsory. Seborrheic areas, yes. So, in pemphigus foliaceus, which was associated with desmoglein 1, we see involvement of mainly seborrheic areas, which are my upper part of the trunk and face. Okay? Anything else? Good. So, we will move on to the next group of disorders, which is hair disorders. So, now we are moving to appendages. So, I told you that skin appendages are hair, nail and glands. So, we will talk about disorders which are associated with hair, nail and glands now. Okay? So, hair disorders, quickly, this is how my hair looks like. Nobody is going to ask you structure, so I am not going to tell you that. Just wanted to tell you that the hair that you see is this, but the hair follicle is deep down. Okay, so hair comes out from this, but this is my follicle, and here in the follicle are the stem cells for hair from which the new hair forms. So, stem cells are in the hair bulb. Okay, so this is the hair bulb and this is where my stem cells are, right. Now, this is important. A hair which starts to grow. Okay, any more questions? Fine. So, the hair which starts to grow does not grow forever. So, a hair in my scalp goes through cycles and there are 3 stages in this cycle: anagen phase, catagen phase and telogen phase. So, a hair which starts growing first goes into the anagen phase. So, we will forget about catagen because this is not asked. So, a hair which is growing grows into the anagen phase. So, this is the growth phase. So, it stays in this growth phase for 2 to 3 years, and after which it goes into the telogen phase, which is the stage of falling. So, this is my falling phase. Once it goes there, it stays for 2 to 3 months in this stage and then falls off. So, a hair which is growing will grow and then go into the telogen phase, stay there in 2 to 3 months and then fall off. That is why after shampooing, when you are combing, you see some hair falling, that is normal, and once it falls, look at it here, anagen, catagen is just a transition phase, telogen. Once it falls, the new hair follicle at the same place starts to form new hair and it goes back into the anagen. So, hair is always following a cycle. It is not constant, it is not like one hair will grow forever. So, it will go into the falling phase, fall, and from the same root a new hair will come in. Right. Normally, 90% of my hair are in the anagen phase and almost 9% are in the telogen phase. So, 9% of hair are falling and 90% hair are in the growth phase, right. So, this you need to know that there are 2 main phases, anagen and telogen. Now, when we talk about hair fall, so hair fall is called as alopecia or hair loss is called as alopecia. Okay. Now, this alopecia or hair loss is divided into 2 categories: cicatricial and non-cicatricial. What do I mean by that? Cicatricial means scarring. What does this mean? When my stem cells are affected. I told you there are stem cells on the hair bulb from which the hair is forming. If my stem cells are gone, my hair cannot form. That is called as cicatricial alopecia. So, some disorders go and target the stem cells, in which case the hair is completely gone and I cannot form new hair. However, most of the times this does not happen and my stem cell is not targeted. The other parts of the hair are targeted and that leads to non-cicatricial or non-scarring alopecia. So, the more commoner ones are non-scarring, thankfully, and that is what is asked in the exam, right. Now, you should know what are scarring and non-scarring. So, when we talk about non-cicatricial or non-scarring alopecia, I am talking about the causes of hair loss where my stem cells are not getting affected. Okay. Now, stem cells, telogen is not resting. Yes, telogen is the resting phase or falling phase. We call it more commonly falling phase. Okay. Now, so when we talk about non-scarring alopecia, there are three main kinds. The hair can fall in patterned distribution when I call it androgenetic alopecia. It can be diffuse hair fall, सारे बाल गिर रहे हैं. Then it is called as effluviums, or it can be patchy alopecia where I have just a patch of hair loss. So, it can be patchy alopecia. Now, patchy alopecia can be alopecia areata, trichotillomania, tinea capitis can lead to patchy alopecia. We saw grey patch, black dot, there was patchy alopecia, or there is a alopecia called as moth-eaten alopecia that you see in syphilis. You can forget about that. So, these are my important causes of non-cicatricial alopecia. Now, there you are asked all causes non-cicatricial alopecia except, so you know. So, androgenetic is pattern, diffuse is effluviums and patchy are these. Now, we will talk about each one of them and then you would know the differences. So, androgenetic alopecia is something which you have seen very, very commonly. It is also called as male patterned baldness or female patterned baldness. So, it can affect both male and females, and so it is called as patterned baldness because there is a particular pattern to it. It is androgenetic. So, there are two main reasons. There is a genetic factor. So, you see a family history and there is androgen. So, what is the classical, what is the main androgen which is getting affected here? So, it is the DHT which is causing the effect here, I am sorry. So, what happens, testosterone under the influence of 5-alpha reductase gets converted to dihydrotestosterone, and this DHT what it causes is it converts my thick pigmented hair into short fine hair. Okay. So, my culprit here is androgen and genes. Genes, that is by family history, and androgen is dihydrotestosterone. This is converting my thick pigmented hair into fine short hair, right. So, androgenetic alopecia due to this, and what is the kind of alopecia that you see? There is a pattern to it. So, all male patients will present with a particular pattern, and what is that pattern? First, there will be recession of this frontotemporal line. You would have seen that in your father, grandfathers, uncles. So, frontotemporal recession here and then vertex balding. So, there is a pattern. So, this is my frontotemporal recession and vertex balding. So, you are a lot of time given an image like this and you have to identify the type of alopecia. So, if you have frontotemporal recession and vertex balding, you call it male pattern hair loss, and there is a staging to it which was given by Hamilton and Norwood. So, because obviously a patient will not land up with complete hair loss. So, there are stages, stage 1, stage 2, stage 3, then vertex goes. So, this was given by Hamilton and Norwood, and so it is called as Hamilton and Norwood staging. Remember, this kind of hair fall is very gradual, painless, not associated with any scaling, nothing. Just the patient is losing hair density in this particular pattern, right? Now, what happens in females? In females, the pattern is different. In females, you see widening of central parting. So, remember, in androgenetic alopecia, it is not the hair fall per se which is happening, but decrease in density. So, in females, it happens here. In females, there is widening of central parting. So, this area becomes scanty. This grading is called as Ludwig's pattern or Ludwig's grading. So, by the time you reach grade 3, there is a Christmas tree pattern that forms. So, we studied Christmas tree pattern in Pitriasis rosea, and this is the second condition where I see Christmas tree pattern. Okay, so grade 3 of female androgenetic alopecia is also referred to as Christmas tree pattern, right? So, patterned alopecia, genetic factor, DHT. How do you treat? So, the management involves counseling, that it requires long-term treatment, and then there are two major agents that we use. One is topical minoxidil, which is used 5% in males and 2% in females, right? Then we use 5-alpha reductase inhibitors, which is finasteride, only in males. In females, you can use anti-androgens like aldactone, right? So, but the mainstay of treatment, if they ask you, if they give you this patterned alopecia, you have to write minoxidil and finasteride. Minoxidil and finasteride, and minoxidil 5% in males, 2% in females. Clear? So, you should be able to identify AGA, know its treatment, and know the different patterns that you see. Okay? Now, moving on to the second type of non-cicatricial alopecias, which was effluvium. So, in effluviums, we have two categories. Effluviums can happen with anagen hair or with telogen hair. Okay? Now, this is short, so I will cover this first. Anagen effluvium would mean when the hair in the anagen phase are falling. When would that happen? Anagen is the growth phase, so it is the actively dividing phase, right? So, when a patient is given chemotherapy, chemotherapy targets all actively dividing cells, so it also targets my anagen hair. So, since anagen were 90% of hair, so 90% of hair are lost. So, chemotherapy when given, patient, you all know that after chemotherapy there is lot of hair fall that happens. That is called as global alopecia, and that is because my chemotherapy is targeting the anagen phase of the hair follicle, and so that is called as anagen effluvium, right? Then what is telogen effluvium? Telogen effluvium is whenever your body goes through any kind of stress. So, whenever there is any kind of stress, which can be any surgery, in prolonged infections, pregnancy. So, in this case, there is premature conversion of anagen into telogen. So, because of stress, the anagen hair goes into telogen. So, whenever there is stress, these 90% hair, a significant chunk of that will go into telogen. Then they will stay in telogen for 2 to 3 months, and then the hair will fall. So, here I have a history of insult which is happening, and 2 to 3 months after that I have significant hair fall. So, this is telogen effluvium, and the question that is given to you is something like that a patient of dengue, chikungunya, COVID or whatever, a patient undergone surgery presents to you 2 to 3 months later with significant hair fall. So, what is the diagnosis? The diagnosis is telogen effluvium. What do you do here? You do counseling. You have to just counsel the patient and give them certain multivitamins like biotin. Okay. Now, why do you do that? Because see, the hair has gone into the telogen phase. It has to fall, but you have to counsel that once the process stops, these hair will again go back into the anagen hair and grow again. So, here you only need counseling and biotin. right? With androgenetic alopecia, it was minoxidil and finasteride. With telogen effluvium, it is counseling and biotin. Yes, PRP is done, but we will not discuss it here, right? Clear? Okay, so no personal questions please. Let's not spam the chat box with personal questions. For that, we can discuss later. So telogen effluvium, next type of non-cicatricial alopecia I told you was patchy alopecia. So most important in patchy alopecia that you should be knowing is alopecia areata. Alopecia areata has two A's. It is associated with autoimmune conditions. So this is an autoimmune disorder, which is T cell mediated autoimmune disorders, and so it is associated with other autoimmune disorders like Hashimoto's, pernicious anemia and other things. So if you are given an association with other autoimmune disorders, think of alopecia areata. Now what is happening in alopecia areata? Here my T cells are coming and targeting my hair, and that is why the body loses hair at that particular patch where the T cell are being targeted. So what do I get here? I get patchy alopecia, which is totally asymptomatic, no itching, nothing, and here there is no scaling. I have a very smooth surface. So this is the typical appearance of alopecia areata, a smooth patch of alopecia. You see no scales here, totally smooth surface. And another important sign that you see is grey hairs are preserved. Alopecia areata, in alopecia areata, grey hairs are not targeted. So sometimes you are given a patch where you see these preserved grey hairs. That is another sign that it is a case of alopecia areata. Right? You can have single patch, you can have multiple patches, but all these patches are very smooth, bald patches which are totally asymptomatic. Now sometimes what happens, this alopecia areata is very severe and patient loses lot of hair together. So in that case, what happens, only the grey hair of the patients are preserved, and that is called as turning grey syndrome. So the patient comes to you and says that I have turned grey overnight. It's not that he has turned grey overnight, it is just that he has lost all his black hair because of the autoimmune process. Right? So here in alopecia areata, know that it is an autoimmune disorder, it presents with this kind of patch, and then there is a sign which is associated with it. If you take a dermoscope and you see at the periphery of lesions, you see exclamation mark hairs. You see exclamation mark hairs. What are exclamation mark hairs? Now this is my hair follicle, right? Here were my stem cells. Stem cells are not being targeted. My T cells start to target hair. So it forms something like this. So it looks like exclamation mark hair. So on the periphery of lesions, you see exclamation mark hair. Another very important question. So alopecia areata is associated with exclamation mark hair. If you do a histopathology, what do you see? Alopecia areata is sustained or temporary hair loss would vary. In some patients, you actually see hair growth happening back and you do not need to treat. But in some in which autoimmune process is greatly hampered, you can see a sustained thing also. Right? Now, if you do a histopathology, since it's a T cell mediated disorders, you see lot of lymphocytes which are targeting the hair, and this is called as swarm of bees appearance. So swarm of bees appearance is nothing but lot of lymphocytes which appear like bees around the hair follicles. So exclamation mark hair, swarm of bees appearance. So alopecia areata can affect great areas. Sometimes total hair loss may occur all over the body, in which case we call it universalis, when your whole body hair are also lost. Sometimes only the scalp is affected, in which case I call it alopecia totalis, when all my scalp hair are gone. Right? So it can vary from severity from single patch, multiple patch to universalis or totalis, and it can also affect eyebrows, eyelashes or beard area. So any of these may be affected in alopecia areata, it's not just the scalp. Right? There are two nail findings also which are associated. So if you look at the nails of patients of alopecia areata, you see pitting. What is pitting? Pitting are these depressions. But when you look at these pits, they are very, very small geometric pits, right? So, pitting, what is globalis? So, small geometric pits is something that you see with alopecia areata. So, grey hair are spared because the immune process is actually targeting the pigment in the black hair, which is not there in the grey hair, okay? That is why. So, you see pits which are small geometric pits in alopecia areata. How do you treat alopecia areata? Since it is an autoimmune disorder, I have to treat it as an autoimmune disorder. So, the treatment of choice is intralesional steroids. So, if I have like 1 or 2 patches or up to 5 patches, I will just inject some steroids intralesionally in that area so that that can take care of inflammation which is targeting that area, and we are done with. However, if it is a very severe case of alopecia areata, universalis, totalis, then you give oral corticosteroids. Apart from intralesional steroids, contact immunotherapy is also used in alopecia areata. These are agents which when applied generate an irritant reaction and help treat alopecia areata. Okay, so you should know how the treatment of each kind of thing varies and what is the sign which is associated with it. So, for alopecia areata, remember intralesional steroids and contact immunotherapy, right? Okay. Then next in patchy alopecia that I was telling you was trichotillomania. Tricho is hair, mania is mania, some psychiatric disorder. So, this is a patchy hair loss. Here the patchy hair loss is associated with some psychiatric illness. So, this psychiatric illness can be mild behavioral modifications or some societal modifications that can happen in a patient. So, in the question they may give you something which is pointing towards a psychiatric illness. Now, due to psychiatric illness, patient does not know and just plucks hair from one side of the scalp. So, he is sitting and thinking and does not realize and is plucking the hair from one side of the scalp. Now, since this force is external, what happens? Patient develops patchy alopecia, but this alopecia is different from alopecia areata because here you see hairs of various lengths. So, you see broken hairs of various lengths here, right. So, you see this is not a smooth patch and you are seeing hair which is of various lengths because of unequal force which is being applied by the pull of the patient. So, trichotillomania, mania, so there will be some psychiatric association, and tricho is hair and hair are being pulled by the patient. So, broken hair of various lengths, if written in the question or seen in the picture, think of trichotillomania. And since it is a psychiatric disorder, you have to treat the patient with cognitive behavioral therapy or antipsychotic medications. Now, sometimes what happens is because of the pulling, you can also see hemorrhages around the follicles. Okay, and the sign, this hair of broken hair of various lengths, is called as Friar Tuck sign because there was a character who had this kind of hair. Sometimes these patients not just pull their hair, they also eat their hair, leading to trichobezoar and can lead to GI obstruction also. Okay, so some psychiatric illness with trichobezoar, with hair of broken hair of various lengths, think of trichotillomania. Right, now this is here I am winding the non-cicatricial, so I will quickly revise. Pattern loss, androgenetic alopecia, you see this pattern, you give minoxidil, you give finasteride. Then effluviums, anagen effluvium associated with chemotherapy. Telogen effluvium associated with some insult 2 to 3 months prior to hair fall, significant hair fall but improves with counseling and biotin. Alopecia areata, patchy, smooth patch, asymptomatic, no scaling, autoimmune disorder, exclamation mark here, give intralesional steroids. Trichotillomania, psychiatric disorder, hair of various lengths, and you give antipsychotic treatment. Then in patchy alopecia, I also said tinea capitis. So tinea capitis can also present with patchy loss, but there you would either see scaling or you would see black dot. And if you do a KOH, it would be positive. Clear about non-cicatricial alopecia? This is important. So brow hair loss during chemo would be anagen effluvium only, okay, not alopecia areata, right? Now, cicatricial alopecia, you just need to know some names which are important. So, in cicatricial alopecia, what is happening? Stem cell is gone. So, here you will not see hair growth happening and there would be scarring on the scalp which would be seen. There are few important conditions where this can happen. It can happen with lichen planus and DLE or discoid lupus erythematosus. Right, these are two conditions which present with cicatricial alopecia, not going into the details, and this is the third one which you need to know. So, a third condition which presents with scarring alopecia. Now, look at the image, the scalp looks all scarred, the hair will not come back here. So, this is pseudopelade of Brock. You should know two things, it is a cicatricial alopecia, and here there is a pattern that you see. It seems as if somebody has walked on snow. So, it is called as footprints in snow appearance. Footprints in snow appearance is seen with pseudopelade of Brock, which is a type of cicatricial alopecia, right? So, because the image looks like as if somebody is stepping foot on snow. Clear? Okay, hirsutism we will just cover quickly. Hirsutism means increased hair growth in areas where you are not needed. So, it is seen in females obviously, and increased hair growth on face of females, hirsutism. Think of hormonal reasons here. So, you have to think of PCOD, congenital adrenal hyperplasias and other disorders which can lead to proandrogenic features in a female, right? That finishes our hair disorders, and I'll move on to the next. Any confusion with alopecias? Alopecias are very, very important and you should be knowing about them. So, if you are confused about any kind of alopecia, please ask me now. Okay, so I guess you are all clear about it. So, we will move on. Moving on to nail disorders, you do not need to know much about nail. I will just cover the important topics. Buse lines in nails is something similar to what you see like telogen effluvium in hair. So, Buse lines are these transverse lines that you see in the nail, and they also represent temporary arrest in nail production. So, if the patient has gone sick or had some problem at that time, nail will not form, and so it will leave these transverse grooves on the nails which are called as Buse lines. Okay. Then you should know of something called as tracheonychia. Tracheonychia is nothing but total nail dystrophy. So, if you are given an image like this where you feel, not total, 20 nail dystrophy, where you see all these nails being affected, showing ridging, destroyed nails, think of tracheonychia or 20 nail dystrophy. Here the most important reason is it is seen with alopecia areata and lichen planus. Okay, tracheonychia. Onychia is nail, trache is damaged nails. Then you should know about this thing. Pterygium is this wing shaped fold. This is my proximal nail fold. It is causing a fold which is extending to the nail plate. This is pterygium and this is seen with lichen planus. Okay. Then there was a question on this. What is paronychia? Paronychia is swelling of nail folds, swelling and infection of nail fold. So this was an image which was given. So if you see a nail and you see an infection on the nail folds, this is paronychia and this is bacterial in origin. This is a bacterial infection of the nail fold. How do you treat? You give oral antibiotics. So when this nail folds, they become swollen, they become inflamed, they become infected. It is called as paronychia and it is bacterial in origin, and you give oral antibiotics, right? That's it about nails. So 2-3 slides. Now we'll move on to disorders of glands. Okay, I don't think so there will be any question in nails. Cicatricial alopecia is permanent. Yes, cicatricial alopecia, see, if the area has scarred, you cannot grow back hair there. So the treatment is aimed as not increasing the area of cicatricial alopecia. So if a patient has LP, DLE, you will treat because you do not want that cicatricial alopecia to increase, right? Hirsutism, yes, you are right. The scoring for hirsutism is Ferryman and Galway scoring. Just know the names. You do not need details of those scorings. So, Dr. Basit, causes for what? What do you want to know the causes for? Kindly elaborate. Okay. So, when I say disorders of gland, okay, what is this? Country looks green since. Is that a mnemonic that you're helping me out with? Yeah. So, I'll move on to this, and since there are no, so there are different types of glands in my body and they can all get affected in different types of disorders. So, broadly the glands in the body are divided into sweat glands and sebaceous glands, right. Now, when I say sweat glands can be either eccrine or apocrine. So, broadly I divide my glands into sweat glands and sebaceous glands. Sweat glands are further of two types, eccrine and apocrine. Okay. Now, just briefly, what is the difference? So, first we are talking about sweat glands. Sweat glands are of two types, eccrine and apocrine. Just remember this image. So, this is my eccrine gland opening directly into the skin surface, right. This is my apocrine sweat gland. It is opening into the hair follicle. So, what are the broad differences? So, eccrine glands are my major sweat glands. When I sweat, it is because of eccrine glands. So, eccrine glands are located all over the body, right, and more on palms and soles. I sweat a lot from palms and soles when I am anxious or anything. Apocrine glands are not a very important sweat glands. They do not help in sweating. They are mainly present in where? Axilla, groins and other places, right. Eccrine glands have eccrine secretion. So, there are three kinds of secretion, eccrine, apocrine and holocrine. So, eccrine is, suppose this is my gland. So, glands are what? Glands are systems which will secrete something. So, there can be eccrine secretion when it forms small vesicles and these vesicles discharge the contents of gland out, or apocrine when the apical part of the gland is shoved off, and holocrine when the whole cell compromises and discharges its content. So, eccrine gland has eccrine secretion, apocrine gland has apocrine secretion. Eccrine gland opens directly into the skin, whereas apocrine gland opens into the hair follicle. Okay. It has adrenergic innervation. This has cholinergic innervation. Now, eccrine glands are the most important because they are helpful in thermoregulation. My body temperature is maintained by eccrine glands, whereas apocrine glands are important for body odor, right. The eccrine glands, the onset of activity happens in infancy, whereas apocrine glands become activated on adolescent age group. So, for A you have all A's, they are in axilla, they are apocrine, they are adrenergic and they get activated on adolescent, right. So, this is broadly about eccrine and apocrine. So, Dr. Shalini, that is ingrown toenail when your nail grows and grows inside the skin fold and causes pain. So, that is called as ingrown toenail or also called as onychocryptosis. Yes, all A's are androgen with apocrine. Right. Now, few disorders of sweat glands that you need to know. One is malaria. Malaria is when my sweat duct gets blocked. Whenever there is blockage of sweat duct in the epidermis, we call it malaria. This will present like this. So, in infants where the blockage is very superficial, it will present as malaria crystallina. So, you have these small crystal like sweat deposits on the skin. The more common one is something that you see in summers, which is called as prickly heat or malaria rubra. So, malaria is when there is obstruction of sweat duct. So, if there is obstruction, the sweat will not be able to come out. That leads to prickly heat or malaria rubra. And if the obstruction is at a very superficial levels, you see small vesicular lesions in an infant, and that is called as malaria crystallina. Okay. Then there is something called as Fox-Fordyce disease that you should be knowing. It is related to apocrine glands and it is a malaria of apocrine glands. Malaria is otherwise of eccrine glands. Fox-Fordyce disease is seen in adolescent females and there is obstruction in opening of apocrine duct. So, you see these small skin colored papules in axilla, groin and nipples, which are the area where my apocrine glands are situated. So, these are Fox-Fordyce disease. Okay. Just quickly telling you the important. Now, this is important. There is a condition called as Hidradenitis suppurativa, which was also known as acne inversa. Now, what happens in Hidradenitis suppurativa? There is inflammation which is involving the apocrine gland. So, this is a disorder of apocrine gland. It is usually seen in patients who are obese, who indulge in a lot of smoking, and these patients. So, in history, you are typically given an obese patient or a smoker. How does it present? It starts with polyporous comedones. So, since you see comedones here, but they are present on the apocrine site. What are my apocrine site? I told you axilla, underarms, groins, inframammary area. So, there you have polyporous comedones and they get infected, leading to formation of pustules, abscesses. So, typically a patient will present with painful lesions, painful pustules and abscesses with polyporous comedones on apocrine sites, and there will be history of smoking or diabetes or obesity. And when these heal, they leave behind such bad scars which are called as bridging scars. Yes, I am live. Can't you see me or hear me? Is there a problem? Okay. So, that leads to bridging scars. So, if any of this image is given, you have to think of hidradenitis suppurativa. Hidradenitis suppurativa is pus-filled lesions, itis is inflammation, hidradenitis is inflammation of the apocrine gland which is leading to this lesion. So, the typical criteria is that in the apocrine sites, you have these deep seated nodules, abscesses, sinuses, bridging scars which are present, and typically these lesions keep recurring. Recurrent lesions in these typical areas, presenting with these lesions, obesity present, smoking present, think of hidradenitis suppurativa. Okay. So, this is a condition which is asked, you are given an image, you are given this history, so you have to identify that. Nobody asks you the treatment. Okay. Now, moving on to disorders of sebaceous glands. So, one was sweat glands, which I told you eccrine and apocrine. The next was sebaceous glands. Now, sebaceous glands are holocrine glands. Holocrine glands are glands which completely destroy themselves to give out their secretions. Now, these sebaceous glands are basically opening into the hair follicle. So, these sebaceous glands are always opening into the hair follicle, and these sebaceous glands are located in seborrheic distribution, which you were asking me, and these seborrheic distribution are scalp, face, upper chest and upper back. Great, thank you. So, these are my seborrheic sites because it's like sebaceous glands are present everywhere, but these are my predominant site where their density is much more. These sebaceous glands, they open into the hair follicle, right? You just need to know this. Now, there are certain types of sebaceous glands which do not into the hair follicle but open directly into the skin. These are called as ectopic sebaceous glands. Ectopic sebaceous glands are glands which are opening directly into the skin, not into the hair follicle. Now, this ectopic sebaceous gland is sometimes given as a question when you are given this image. So, this is an image of Fordyce spots. So, don't get confused with Fox Fordyce disease. Fox Fordyce is apocrine malaria seen in adolescent females. Fordyce spots are ectopic sebaceous glands which are present around the oral mucosa. Oral mucosa. Ectopic sebaceous glands. Ectopic sebaceous glands around oral mucosa are Fordyce spots. They present with asymptomatic, yellowish, very small papules around the lips, can also be there on the buccal mucosa. Okay, so this image is given and you are asked what is this. So, this is Fordyce spots. Fordyce or oral mucosa and yes, ectopic sebaceous glands. Clear? Now, a very important topic in glands is acne vulgaris because it affects my pilosebaceous gland. So, we will talk about it. So, acne vulgaris. Vulgaris is again common. So, I am talking about the common form of acne here. Age, it will affect the adolescent and teenage group usually. And the characteristic feature of acne vulgaris is you get polymorphic lesions. We also talked about polymorphic in chickenpox. So, polymorphic is when multiple morphologies are present. So, here you see comedones, papules, pustules, which I will just show you. The site of acne vulgaris is face, seborrheic areas, back, chest. So, this is opposite of what my hidradenitis was manifesting with, and that is why we called it acne inversa. Now, acne vulgaris is related to 4 pathogenetic mechanisms. One, there is increased sebum production, right? Second, there is altered keratinization of hair follicle. Third, there is inflammation, and fourth, there is microbial overgrowth, right? So, it is not like it has to happen in a particular order, but these are the 4 main changes that are happening in acne. So, sebum production is increasing, keratinization of the hair follicles and the pilosebaceous unit is getting affected, there is inflammation and there is microbial overgrowth. And the microbes which are associated are Propionibacter acnes, P. acnes or Propionibacterium acnes. So, P. acnes or Propionibacterium acnes is the microbe which is overgrowing here. Apart from this, staph epidermis is also overgrowing, right? So, this is asked which pathogenic organism is associated with acne. It is Propionibacterium acnes. Okay. Now, Earlier it was believed that these 4 are the main factors. Now there is lot of role of inflammation, hormones, insulin, which is there in acne, which I am not going to discuss. Now, acne, I told you, acne has special lesions. The special lesion of acne is called as comedone. Comedone is nothing but my blocked pilosebaceous duct. What do I mean by that? I just told you my sebaceous gland opens into the hair follicle. If this pilosebaceous duct is blocked, that leads to comedone. So, comedone is nothing but blocked pilosebaceous duct. This comedone can be either open comedone or closed comedone. What do I mean by open and closed comedone? Open comedone is when the overlying epidermis is not there. So, this blockage which is happening gets oxidized. The keratin in this duct gets oxidized and it appears black. So, this is called as open or black comedone. Whereas this is closed comedone when there is blockage, but there is an overlying skin around it. So, there is no oxidization of keratin. So, it leads to closed or white comedones. So, comedones are special lesions for acne, and this happens because of blocked pilosebaceous duct. Yes, comedone is specific for acne. Okay. Then, as I told you, acne is polymorphic. So, why do I call it polymorphic? Because the patient can present with either comedones, patient can present with papules, there can be pustules, there can be scars, and there can be nodules and cysts. So, all these may be present together or separately in a patient, and that is why acne is called as polymorphic. Acne is something which you all have seen around you, right? So, usually it will start with comedones, but you will see all these lesions. So, now next important thing is, so this is how a patient present, has all the lesions. Then, let me first, okay. Certain variants of acne is something which you should also know. 2-3 variants are important for you, which are asked in the exam. Now, sometimes I told you acne vulgaris was the commonest. Now, sometimes what you see is a patient has lower face acne, patient has associated hirsutism or increased hair growth, patient may have obesity, patient may have dandruff, or a patient may have non-healing acne. In all these situations, when you get this, you have to think of hormonal causes of acne. So, when there is hirsutism, lower face acne, not responding to treatment, then you think of hormonal acne, that probably there are certain hormones which are influencing this, and this hormonal acne is usually associated with hyperandrogenism or increased androgenism. Now, we know that androgen is being secreted from 2 sources, ovaries and adrenals. So, it can be ovary related hyperandrogenism or adrenal related. In ovaries, I will have PCOS, a very important cause. Adrenal, I will have congenital adrenal hyperplasias, adrenal tumors, right. But whenever you are given this question, you think of hormonal acne, and in this case, you have to give hormonal treatment. Okay. So, they give you a question, a patient obese, patient with acne, not responding to treatment, what will you do? Patient with hirsutism, dandruff, hair fall can also be there. So, then again you think of hormonal acne. Clear? Then sometimes acne may be very severe, in which case we call it acne conglobata, which is a very severe form of acne. You see abscesses being formed, nodules being formed, sinuses being formed. So, all of this may be present. Then this is important. Sometimes there are some drugs which can cause acne. These are called as acneiform eruptions. So, if they ask you acneiform eruptions, it means they are talking about drug induced acne. Now, how are they different from normal acne? Drug-induced acne are monomorphic. They are on the trunk and they have no comedones. I told you acne is polymorphic, it is monomorphic. Acne presents mainly on face, this will present mainly on trunk. Acne has comedones, you do not see any comedones here. So these are acneiform eruptions, and common drugs which cause acneiform eruptions are steroids, ATT and anticonvulsants. So they may give you a history that a patient on ATT present with these monomorphic lesions on the trunk. What will you do? So this is acneiform eruptions. You will see whether you need to continue with the medication. If you need to, you just give benzoyl peroxide. Okay. So this is acneiform eruption. Now, this is a question that is asked, that you're given a clinical acne situation and you are asked the treatment that you would do for that. So grading of acne and its treatment. So there are 4 stages of acne. In first stage, you mainly see comedones, and here you treat with topical retinoids, right? In second stage, you see, apart from comedones, you see papules and few pustules. Here you give, along with topical retinoids, you give topical antibiotics. In third stage, apart from this, you see many pustules. So here you will treat with oral antibiotics. In last stage, you see nodules and cysts. If you are seeing nodules and cysts, you will treat with oral isotretinoin, right? So now they give you in the question, a patient presenting with nodulocystic acne, what will be your treatment of choice? It will be oral isotretinoin, right? If it is just comedones, you give topical retinoids. And in all of this, you can add benzoyl peroxide. Okay. Now, mechanism of action of retinoids, very good. So, retinoid is the only class of drug which is acting on all the pathogenetic factors of acne that I discussed. Inflammation, microbial flora, inflammation, blockage of duct and sebaceous hyperplasia. So, that is why retinoids are very, very effective in treating acne. But now you should also know that oral retinoids there are a lot of side effects that you should be knowing about. So the common side effects are, it can cause dryness, it can increase bacterial colonization at times, especially gram-negative infections. It can sometimes cause constipation, can also cause headache. But the most important side effect is, can anybody tell me? Yes, it is 13-cis-retinal analog. What is the most important side effect of isotretinoin? Anybody? Yes. So this is a teratogenic drug. So can I give it in female of childbearing age group? Can I give isotretinoin in female of childbearing age group? Yes or no? Yes, you're right. Cheilitis, I missed that. Quickly. Okay. Anybody, can I give this medicine in childbearing age group? Yes. So please don't confuse, just understand my question. If I am saying, can I give it in childbearing age group? So yes, I can give it in childbearing age group, but I have to ensure that there are 2 negative urine pregnancy tests and I have to counsel about contraception. So please remember this. Lot of times students get confused. I say childbearing age group and they say no, it cannot be given. When does acne happen? Acne does not happen post-menopausal. It happens in teenage and young age, and so this is the childbearing age group. So you can give it and you have to give it. But you have to ensure that there is no pregnancy by checking 2 negative UPTs, and you have to tell the patient to follow contraception, and this should be followed up to 3 months after stopping medication. So the patient can try to conceive 3 months after stopping the drug. Okay, clear? You should not get confused. So you can give it in childbearing age group if you ensure this. So it is teratogenic drug, it causes embryopathies, so should not be given if a patient is planning to conceive, okay, right? So this is important. So isotretinoin is very good drug. It's used in nodulocystic acne, but we have to make sure of this thing. Okay. Now regarding rosacea, you have to just know that rosacea is a vascular hyperreactivity, and this is how it presents to you with. The patient will present with flushing. What is flushing? Flushing is the patient will feel redness which happens on eating hot food, spicy food, stress, some amount of sun exposure. So there can be extensive flushing. Along with it, patient will have some telangiectasias, and there will be no comedones here. Okay. So, increase in cholesterol with isotretinoin is a side effect which used to happen when we used to give high dose of isotretinoin. Okay, so earlier we used to monitor LFT and triglycerides, but now since we are using low dose isotretinoin, we are not doing that. So rosacea is a condition which presents with vascular hyperreactivity. So typically patient will have flushing, telangiectasias, will have no comedones, can have papulopustular lesions. So there are stages of rosacea. So first stage is just erythema and telangiectasias. Then you have papules and pustules, and then you can have this. What is this? Anybody? This is the phimomatous or granulomatous stage of rosacea. What is it called as? It is called as potato nose or rhinophyma. Very good. So rhinophyma or potato nose is a feature of granulomatous rosacea. So rosacea has 3 stages. Now lot of time you get confused between acne and rosacea. Remember, no comedones, flushing and telangiectasias are feature of rosacea, not of acne. So in acne you do not see flushing, do not see telangiectasias, and you see comedones. So sometimes when the patient just has papulopustular rosacea, you may get confused. Then take history of flushing, look for telangiectasias and look for comedones. Yes, aloo nose or potato nose it's called as. So this is rhinophyma, which is the granulomatous or phimomatous stage of rosacea. Treatment of rosacea, just note 2 important drugs which are used. One is ivermectin orally and metronidazole topically. Okay. So, oral ivermectin and topical metronidazole. Okay. Om Puri had this. Yeah, you're right. So, Om Puri had that potato nose. Difference in malar rash and rosacea. So, malar rash typically spares the nasolabial fold, which may not be there with rosacea. In malar rash, the rash is very persistent. In rosacea, on the other hand, the rash comes with flushing. Okay. Then obviously, if you're still confused, you have to do ANA, which will be positive in malar rash. Right. So, history of photosensitivity is present in both, but typical history of flushing is seen with rosacea. Sparing of nasolabial fold is seen with malar rash, and you can do a ANA, which is positive. Okay. Right. So, next we will move on to papillosquamous disorders. Should we take just a 5 minutes break, and then we will complete this topic and wind up for the day. Is that okay with you all? This would be a short break of 5 minutes only because we also have to wrap up the session. So great. So let's take this 5 minutes break. I'll come back and you also come back after 5 minutes. Eat something quickly and do the necessary work that you need to. Hi students, so ready? Should we move on to the next topic? Okay, great. Can you see me on the app? My app is not, so just okay, great. So let's start with this. So this is I think now it started on the app as well. Great. So now we'll talk about the next group of disorders, which is my papillosquamous disorders. Here we will talk about psoriasis and lichen planus, and I think this would be the last topic for today, and then we will resume from tomorrow, right? So psoriasis, we all know, is an important topic. You get a lot of questions from this. It is basically a papillosquamous disorder. What do you mean by papillosquamous disorder? So papillosquamous, papules, so you have papules and plaques here, which are typically scaly, and the scale which I told you is silvery white scales. So psoriasis presents with papules and plaques which have silvery white scales, and this is the main feature of psoriasis. Okay. Now, psoriasis is caused by a lot of problems, lot of conditions. You do not need to know the details, just know that there is inflammation, there are immune factors, there are hereditary factors, and lot of environmental factors which can aggravate psoriasis, right? Now, in psoriasis, you are also asked about the pathology and pathogenesis. So, three things are happening in psoriasis. One is the epidermis is getting thickened. So, there is thickening of epidermis. There is dilatation of blood vessels, and there is inflammation. Okay. Now, once a question was asked that when you see psoriasis, what is the first histopathological change that you see? So, it is important to know that in psoriasis, the changes happen again from bottom to top. So, it is the dermis which is affected first, and then the disease go to the epidermis. So, if I am seeing a histopathological change, I will first see it in the dermis. So, what happens in dermis? There is lot of inflammation which comes in, which leads to dilatation of vessels, which goes and targets my epidermis, and my epidermis becomes thickened, right? So, this is the broad pathogenesis of psoriasis. It is basically a Th1 response. So, when I say Th1 response, I mean that there is increased in interferon gamma, TNF alpha, then also there is Th17 and 22 response. So, just remember it is a Th1 kind of a response. Now, what happens in the histopathology of psoriasis is also very, very important. So, first I will enumerate the features and then I will show you the images. So, depending on the layer, I will talk it layer wise. So, in stratum corneum, the changes that you see are, there is, what did I teach you? Parakeratosis here. Do you remember what was parakeratosis? So, parakeratosis, hyperkeratosis, and yes, so nuclei are retained. Now, remember I told you about epidermal turnover time. So, psoriasis is the condition in which the epidermal turnover time is reduced to 4 days. So, just imagine the skin is forming at such a rapid rate, it is just being formed. It cannot slough off so easily, and that is why you have the thickened epidermis and you have scales in psoriasis. Okay. Now, because of this rapid formation, the keratinization is altered. So, you have not absent nuclei, presence of nuclei, okay, do not get confused. So, here you have parakeratosis, which is retention of nuclei, nuclei are retained in the stratum corneum. There is increased thickness of stratum corneum, and there are inflammatory cells called as moon rose microabscesses that you see here. So here what happens, the inflammation which is coming from dermis travels up to the epidermis, and in stratum corneum it forms a collection of neutrophils which is called as Monro's microabscesses. So Monro's microabscesses is nothing but collection of neutrophils. Clear? Now what happens in my stratum granulosum? Anybody? What happens in stratum granulosum? I've told you this already. So I no absent nuclei, presence of nuclei. So nuclei is present here, okay? What happens to stratum granulosum? Quickly. So stratum granulosum is absent. There is no stratum granulosum, which is called as agranulosis or no stratum granulosum, right? Then what happens in stratum spinosum? Stratum spinosum is also thickened. So you see acanthosis or thickening of stratum spinosum, and here also there is a collection of neutrophils which is called as Kogo's spongiform pustules. So there also you see collection of neutrophils, and this is called as Kogo's spongiform pustules. So remember, Monro's microabscesses is in stratum corneum. Kogo's spongiform pustules has multiple S, so it is in stratum spinosum. Both of them are collection of neutrophils. Okay. Then what happens in stratum basale? Anybody? Now here you have to understand one concept. When I talked about epidermis and dermis, so I told you that dermis has papillary dermis and reticular dermis. Now this invagination of epidermis into the dermis is called as rete ridges. So here my rete ridges are elongated, and I get a camel foot appearance. What do I mean by that? Normally my epidermis is like this. What happens in psoriasis? The rete ridges, they get elongated like this. So it looks like a camel foot. So this is called as camel foot appearance, right? What happens in my dermis now? So in dermis I have, so since this is getting invaginated, the papilla, the papillary dermis is getting thickened. So there is suprapapillary thinning that happens. See, the epidermis here is thinned above the papilla. So when there is invagination just above the papilla, my epidermis is thinned. So this is called as suprapapillary thinning. And I see vasodilatation here and inflammation, right? So these are the changes that I see in dermis. I'll come to auspicious sign, right? Got it? So important features out of this that you should know: parakeratosis, agranulosis, Monro's, Kogo's spongiform pustule, camel foot appearance, and suprapapillary thinning. Now let's look at it. So this is what is happening in psoriasis. Can you see this? There is parakeratosis, retention of nuclei, camel foot appearance. So they give you histopathology of psoriasis and you have to identify. So see, it is camel foot appearance. You see parakeratosis. Easily you can make out on histopath image. Then there is suprapapillary thinning. There is lot of inflammatory cells that you can see. Okay. What is tension nuclei? Tension is retention. Retention means the nuclei are retained. Retention nuclei. And this is also helps you diagnose. So this is my normal skin. This is my elongated rete ridges. Right? So this is the histopathology. Then how does psoriasis present to me with? The clinical features are you see erythematous, indurated plaque. So what do you mean by indurated? Thickened plaque. So there is thickening, there is redness, and on top of it I see silvery white scales. Remember, Psoriasis is asymptomatic. You have no itching, nothing. So, totally asymptomatic. So, erythematous indurated plaque with silvery white scales are the features. So, if in the question they are mentioning silvery white scales, think of psoriasis only, right? Now, psoriasis also shows winter exacerbation, that can also be given. And there can be family history also which can be given to you in the question. Now, this is a sign that you should be knowing in psoriasis, which is called as Auspitz sign. Now, what happens if there is a scaly plaque of psoriasis and you take the blunt end of the scalpel and start to scrape off the lesion? If you scrape off the lesion, what happens? First, there is increased scaling that you see. In the second stage, you see a thin, shiny membrane. And if you keep doing what you are doing, you see bleeding points. So, this is called as Auspitz sign. All these three steps are called as Auspitz sign. And this first step is called as Grattage test. So, Grattage test and Auspitz sign are something that you see in psoriasis. And what is it? There is increased scaling, then you see a shiny membrane, and then you see pinpoint bleeding points. You are right, pinpoint bleeding points are seen. So, psoriasis, what did we discuss? Erythematous indurated thickened plaque with silvery white scale with positive Auspitz sign, asymptomatic. Clear? Okay. Then, what is this? Anybody now? Tell me. I have talked about it multiple times, but I had not shown you the image. Quickly, I'll wait for your responses. Very good. So, this is Koebner's phenomena which I have been talking about. So, Koebner's phenomena is when the patient scratches, see along these scratch lines, you are seeing lesions which are resembling psoriasis. You see erythematous plaques with silvery scales, but they are along the lines of excoriation. So, psoriasis shows positive Koebner's phenomena. So, this is seen in, this is called as true Koebner's, and this is seen in psoriasis, lichen planus and vitiligo. Okay. So, LP, VIP, LP, vitiligo and psoriasis are the three conditions where you see true Koebner's phenomena. And pseudo Koebner's, so this is what I have written. Koebner's phenomena is also called as isomorphic response because you have similar morphology lesions. True Koebner's we discussed, and pseudo, this you can forget about. Pseudo Koebner's we discussed is seen in molluscum contagiosum and warts. True Koebner's is in lichen planus, psoriasis and vitiligo. Not scabies, not seen in scabies, okay? Don't get scabies here. Warts and molluscum. Clear? So, Koebner's is another important question that you should be knowing. So, in psoriasis, we studied about Koebner's phenomena and Auspitz sign, right? Now, sometimes psoriasis can happen in flexures. This is just to show you different sites which can be affected. Then, you should also know about nail psoriasis. Can anybody tell me what are the features of nail psoriasis? What is the most common finding in nail psoriasis? So, in pseudo Koebner's, it is same morphology, but it is not because of immunological process. Here there is, so what is happening in pseudo Koebner's is कि you had a wart and you scratched and the wart got transmitted. Whilst in psoriasis, LP and vitiligo, that's not happening. Very good. So, most common finding in nail psoriasis is you see pits. But unlike alopecia areata, where I told you it is fine, stippled, geographic pain, here the pits are deep, random and irregular. And they are very large. So, remembered by the help of a mnemonic drill. Deep, random, irregular, large pits are a feature of psoriasis, and these are the most common finding. But what is the most specific finding in nail psoriasis? The most specific finding in nail psoriasis is quickly. Anybody? So what do you see? You are seeing something here. You are seeing something here. Yes, so this is oil drop sign or salmon patch. So it looks like an oil is there on the nail, and this is called as oil drop sign or salmon patch, which is the most specific finding. So most common finding is pits and most specific finding is oil drop sign or salmon patch. Right? Clear? So these are the two nail findings that you should be knowing about. Now, sometimes you get confused with onychomycosis. Somebody asked me also the difference between onychomycosis and psoriatic nail. So remember, psoriatic nail affects hands more, whereas onychomycosis affects toe more. Here you will not see any pits. Here pits will definitely be seen. If you would do a KOH here, it will be positive. If you do KOH here, here will be negative. You see salmon patch here, which will not be seen here. So these are the differences between onychomycotic and psoriatic nail. Clear? Okay. Now, also you should know that psoriasis can also affect joints, leading to psoriatic arthritis. Don't get into more details. Remember, the most common joint involved is distal interphalangeal joint. Okay. So distal interphalangeal joint is the most common joint which is involved, and the classification of psoriatic arthritis was given by Moles and Wright. So we use Moles and Wright classification for psoriatic arthritis. Okay. So this is the Moles and Wright classification. Nobody is going to ask you that. Now, there are certain changes in the joints which can be asked. So if you look at the hands of a patient, what are these changes? Can anybody tell me what is being seen in the clinical image and what is seen in the x-rays? So here if you see, look at these joints. These are called as, okay, very good. But what is this, the clinical image that I am pointing to first? Anybody? Okay, so this is sausage digits. So sausage digits are also seen with psoriatic arthritis. Then you all were right. This is pencil in cup deformity. So you have a bone and you see this. So see this? So this is a bone and this is going into this. So this is pencil in cup deformity. And here you see that there is increased bone formation, which is called as ivory phalanx. So ivory phalanx, sausage digits, pencil in cup deformity, these are all associated with psoriatic arthritis. Yes, and it can also lead to arthritis mutilans. Clear? Then, this is another type of psoriasis which is very commonly asked, guttate psoriasis. So, psoriasis which we discussed, you have to know that psoriasis can affect various sites, like I discussed nail, joints. Then there are different morphologies also of psoriasis. Not all psoriasis will present with erythematous silvery white scales. So, this is morphological variant of psoriasis. So, what happens here is that typically it will happen in a child and there would be a history of preceding streptococcal infection or tonsillitis. Okay, so there will be a child who will be affected, preceding streptococcal or tonsillitis will be there. And if you look at the lesions closely, the lesions are very different. They are small, they are erythematous, they are not so scaly. So, they are very mildly scaly lesions on trunk. And if we see the pattern, it is looking like raindrops have fallen on trunk. So, raindrop appearance. So, this is guttate psoriasis. Guttate means small. So, you see multiple small erythematous, mildly scaly lesions on trunk which looks like raindrop appearance. You see it in children, and there is history of preceding streptococcal infection. Now, this is very, very important because this is one type of psoriasis which is treated differently. How do you treat it? Yes, so this is treated with antibiotics. So, you give erythromycin. Now, I am stressing on this because guttate psoriasis is very, very commonly asked. Okay, so any history of so this is believed that this psoriasis is triggered by streptococcal infection, and so you just treat with erythromycin or macrolide antibodies, and in very recurrent cases you can even go for tonsillectomy. So if they mention child preceding streptococcal infection, trunk lesions, and they are showing you like this, they can ask you what is the treatment that you would give or what is the diagnosis. So this is guttate psoriasis and you treat with antibiotics. Clear? Tonsillectomy is done if a patient has recurrent lesions like this. Okay. Then what is this? Sometimes psoriasis may involve your whole body when you call it as erythroderma. Erythroderma is when more than 90% of body surface area is involved. Just know this. More importantly, you should know about this kind of psoriasis. Now, I told you that psoriasis has pustules, but they were on histopathology. Now, when you start seeing pustules clinically, this is called as acute generalized pustular psoriasis, also called as von Jumberg psoriasis. Now, here you are seeing pustules on an erythematous base. Now, in this case, you would also get history of fever or systemic features being present. And this type usually happens on withdrawal of coal tar or steroids. So, all of this may be given in the history. A patient of known case of psoriasis or a de novo had taken some coal tar application, steroid application, and once he withdrew, he developed multiple pustules on the trunk. Yes, so this is an unstable form of psoriasis. Otherwise, psoriasis is very stable. People live with it for years. Another important point, psoriasis involves mainly the extensors. I forgot to tell you that. So, psoriasis is mainly involving my extensors. Now, here on trunk you are seeing these pus-filled lesions, and if you look very, very closely, they are forming lakes of pus. So, lakes of pus is a feature of psoriasis, and this is not infection, this is just neutrophils. So, these are called as sterile pustules because this is not infected pustules, this is just severe collection, severe inflammation leading to collection of pustules. So, if any of this history is given, you think of acute generalized pustular psoriasis. Here, my treatment of choice is acitretin, which is a vitamin A analog. Okay, so for guttate psoriasis, I gave antibiotics. For pustular psoriasis, I will give acitretin. Yes, so oral retinoids are broadly of two types that we use in skin. One is acitretin and one is isotretinoin. So, do not get confused. Acitretin is used in psoriasis and isotretinoin is used in acne. So, way to remember is A you do not use for A, and it has areas I is not for A. So, acitretin is for psoriasis and isotretinoin is for acne, and both are types of oral retinoids. Right? Now, there is another form of psoriasis that you should know, which is a pustular psoriasis that you see in pregnancy. So, if pustular psoriasis is happening in pregnancy, it is called as impetigo herpetiformis. Neither is it impetigo, neither it is herpetiformis. I don't know why they give these names. So this is simply pustular psoriasis in pregnancy. Now why am I telling you this? Because in this the important thing is that here the treatment is giving steroids or cyclosporin. Now remember, you never treat psoriasis with steroids. You don't give steroids for psoriasis because I just told you it can lead to pustular psoriasis. But in pregnant patient, other drugs are not safe, so you have to give steroids or cyclosporin. So if I have a pregnant patient, this is the only indication of giving steroids in psoriasis, oral steroid. So only indication of giving oral steroid in pregnancy in psoriasis is this. Clear? Now, this was about specific types. Now, talking in general about treatment of psoriasis. So, I told you for special cases, pustular psoriasis, you give acitretin. For impetigo herpetiformis, you give steroids. For guttate psoriasis, you give antibiotics. But what about other types of psoriasis? So, in general, psoriasis is treated with 3 modes of treatment: topical, oral medications, or phototherapy. In topicals, we can use corticosteroids. So, topically, you can use corticosteroids, you can use coal tar, anthranilin, and all of this can be used. But when face and flexures are affected, you use calcineurin inhibitors, which is called as tacrolimus. Okay. Now, the more important thing is phototherapy. Phototherapy is used for psoriasis. What is phototherapy? There are chambers where you give either UVA. So, 2 forms of phototherapy are used. NB UVB, which is more commonly used, we use narrowband UVB therapy, or UVA. So, both these therapies are used. NB UVB, you should know the wavelength is 311 to 13 nanometer. So, this is used, or PUVA, just know the names. So, you use narrowband UVB therapy, or you use PUVA, where you combine psoralen and UVA. So, phototherapy is an important mode of treatment for psoriasis, right? Now, I'll leave this. What are the systemic treatment? What is my treatment of choice for psoriasis if I have to give systemic treatment? Anybody? Quickly, and the treatment of choice for psoriasis. Okay. So, yes, it will be methotrexate. So, I will come back to tofacitinib, but the treatment of choice is methotrexate. So, if a patient has joint involvement, if a patient has PASI, which is body surface area, which is more than 10%, or any other type of psoriasis, you give methotrexate, except for what I have already told you. So, treatment of choice is methotrexate. Other drugs I have already told you, we can use acitretin, we can use cyclosporin. Cyclosporin is the crisis drug. If the patient is presenting with severe psoriasis, so I use it as crisis drug. Okay. So, but methotrexate is very important. Now, tofacitinib is a newer agent which is being increasingly used for psoriasis. So, just know the name tofacitinib. This is an oral JAK kinase inhibitor which is used in psoriasis. Okay. Now, there are also some newer classes of drugs which are used, which are called as biologicals. Just know their name. So, they are given through injections, they are costly, but they are very, very effective, right. So, in injections, we can use different kind of biologicals. Now, what we are using commonly is secukinumab. Nowadays, there are 2 new agents, ixekizumab and guselkumab. Sometimes they ask you the newer things. So, that is why I am just telling you this. So, ixekizumab and secukinumab are most commonly used. They are anti-IL-17. and guselkumab, which is used as anti-IL-23. These are two important inflammatory cells which target, are important in psoriasis. So remember, secu is 17, ICSI is also 17, and guselkumab is IL-23. Okay. Okay. Moving on to next papilloscomus disorder, in which you do not have to go into details, just remember these three things. Pitriasis rubra pilaris is a papilloscomus disorder which presents with three things: follicular papules, islands of sparing. So you have this follicular papules, erythematous papules. It spreads and leave this islands of sparing, and you have something called as PRP sandal, where you see hyperkeratosis of palms and soles. So if you are given an image where you see islands of sparing, you see follicular erythema with PRP sandal, think of Pitriasis rubra pilaris. And what is this? Can anybody tell me? You also see nutmeg crater papules here. PRP sandal, nutmeg crater papules, and islands of sparing are all features of PRP. You don't need to go into the details of PRP. Okay. Now this is something that you need to know, and I am going to discuss this. Now lichen planus is again a papilloscomus disorder, but it is different from psoriasis. Now how is it different? It is an autoimmune T cell mediated disorder, just like alopecia areata, right? Now how does it present to us with? Now lichen planus is itchy. Psoriasis was not itchy, this is itchy. Here it presents mostly on flexures, whereas psoriasis used to present on extensors. Can anybody tell me the morphology of lichen planus? What is characteristic of morphology of lichen planus? Quickly. Very good. What is the sixth one? I know of 5 P's. So there are 5 P's which are associated with lichen planus. Yes, so 5 P's. I'll tell you what are these 5 P's. Purple, pruritic, plain topped, papules. What did I miss? Plain top, polygonal. Thank you so much. That happens. So there are 5 P's of lichen planus which helps you clinch a diagnosis. So if you see purple or violaceous color, itchy, plain topped, polygonal papules, think of lichen planus. So look at these lesions on the flexures. So this is the wrist cuff flexure. You are seeing this plain topped or flat topped polygonal papules, which is purplish, giving you a purplish or violaceous hue and is itchy. So this is lichen planus. So lichen planus has P, and so it has 5 P's, and one of them is in planus, plain topped, and lichen is always violaceous. So violaceous plain topped papules which are pruritic, which are polygonal, and which is present on flexures is something that you see with lichen planus. Okay, so these are the 5 P's. Now remember, lichen planus is a condition which affects skin, nails, hair and mucosa. In psoriasis, we did not talk about hair and mucosa because psoriasis does not affect those things, but lichen planus affect all of this. So on skin you see 5 P's. What is this? Koebner's phenomena. I told you lichen planus shows Koebner's phenomena. So along the line you are seeing these papular lesions. Then there is something called as Wickham's striae that you see in lichen planus, which is nothing but these whitish things that you see if you use a dermoscope. Wickhamstra is in whitish streaks that you see if you put mineral oil. You do not see it like that, otherwise you do not see any scaling, but if you put mineral drop and see it with microscope, you see these whitish streaks. Why? Because lichen planus is one condition which is associated with hypergranulosis, and this is what is manifesting. Okay. Then in oral mucosa, what are the findings? You see oral mucosa, you see whitish, lacy, reticular pattern. So, if you have a whitish, lacy, reticular pattern with difficulty in eating hot spicy food. So, the patient is telling you that there is difficulty in eating hot and spicy food, and you see this whitish, lacy, reticular pattern in the oral mucosa, again think of lichen planus, right? Then what happens in nails? Anybody? What are the nail changes that you see in lichen planus? Very good, yes. So, in nails, the most common finding is seeing this trachonicia or dystrophy of nails, as I told you. But the most specific finding is seeing pterygium, which I showed you in nail disorder. So, pterygium and trachonicia, you're right, trachonicia is also called as sand blasted nails. जैसे आपने sand से उसको blast कर दिया हो. So, you see these lines, you see very rough skin. So, nail are also affected in lichen planus, and pterygium looks like this. There is a wing shaped fold of proximal nail fold on the nail plate. So, pterygium and trachonicia. Then in hair, I already told you that lichen planus leads to cicatricial alopecia. So, skin, hair, nails and mucosa all are affected in lichen planus, right? In histopathology, there are few things that you should know. Hyperkeratosis we all know, but this is the most important finding. In psoriasis, there was agranulosis. Here you see hypergranulosis. The granular layer is increased and it is typically wedge-shaped hypergranulosis. Also, this was once a question, histopathology of lichen planus has been asked. So, there are colloid or civet bodies which are nothing but, now what happens in lichen planus is the immune cells which are coming are targeting my basal cells. So, the basal cells get degenerated and lot of keratinocytes, they become apoptotic, which are called as colloid bodies, right? So, colloid bodies and wedge-shaped hypergranulosis with hyperkeratosis are features of lichen planus. Clear? Right, everyone? Treatment, you give topical corticosteroids, calcineurin, and in here you treat with oral corticosteroids. You can give other agents also, you can use azathioprine, but here you can use steroids, and you also give phototherapy to the patient, right? So, I finished lichen planus here. If you have energy, we can also finish tuberculosis and then move on to the session for tomorrow. Tuberculosis is a short topic, so if you give me 5 minutes, we can do I can add up that presentation here and we can do tuberculosis. So, what do you say? You want to wind up or can we do cutaneous tuberculosis? Psoriasis, yes, you use calcineurin inhibitors, but face and flexures only. Okay. So, most of you are up for it. So, just give me 5 minutes. I will upload that PPT and then we can just finish with tuberculosis and then I'll definitely wind up. Okay, that will save your also because there will be a lot of topics for tomorrow and we still have some time today. Okay. पॉज कर देना नहीं एक टॉपिक और है इसमें हो गया? Okay. So welcome back. So we will, I assure you this is the last topic. I will not bribe you with another topic. So cutaneous tuberculosis, it's a short topic and we'll quickly finish it. So we all know you've read a lot about tuberculosis in various subjects, and I will be just talking about skin manifestation of tuberculosis. So you know it is caused by Mycobacterium tuberculosis. Now when we talk about cutaneous tuberculosis, let's not bore you with this. You have to remember two important points, that the kind of tuberculosis will depend on two main factors: whether the patient is immune or non-immune. So what do I mean by that? Immune is if he or she has been exposed to MTB bacteria in the past, or non-immune when not exposed, right? Then it will depend on what is the route of infection. So route of infection can be, it can be either inoculation, from outside the bacteria is coming and infiltrating the skin. So this I am only talking about skin, okay? Or it can be hematogenous spread. There is a focus of TB somewhere, and from there through blood TB comes and sits on my skin. It can be contiguous spread. What do I mean by contiguous spread? That if suppose there is a lymph node which is affected by TB, the lymph node forms an abscess and affects the overlying skin. So that can happen. Then there can be orificial TB, where suppose there is a sputum which is coming out, or excreta which is coming out which has MTB, it can also affect the skin. So this route of infection can be various, and accordingly different types of cutaneous TB may be there. And also it will depend whether the patient is immune or non-immune to MTB, right? Got it? So this table is basically about that. Now from this table I am just telling you that there are so many types of cutaneous TB, but the important ones which you need to know for sure are lupus vulgaris and scrophulodema. These are the most important ones. Then TBVC and TB chancre are partly important, and even tuberculids are very important. So these red ones are very, very important for you. Yellow ones you may know, right? So quickly now I'll walk you through different forms of cutaneous TB and only the important points that you need to know. Now TB chancre happens just like Gons focus. So whenever a person is inoculated with TB bacilli, what happens? The first focus that forms in lungs is called as Gons focus. So similarly, TB chancre is the primary inoculation in skin. So it's like a Gons focus in skin. So this is happening in patient who has not been exposed, so it's non-immune, and this is the primary form of TB. So this is called as primary inoculation TB also, or TB chancre. Clear? Yes. Important thing about TB chancre is, remember, okay, sorry, all forms of cutaneous TB are painless. Again, so that is why it gets missed, na? TB you know. So here the patient will present with an ulcer which had undermined edges. Now in skin, when I talk about ulcer with undermined edge, think of three important DDs: chancre, which is my TB chancre, chancroid, which I will study in STD, and pyoderma gangrenosum. Okay, now we will forget this. So it is a primary inoculation. TB patient is non-immune and inoculation se TB bacilli skin mein aa gaya. What will it form? It will form ulcer with undermined edges. This is TB chancre. That's it that you know to know about it. Next is TBVC, or tuberculosis verrucosa cutis. Now, if you know this name, it is very easy. TB of skin, but verrucous. So here you have a verrucous plaque. So if they are pointing towards TB and giving you a verrucous plaque, think of TBVC. Now TBVC is also due to inoculation, kahin bahar se. But this is post primary. Patient is already exposed and uske baad aaya. So it is high immune system TB. right? So, but remember, just remember the name tuberculosis verrucosa cutis. It is post-primary inoculation TB. That patient was already immune and then inoculation happened. This is also called as anatomist ward or prosecutor ward, because when anatomists, they deal with pathology samples, then the TBVC can get inoculated and they are already immune, so they develop verrucous plaques. It can present in healthcare wormers, in farmers, in children who squat in open, तो उनके buttocks पे हो जाता है. So it typically presents with an indurated verrucous plaque on extremities. Inoculation है, so extremities पे होगा ना, क्योंकि inoculate body में कहाँ होगा? Inoculate तो आप it will only happen on the extremities. Clear? Are you with me? Yes. So anatomist what or prosecutor what is TBVC. Now we will come to one of the most important form of TB that you know. As I told you, vulgaris means common. So lupus vulgaris is the most common form of TB in adults in India. So in adults it is lupus vulgaris. It is also called as plaque type TB, and this is something that you was once asked, that on lupus vulgaris you can develop carcinomas like SCC or BCC. But the more important thing is, how does lupus vulgaris presents? So lupus vulgaris presents with erythematous annular plaque with typically central scarring and peripheral expansion. So when you are given an image of lupus vulgaris, you see this plaque which is showing scarring in the center but is also advancing peripherally. So it is advancing peripherally, and wherever it is getting healed, it is showing scarring. So if you see scarring, if you see peripheral expansion, think of lupus vulgaris. It can also present on face, buttocks, anywhere. Then what is this test that I am doing? So sorry, what is verrucous? Verrucous is one which has that hyperkeratotic verrucous surface. I talked about verruca plana. So verrucous is when you have that hyperkeratotic rough surface, right? Okay. Okay. No, there is no scaling here. There is no scaling here. But what do I see in diascopy here? What do I see on diascopy? Anybody? You had already mentioned once. Yeah, so what do you see on diascopy? So the test which is done is called as diascopy, and on diascopy you see apple jelly nodules. So two important features which help in diagnosing of lupus vulgaris is central scarring, peripheral expansion. It is a granulomatous plaque, no scaling, and on diascopy you see apple jelly nodules, right? Got it? Good. Coming to the next form which is important for you, lupus vulgaris was most common in adults. Scrofulloderma is most common form of TB that you see in children. Okay. Now this is a form of TB where there is an underlying focus. So underlying focus would mean there can be a lymph node, there can be a bone or something which has TB and it manifests on skin. So suppose there is a lymph node, you form a lymph node abscess, this breaks into the skin and in skin you get scrofulloderma. Most commonly the underlying focus is lymph node, and that too cervical lymph node. So you are usually given this image where there is a cervical lymphadenopathy that you see, and on the lymph node above that you see that the skin is breaking up. This is scrofulloderma. Okay. So scrofulloderma, there is a contiguous focus, you see an underlying focus, and on that affects the skin. This is the most common form of TB that you see in children, and cervical lymph nodes are the most commonly underlying focus. Clear? Any confusion, anybody? Right? So this is how scrofulloderma. So if you're looking at it, all kind of TBs are looking different. Chancre was an ulcer with undermined edge. TBVC was a verrucous plaque. Lupus vulgaris was an erythematous plaque, central scarring. And scrofulloderma is there is an underlying focus and you see abscess or you see discharge or you see sinuses here. Okay, clear? Yes, there can be discharge here, right? Now, the last form of TB that you need to know are called as tuberculosis. Now, here understand IDS are always hypersensitivity reaction. So, tuberculosis are hypersensitivity reaction to TB bacilli. If you understand tuberculosis, it will be very, very easy to understand. So, now what happens in tuberculosis? Suppose there is a focus of TB somewhere in the body. From that focus, some bacillary antigens are released or MTB are released in the blood. Now, so there is a primary focus elsewhere. There is a focus from which the antigens or something is released, and my body mounts a type 4 hypersensitivity reaction against those antigens, right? And this leads to development of lesions on skin. Okay. So, one criteria becomes that there is a primary focus elsewhere. Now, since the body is mounting a hypersensitivity reaction, that also means that body has good CMI, then only it can mount a type 4 hypersensitivity reaction. And if my body has good CMI, what will happen? My MON2s will be positive. MON2s is only positive if you have good immune response, right? Now, the lesions on the skin are hypersensitivity reaction to tuberculosis. So, if I do a histopathology, I will see a tuberculoid histopathology. But if I do a culture, it will be negative. Why will it be negative? Because these are lesions on the skin which are hypersensitivity. Here, there is no actual TB bacilli sitting. But if you give ATT to the patient will respond, because ATT will cure the primary focus, and so hypersensitivity reaction will also get cured. So, this criteria is asked, tuberculosis are asked. So, tuberculosis are hypersensitivity reaction, there is primary focus elsewhere, you have a positive MON2s, tuberculoid histology, culture is negative and respond to ATT. Now, normally what they give you is negative MON2s. So, MON2s will be positive here. Okay. Tuberculosis are two types, broadly just you should know. One is lichen scrofulosaurum, there are more types, but you only need to know two types. So, lichen scrofulosaurum is something that you see in children. Here on trunk, you have these grouped perifollicular, shiny looking micropapular lesions like this, right? They do not scar, and on histopathology you can leave it. You don't. So, lichen scrofulosaurum, and the next type is papillonecrotic tuberculosis. It is just the reverse of lichen scrofulosaurum. You see it in adults. Here you have necrotic papules. It was present on trunk. This is present in extremities. And these scar. So, papillonecrotic. So, papules which are necrotic, it is seen in adults. Seen on extremities, necrotic papules with scar. Lichen scrofulosaurum seen in children on trunk, do not scar, they are grouped perifollicular lesions. So, these are two tuberculosis that you should be knowing about, right? How do you treat? You give ATT, which you all know. I do not need to teach you this. Right? Now, a question which is asked, has been asked recently in tuberculosis was that what are the tests that you would do? So, when you have a patient of cutaneous TB, the test that you do is you do a histopathology. First of all, histopathological examination is done, and that is the most important test. But in the question which came in the exam, they did not give you histopathology. So, remember, you can also do PCR, you can do nucleic acid amplification test. All of this can be done, and there are certain ancillary tests. Ancillary tests are tests which will not help me diagnose cutaneous TB, but will tell me if there is a TB focus underlying, like MON2s, chest X-ray, then IGRA, right. So, these are ancillary tests. They cannot say that you have cutaneous TB, but they can tell you that there is an underlying focus of TB, right. So thank you so much for bearing up with me, and we completed tuberculosis. Rest of the topics we will talk about tomorrow. So we will start with leprosy and STIs and then cover the other topics. So now, any questions for today's session before I wind up this session? I hope you guys were with me. I know it is a bit toxic studying the same subject for so long, but thank you so much. You've been really patient listeners and you were quite active, which helped me stay active. And I will wait for any questions if you have for another minute before I wind up. So sleep well. I have already told you what are the topics that I'm going to cover tomorrow. I will again show you so that you can read up a little bit. So cutaneous TB we already did. So if you read up and come, it becomes very easier for you to understand and for me to take care of the topics. Because otherwise, I know if you have not read at all, it might seem a little heavy. But don't worry, this may be your first revision. At least you know what to read. At least you know what to expect in exams. And then you can revise. Okay? Leprosy is a big topic. I don't want to do it right now because I really want you to understand. Okay? So we'll wind up today and we'll finish whatever is left tomorrow. That's okay. Yes, so tomorrow's class would be on app. So I encourage you guys that kindly take up the plan. Today's session was free, but tomorrow we'll have it on the app. Okay, so if there are any inputs for this session, anything you want to share, I'm more than willing to hear. So we will again start around 3 o'clock tomorrow. And day after tomorrow would be a test and discussion which will happen in the morning, and we will do the discussion for the test between 2 to 4 on Wednesday. Tomorrow's class we will start at 3. No, it would not be on YouTube, it would be on the app only. That is what I know as of now. So lichen nitidus, somebody asked me, lichen nitidus presents with shiny papules. It can present on arms or it can present on glans penis. It is a variant, you can say, of lichenoid disorders, lichen planus, and you should just know how it presents. So I think I've put this question in test so we can discuss it there. Okay, great. So I'll do a quick revision after every subtopic. I tried to do that orally today, and we'll do it tomorrow also. Great. So to join the Telegram channel, so in the description of today's session, there is a link which you can join, and you can join the Telegram channel for Resolve 2026, where all the educators would be there and your queries would be easily solved. No, this is not less than rapid revision. So rapid revision for NEET PG is slightly different. So I have, this session was mainly for FMGE. So the rapid revision videos that we have on our platform is for both NEET PG and FMGE. So probably you found it a little different because I've excluded from this live class what is not required for FMGE. Okay, so a Bruillet's ulcer is an atypical mycobacterial infection which presents with ulcer. Again, not an FMG topic, so I was not discussing here. You will get the PDF after the session, and we had shared the PDF before also, which was not annotated. This would be with all the notes, and it would be shared within 24 hours, as I know. Okay, so good night to everyone. Take care, sleep well, and see you tomorrow.